Are you ready to start? Okay. Hello. Good evening from the UK, and good morning from Sydney, Australia. We are really excited to join Professor Richard Harvey. Today is our third day of GRN live endoscopic sinus surgery event, the GR-ESS 2025. This is our 11th live surgical event, and we're really privileged to be joined by Professor Richard Harvey. He's operating from Sydney, Australia, and that is the 7:30 a.m. in Australia. And he's got lined up excellent, very useful cases for learning. And I have with me my colleague Louise Melia. So Louise have been on the panel for last 2 days. She was my co-host. So welcome, Louise.
Thank you, Ash. I'm looking forward to another great day. We've seen lots of excellent surgeries so far.
Yeah, we're absolutely fantastic 2 days. Really thoroughly enjoyed it. Range of cases, variety of cases, and we have some more coming today. So Professor Richard Harvey joining from Australia, and then once we finish that, in the morning here in the UK at 7:30 a.m., we'll be joined by Prof. Paolo Battaglia and Mario Turi-Zanoni from Como Hospital, Italy. They have a wonderful case of orbital tumor. So before further ado, I would move over to join Professor Harvey. Hello, good morning.
Good morning. Good morning, everyone.
Good morning. Yeah,
Ashok and Louise.
Richard, thank you for joining us, and we're really looking forward to this great day.
Well, thanks for hosting another one of these, Ashok. You know, a lot of commitment I know goes in on your end for making these happen. So thank you very much, and Louise for contributing. And I've got 3 cases today. The first one is a really good one in the sense that it's a hold on, I'll just get you to help me with the head drape. Thanks, Jackie. The first one's a young boy who's 16. And I've left, hopefully you can see the CT scan up on the screen. Can you see that?
Yes, we can. Yeah.
Yeah, and he's a young boy who was sent to me.
Yes.
He's 16, he's highly allergic, so he's atopic. He's certainly had long-standing history of allergy and everything else going on. It even had discussions with doctors in the past about going on immunotherapy, but really hasn't done much for his allergy. And then over the last 12 months after a viral event, he's had terrible right-sided congestion. And he was sent along to me, you know, really with a lot of polypoid tissue in his nose. And I think there was genuine concern that he might have had some sort of benign neoplastic process. But when I saw him, it was clearly an inflammatory one. It's unilateral. And this view right now on the CT scan really shows you what's going on, because you can see the subtle hyperdensity in that superior part of the ethmoid cavity. Okay, does that come up on your image? I mean, it's a subtle contrasting.
Richard, it does. Yes, we can see that, though it's actually quite clear on the image. It's excellent to see.
That's not a partition within the partitions. That'll be fungal elements. And when he came to my clinic, he's highly dust mite and mold sensitized on epicutaneous testing. He had a lot of secretions in his nose, and when we swabbed them, it came back as Staph aureus, and that's really common. So staph really commonly co-infects people with allergic fungal rhinosinusitis. And if anyone hasn't or wants to know about fungal elements and how they interact in the sinuses, I think it's chapter 6 in EPOS 2020 is a great chapter summarizing, you know, the sort of findings of AFRS versus classic sort of, you know, adult onset eosinophilic sinus disease. And the reason I say that is because I was the author for that chapter, and there's a lot of things I actually did in reviewing it, because, you know, one of the debates, there are some parts of the world that just don't see AFRS. I've worked in the southern part of the US. I've been to the Middle East many times, and in Australia, and you absolutely see it. Can I have a Blakesley forceps? You absolutely see AFRS as a completely distinct entity. And really, it just is one of the many type 2 or eosinophilic disorders that are in the nose. But it is a disorder that forms tissue remodeling because of this severe allergic response. And Mel, can we get these, the camera set up here? And therefore, people get this trapped, problem in the sinus cavity where everything becomes very, very inflamed. We'll just give us a sec here. We've just got a camera issue here in a second. Oh, here we go. Perfect. We got it now, up and running. So let's go to the endoscope view then. So my plan for him, if you said to me, what did I do beforehand? He was really inflamed beforehand. So I started some oral prednisone last week, 25 milligrams when I saw him, and I started some anti-staph treatment. And it's really made an enormous difference to his nose. Can you see the endoscopic view now? Steen, have we switched over?
Yes.
Yeah. So
yes, it's a great view. And Richard, the anti-staph treatment, do you do you have any empirical regime for that, or you do?
Yes, we can see the endoscopic view.
Yeah, fantastic. So here on this endoscopic view,
Richard.
So you can see here on the right-hand side, we've got this tissue was hanging out his nose before. So that, when I saw him last week, and it's, although medicines like prednisone and anti-staph treatment settle this condition down, it doesn't solve it. You cannot fix AFRS with medical treatment. So when you have someone who comes and sees you, they are destined for an operation. I don't think there should be people giving AFRS patients lots of medical treatment with the idea that it's going to help them. Jackie, can we give you this, please? So one of the first things I'm going to do is I'm going to take out just the polypoid tissue that's sitting here. I'm going to send it off as a bit of a biopsy. Jackie, this pit here that I'm going to give you, this is going to go to our tissue bank. So can you keep it fresh? And Kate and Justin are going to come later on and pick it up. We always have research projects and things going on, and we have an active tissue bank, Ashok, and we routinely, keep tissue to add to the tissue bank, whether we're doing simple interventions like just histopathology or flow. We've got a flow cytometry and single cell analysis right now that we're doing on sinus cavity specimens. Now, one of the main things that's really important, is when you do sinus surgery, especially when you're managing a polypoid condition like AFRS, is you mustn't inject, can I go swap to the 25? You mustn't inject the polyps. The polyps do nothing when it comes to the injection. The most important thing here is to make sure we inject the lateral wall. Now I use neuropathies that contain 1 in 1,000 adrenaline and ropivacaine, and my injection is also 1 in 100,000 adrenaline, 1% ropivacaine, and it has tranexamic acid in it as well. And the patient also gets a dose of tranexamic acid IV as part of the surgery. And I was in Phoenix, Louise, recently, and it's amazing. Very few Americans give tranexamic regularly, but really, I signed off on the Cochrane review for that one.
Yes.
There was a lot of debate on the Cochrane review because there's 12 RCTs now on using tranexamic acid for bleeding and sinus surgery, and the effect size is a moderate effect size with significant clinical relevance. And that's, I can't tell you, in the Cochrane reviews, they often come up with these really soft indications and ideas, but actually the effect size was really dramatic. It was almost a full standard deviation on average that people benefited from using tranexamic acid in terms of...
Richard, I think it is becoming, we are also using more and more commonly now.
Yeah,
and it's certainly past standard part of my practice, isn't it, Louise?
Yeah, 100% right. And it's gotten to the point now where I would say that tranexamic acid, there's the evidence for it helping in bleeding is so strong.
Exactly.
You should be really asking yourself why you're not doing it, Yes. And then people often worry. They say, oh, but I'm worried about the prothrombotic risk. Do you know what? That's been looked at. There was a systematic review of 250,000 patients in tranexamic acid trials across different surgical disciplines. And they really failed to show any significant increase prothrombotic event, even in people who've had previous thromboembolic phenomenon. There was only one small subgroup which maybe suggested these were people with who'd had a previous embolic neural event, and that was it. Pretty much every other subgroup, because overall there was no difference, and when they broke it down, they could barely find a difference. And so really the risk there, even in people who've had a previous embolic event like a PE or DVT, is still to use tranexamic acid. So it really is something that if the listeners are online now thinking about tranexamic, you should be very, very comfortable doing it. Tranexamic acid comes as 1,000 milligram vial in most places, and the average dose is about 15 milligrams per kilogram. So it means for a 70 kilogram person like this guy, this young man's 70 or 80 kilograms, 1,000 milligrams ends up being just a bit of a standard dose, the whole vial for a single person. And really just one dose is all you need. The half-life in the serum is many hours, but in the tissue it's even longer. It's up to 17 hours in the tissue. And so, one dose alone is all you need. I don't send patients home on oral tranexamic. I don't have them do additional tranexamic acid sprays or anything else afterwards. We just simply...
So how do you inject topically? Did you say that you inject it along with the local anesthetic? So how do you do that? That certainly is not...
yes. So you said what? Say that again, Ashok. I couldn't quite hear.
Did I hear you correctly that you inject the tranexamic acid along with the local anesthetic as well?
Yes.
Correct.
Yeah, I do.
So how do you do that?
Our standard mixture. Yes, our standard mixture is to draw up a 10 ml syringe.
Okay.
We draw it up with 8 mils of ropivacaine 1%.
Okay.
1 mil of 1 in 10,000 adrenaline.
Okay.
And 1 mil of the tranexamic acid, which is 100 milligrams.
Okay.
So that's our standard dose that we use when it comes to... We won't do it just yet. Let's just do a timeout, guys, now. So let us do a few mandatory things. And I just use the 10 mils. Most people get the full 10 mils when they do it.
Okay. Thank you.
Let us do a quick timeout, doing all the right things, Ashok.
Yeah, thank you. I think for some part of the world, there may not be concept of timeout. So timeout is going over, reviewing the patient. Is it a correct patient? Is there really the WHO checklist?
Okay.
Going who?
Antibiotics
is the correct patient? Is the correct surgery? Everything is in place. So doing all the checks, that's really the timeout. So all team comes together and does the timeout, does all the checks before the surgery is started.
That's fresh. I'll give you a separate one.
It's almost part of the standard practice now.
Make sure there's some saline in that or something. Bring us to keep it healthy. Okay, so let's get started. Let's do a little bit more reverse Trendelenburg, please. And Ashok, many people ask me, they say, what do we do to get the conditions right?
Yes.
Perfect, thanks, Martin. There's no one thing that gets it right, So the first thing I would say is that you've got to have an anaesthetist who's willing to give you this. I don't know if you can see the 68 there. Do you want to turn the screen around? You got to get a heart rate in the 60s somewhere. That's less important. Just normotensive to, sort of slightly hypotensive. But you cannot have an anesthetic where the heart's going beep, 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 really loud, because that usually equates to some sort of peripheral dilatation and low systemic vascular resistance. And so that's really not ideal. We then place the patient in reverse Trendelenburgs, a good 15 or 20 degrees. We use the local anesthetic, and then we try not to strip, and we give, we use local anesthetic. Our local anesthetic has a non-selective alpha agonist, so we intentionally don't use oxy or phenylephrine when it comes to the vasoconstriction, just adrenaline, because we don't want selective alpha agonists. And then, of course, we give systemic tranexamic acid. And you know what? There are systematic reviews now on most of those interventions, and pretty much all of them equate to about a half a Bozert score. Do you guys know what the Bozert score is? I'm sure you guys do, but maybe for the listener, Bozert scale is this nice scale that was designed to talk about the surgical field. How good is your surgical field? And I think it's 0 to 5, but, Louise Ashok, correct me if I got it wrong. It's 0 to 5, and each of those things I discussed reverse Trendelenburg, non-selective vasoconstriction, bradycardic anesthesia, TXA, they're all worth about a half a Bozert score each. And if you add in don't strip, that's another half a Bozert score and good surgical technique. And there you have it. That's a 2.5 Bozert score difference in the surgical field. And that takes you from a terrible field to something that's really sensible. So, people always want to know, what is the magic sauce? There's no one thing. It's like this sort of mix of interventions that we do to create a nice surgical field. Okay, so hey, let's get started. Is there anything I left off the list, Ashok and Louise, you think's relevant?
Well, can I just ask just about ergonomics, Richard? How do you set the patient up with regards to your position, the patient's position, and the screen, for example? Do you stand? Do you sit? Let's
go backbiter, thanks. Make sure it's going directly up. So look, I stand. I don't use arm boards and things like that. I am very mindful of our my positioning. So I make sure that the screen is not in a position where my head's turned. Ball probe, thanks. And I try very hard then not to lean over the patient. So the patient's not in the center of the bed, but they're towards me. And just by the way, everyone, of course, I'm making a little backbiter through the uncinate. I just really want to find the natural os, which is about here. Straight through cut, thanks. And then we'll go back to the backbiter. And I'll take out...
And one of the things that contributes to good hemostasis is also the preoperative preparation. Like as Richard mentioned before, giving the steroids, antibiotics appropriately to that pathology.
Everything's involved on this one side. Yes. But it won't be, everything won't be involved in the AFRS process, Ashok. You know how it is?
Yes.
There'll be a selection of cells and functional units packed full of fungus, and then everything else will be secondary obstructive disease. So we still then treat this. Let's go back by, let's go kerosene up. So we still treat this as a sort of a localized process, but it does tend to involve the surrounding cells because of the severity of the edema. So you can see here, I've just taken out the lower uncinate, and look, I don't even bother looking when I know that I'm there. But if you said to me, what if you really wanted to see, we could put a shaver in and just very quickly shave out. And there's the roof of the maxillary sinus there, right? Now, the reason I like to do the lower uncinate first, kerosene up, is because if we do the upper uncinate, you can make it bleed very quickly onto the area where you want to go and find the maxillary sinus. And so I know early on in early FEST days, people started fiddling with the upper uncinate first, but I really don't think that makes a lot of sense. So I really encourage people to do the lower part of the uncinate first, find the maxillary sinus, understand where you are, then take the upper uncinate out. Because if you cause bleeding, then at least you've already discovered that sort of natural ostium area. So when I do FEST, the first thing I do is I'll do it in stages so we won't rush through it. You can see there's the uncinate. Give me a kerosene up again. Okay. And I really like to max out the uncinectomy here. And guys, Mel, we might have to go down on the suction here a little bit. It's going to be a bit too strong. Maybe to like 150 or 180. I'm going to turn the suction down because it's, maybe 160. Really nice thing about the Stryker Neptune unit is you've really got nice control over your suction power. And you just don't want to strip. It's all about stripping, Now, this is a good view. So I'm going to get rid of this polypoid tissue here, just hanging off all that. Okay, now, it's sort of like the bullet's almost gone here, or something had happened to the bullet already. But I'll point all the anatomy out here in a moment. Just give me an up-through cut, thanks. This is really important. So if you said to me, what am I looking for? I think in the olden days of when we first started doing FEST, people are so fixated by finding the natural ostia. I really discourage that. Kerosene up now. I really just say to people, find your anatomy, understand where you are. This is sort of the Sydney philosophy and how we teach FEST. Don't worry about the tracks and the pathways and everything else. While I think it's nice to learn all of that, and it's great for your understanding of the anatomy and how it all plays a role and connecting it up eventually, what surgeons need to know early on in their career is really just making sure they 100% know where the brain, the eye, the orbit is. And I know the patient wants to know that you know where that is, That's the most important thing. So here we go here. Give me a curette now, and I'll just point out a little bit of anatomy here. And you can see how much I've really made that uncinectomy as lateral as possible, right? You can see me biting bone. And I'll tell you why in a moment. Here, give me the curette. Because I want to see this structure here. So there's the roof of the maxillary sinus. Can you see that? So if that's the roof of the maxillary sinus, that makes this the medial orbital wall. And when you press on it, it's got that mass movement to it, what we call Cohen sign. So that's a great example of just defining the floor of the orbit and then the medial orbital wall. Let me just get a nice view here. I feel like we're a little bit blurry. Okay, so here we go here. Now we're going to go through into the sphenoid. So here's our basal lamella. There's the floor of the orbit. We need to go through somewhere here. Up through cut, please, Jackie. And then we're going to go straight through cut. So we're going to take the coronal part of the middle turbinate out. And we're doing this at or about the level of the orbital wall. And actually, it's all a bit mucky, so we'll just do what we call sometimes a crunch and gobble. And then we'll put a shaver in. We'll go straight through cut after this, I think. And of course, we're using a Medtronic M5 hand PCR and the quad cut. The quad cut, to me, I've grown up when we used all those other things. The quad cut just doesn't block like other things that we used to use. And so for a case like this, I always use a quad cut blade. Now, you can see this is the back edge of the middle turbinate, just there. I'm going to get a through cut here. And this little ridge here is what we sometimes refer to as the orbitoethmoid plate. Now, sometimes a retromaxillary cell will hide in here, and I really encourage people to divide this early in the case. Don't create a tunnel down the ethmoid. Make sure you can see the posterior ethmoid here as part of this approach. So, and what I'm doing here is I'm defining that orbit. Give me a straight Blakesy, thanks. Let's go straight through cut, thanks. That's a bit big, that Blakesy, if we've got a smaller one. Usually there's a smaller one on there. That's a bit of that back uncinate. I haven't quite taken it all the way down. And you've got to make sure in this case, you've got to do maximal cells here. This is the rest of the posterior fontanelle. Just needs to be a little bit lower. And of course, you want to go low here, but not posterior. Because if you go too posterior, you get that wall there, you get into a bit of blood vessels. So you always want to leave a little bit of tissue there. It's one of those bleeding sites. I'm sure you guys acknowledge that as well. So here we go now, right? So here's my orbit here. So I knew the orbit was here. I've still got this little ridge, which bothers me. Let's see if I can get rid of that. I want to get rid of the bone ridge, but I don't want to start stripping it all, right? So here we are now. Now, we're getting into an area here that hasn't seen, there's a bit of that sort of fungal mucus. So here we are now. So we're into the posterior ethmoid. Now I want to find this sphenoid, right? Now, if you had a tumor, you could just use the floor of the orbit and keep going back. But this is an inflammatory case. So we will make a little bit of an effort to find the superior turbinate and use the superior meatus to get there. But you don't have to. So here we are now. We've just gone through the very back of the middle turbinate. You can still see a little bit of a ridge here. We'll take that ridge off. Here we go. And you see all this? There is, see that little ridge there? That is the superior turbinate, a very polypoid, redundant superior turbinate, right? Okay, so give me a straight through cut. So, at or about the level of the orbital wall, you want to now feel for that superior edge and do the tiniest of little resections here. Let's go curette now. You don't want to trim the superior turbinate off. I think that's one of the errors I sometimes see, Louise. People, when they get very confident in it, they start to just go for it. And then you can see a tiny bit of stripping happening there. Give me a curette now. So that's our sphenoethmoidal recess just there at the level of the orbital floor. Can you see that? So I'm sort of looking across to here. Give me a curette. Then give me a kerosene up. So we put the curette in.
Yes, and they just remove too much of the superior turbinate.
And they take too much superior turbinate, yeah. And that's because people get confident about where they are. And so they just start over-resecting it. Actually, hold that very still. Just give it to me in 2 seconds. I just want to remove the blood so I can show people what I'm doing. So I just stretched open the natural os, just enough. Give me a curette again. I'll show you again, right? Get rid of that tissue, just so you can see what I'm doing. Here we go. So I went into the superior meatus. I went in, I fell into the pocket, I turned around and then stretched down. Can you see that? So that's how I get into the natural os. And I don't really care at this stage whether I'm in the natural os or not. I could have just poked through the posterior fontanelle. I can connect it all later on. What I want to do is just enter the sphenoid at a nice, safe height, and that orbital floor tells me where I'm at. Mel, can we go down, please, on the suction now, down to 100? So as we come up to what I call final cavity mucosa, we'll start, thank you, we'll start now reducing the suction, so I'm not going to do any stripping. Now, here is the floor of the orbit. Come across, guys. Here's my bitten wall of the sphenoid, and now I'm into sphenoid. So I've used the orbit and the floor of the orbit as my guide to showing me where I need to go. And you can really see here, this is a great case because it's so inflamed. I'm not looking for the air cell tracks at all. And I think that's a really important difference here. Let's go up through cut, thanks. I'll get rid of that little flake of bone. I don't want to strip here. I can see it stripping ever so subtly from that corner pocket. And I'm going to here in a moment find what we call the corner pocket. So the corner pocket here, with an up through cut, is the most supralateral part of the sphenoid. Or it could be an anode cell. And what it defines for us, it's this bit here. It defines the skull base. Because if that's the skull base, I know that this tissue isn't the skull base. Can you see that? And then I know that this can't be the skull base because I'm between orbit and middle turbinate. And then I can come forward all the way like this. And I know that I'm below the skull base at all points there because I found the corner pocket. And I just really make a channel through all the tissues like that. And when I make a channel like that, it means I can come back now and do what we call ridge running. Ridge running is how we complete the sinus cavity. And I think, guys, last time I did a case with you guys, we did it all just with the ground lamella intact, I think, because the person had only unilateral. I think it was an AFRS case as well. So here we are here. We got to actually do the whole sphenoid cavity, the whole sphenoethmoid. And so we come back here now. This is that ridge that had the supposed corner pocket in it. And this is the first ridge that you've got to make sure is 100% right before you move on. So there's my little partition. I really want to make sure, straight through cut. I want to make sure we're not stripping here. Okay, I think I can see the first of the ridges. Here we go. And you can see my suction's turned down, guys. That's why it's all a bit slow, but it's going to stop me from stripping. So there's sphenoid. That mucosa is ever so subtly wanting to strip. Here's my first ridge from here to here. So I want to see that ridge come off the turbinate and onto the orbit. And you still can't quite see the ridge here. There's the ridge there. This is the ridge here. So you really want to see it onto the turbinate. Can you see that ridge?
Yes.
And then now we're going to follow the next ridge, right? So you can see the next ridge is here. So I'm not shaving just the roof of the cavity in between, but this ridge. And I want to see this ridge come across, and then I want to see it come down onto the turbinate. I've actually got to see it become the turbinate, right? There it is there. It's becoming the turbinate. Can you see that? Become the turbinate. And then it's got to come over the ethmoid roof and then down here onto the orbit. But you can only do that once you know where the skull base is and you know where the orbit is. And this is how you become one of those surgeons that avoids leaving this little run of ethmoid cells against the orbit. I think that was, when I was a trainee, almost everyone had like a row of ethmoid partitions left on the orbit. And so here's the next ridge. So the only way you can do it, though, is you can't be using IGS to make sure you're there. You just got to know where the structure is. That's why we find it early on in the piece. There's another ridge. This ridge comes forward a little bit, but then comes down onto that turbinate. We'll do the next ridge here. Here's a ridge here. Let's get rid of that ridge because I can see I've already found my medial boundary of my cavity. It's the turbinate here. So if you said to me, is this the medial boundary? It can't be, right? Because my medial boundary is here, so I know I can take this a bit more. You know, I've got it all well defined. Okay.
Almost skeletonize all the boundaries, really.
Yeah, it's just I don't care how they're all arranged, the sinuses, like how anatomically they're organized. You know, Ashok, I think it's nice to talk about that, but the surgeon needs to know is what's my boundaries and my limits. And then we get a cavity that looks like this, and it's looking very, very close. I like to lower the sphenoid here, so give me a down kerrison. And for me, when I lower the sphenoid, it's got to be, someone said to me, well, you know, what's a sphenoid open? When's it open enough? Well, I must be able, every case, to be able to put a straight sucker into the retroclival recess. If I can't do that, then my sphenoid's not opened wide enough. And the rationale for that is that if my patient gets some sort of plugging mucus or crusting, if I can't even reach it in the clinic with a straight sucker, then I'm in real trouble. So if you said to me, you know, if I take someone to theatre and I'm going to do a surgical opening of someone's sphenoid, then the minimum I do is really like there was a nice new classification actually came out in IFAR recently that I was asked to be involved in. I think it was a nice agreement amongst colleagues on how we might define sphenoid openings. But really, my basic sphenoid opening is like a level 3 sphenoid. It's complete opening of the sphenoid, a little bit of lowering, see the front wall. Yes. And of course, when you do this, you will pick up the septal branches, but there are many, many septal branches, right? So if you pick up one, then you're not picking up all of them and everything else. So it's just one of the septal branches. But I almost always will bipolar it. So hit me out with a bipolar, please. So this tissue here is what has the little vessel in it. Okay, good. I'm not going to hold off. Give me an up through cut. And you can see my little posterior ethmoid cell here. This is actually referred to as the retromaxillary cell. It's a tiny one in this patient, but it's definitely still in that position. And a lot of people who make what I call a two-tunnel phenomenon, where they make a tunnel into the maxillary sinus, and then they almost do a tunnel down here. And it's sort of not connected. They're sort of separate concepts. Let's go a max on the suction, guys. We're going to do it a big washout. Sponge to me first. So we're going to wash this out and pack it off. And I'm going to go and do a turbinate reduction on the other side. So I don't do a lot of turbinate surgery with FES unless patients have a condition in which it's expected that they would have turbinate hypertrophy. I think there's a tendency for a lot of surgeons, they love doing turbinate surgery, I think as some sort of, almost like a crutch. They're not sure if the sinus disease will get better, but they hope that at the very least they can, make sure that there's an airway. I don't think that's particularly a scientific approach when people do that. I would say I'd like to do turbinate surgery when I believe the process going on, like in allergy, and in this case, is one that you would expect turbinate hypertrophy to be present. Whereas patients who, say, have adult onset asthma and polyps and really have no evidence of allergy, those patients don't generally get a turbinate reduction. So, I don't think it does any harm, but I think, the more you have a philosophy of just doing turbinates with every single FES, I do think that opens the patients up for more risk of bleeding and other problems, and it's probably not necessary. And it's about maybe having confidence in what do you think's going on in terms of the actual underlying pathology. But there we go.
Richard, if you decided to do the turbinoplasty, what is your technique?
Say that again?
If you decided to do turbinoplasty, what is your technique?
Oh, we're going to do a turbinoplasty here, so I'll do you one better, Ashok, than describe my technique. I'll do it for you. And there's a couple of things we're going to do here that might be a little bit different. You're probably familiar with medial flap, but I'll show you what we even do with a septal turbinate here. So the septal turbinate is this tissue here, right? Now, do we have any more injection left? We may not, actually, Yeah, we do. So very commonly, it's not too bad on this side, right? But very, very commonly, I'll inject the septal turbinate on both sides. Just turn it off, thanks, Martin. And I'll do a septal turbinate reduction as part of my surgery. It's really common that I'll do that. Can we go down, please, on the suction? Thanks. And you'll be surprised, there's nothing wrong with this guy's cartilage and bony part of the septum, but he has bad allergy. And actually, the septal turbinate, or septal swell body as it's often referred to, is not discussed enough. It's a really big part of tissue remodeling changes that occur in the nose. And although there's lots of different techniques described for reducing it, and I don't think any of them necessarily are better than the other, it's absolutely something that's enlarged with disease, and it's increased in allergic conditions. And additionally, it actually is correlated with inferior turbinate volume on studies. And so I'm a really big fan of doing little things to the septal turbinate. Now, that wasn't so much on that side, but I was keen to do it. On this side, we'll do the same thing. And you'll see here, this side is actually quite tight. Now most of it is actually not bony, or cartilaginous. It's actually a soft tissue phenomenon, because you can see how close we are there to the olfactory level. See, as we go past the middle turbinate, this chunky septal swell tissue I'm trimming, and I'm down to cartilage there, so that's deep enough, it gets very close to that flat area. So we will very quickly just trim this back like this. There you go there. And I can't tell you enough, for many patients, just doing a little trim like that is enough to sort of open up the airway in that area. And then you have to make a decision, is it worth taking out the bony cartilaginous junction and things like that. But often it's more soft tissue than it is bony. And actually I'm more and more now inclined to take the soft tissue component out rather than the bony component. Now give me a medicine balm. So we'll do a turbinate reduction on this side. Can I have a drier Raytec? It's just too wet. Sorry, I might just take a little bit of... Okay, here we go. Perfect. Alrighty, so the first thing I'm going to do is we're going to do a medial flap turbinoplasty, but I need to keep the tail here for my graft at the end of my case. So this is something that when I'm doing FES, can we go max on the suction, please? I'm going to take this soft tissue tail, and this is my go-to area. Can I have a curved iris? This is my go-to area to harvest soft, like mucosal grafts in the nose. Because when you take it out, and I'm just trying to get the right instrument here to show you, when you take it out, if you take away, see this soft tissue, you can see my blade? If you slice it slowly, you can feel the bone. And for most patients, you can just sort of take it where you're not getting into the bone itself. So have a look here. See that? See how I'm not actually in the bone?
Yes.
Yeah, and I tell you what, if that's all I was doing for a graft, that's incredibly low morbidity for a graft, because, and now all I would do, if we weren't doing a turbinate reduction, I'd simply come back now with my bipolars. Just getting my angulation here, right? Yeah, and I just seal it up like that. Now, a little bit, because we're doing a turbinate reduction, I'm going to be back here anyway with a diathermy, but you just seal it up. And you're not really into the artery. You know, you're going to be well away from the main vessel and everything else. And because it's right at the back of the nose, it's an area that's going to heal really well as well, because it's, you know, not in the middle of airflow at the front of the nose. But let's go ahead and do a turbinate reduction. So, my first step on doing a turbinate reduction, if I'm doing it in isolation, I won't use the quad cut. The quad cut's a bit chunky for most people. But I'm not going to open another instrument just for the sake of that. So I make a little window to see the inferior meatus. Can you see the inferior meatus here?
Yes.
Yes.
Yeah, and so I'll see if I can then, I fracture it out a little bit. And I like to get my instrument into that area. Can we open a 90 shaver? Only because I'm going to do... Here you go. So I'm going to come in here. Oh, there you go. I'm in. So you can see the inferior meatus. And I like now just to score the apex of the inferior meatus. So I just want to score at 12 o'clock. And the reason for that is I don't want the mucosa in the inferior meatus to strip, because here is the young man's nasolacrimal duct, that little area just there. See that? It's not up here. It's here on the lateral wall. Can you see that? There's the valve. So that's really important. I still meet trainees who think it's sitting at the top of the inferior meatus. And so I think it's really important to appreciate where the valve is. Then I'll come down, and he doesn't need much, actually, this young guy. Probably about there. There's not much. Give me a curette, thanks. And if you said to me, what I'm doing here, I'll go straight through, cut next, is I'm judging how much medial flap I have. Can you see that? It starts from there to there. So that's going to dictate what I'm leaving behind, because I want that medial flap to fold in over itself at the end of the procedure. Now, I like just to bite the edge here, and the reason I do is it releases the periosteum, and it makes then the dissection a bit easier, and I'll show you what I mean here in a moment. So even though you said to me, Richard, you've already shaved it, why are you biting it again? Well, when you bite it again, you really release the periosteum, so that when you come back now here, I find the bone up here on the piriform. See that? I don't find it on the weak inferior turbinate bone. Once I found the bone plane up here, subperiosteal plane, I'll come down over that bone and I just slide straight through. Can you see that? So I've just slid straight through. Suction, thanks. And I can feel the bone, and I'll just slide straight through. And by releasing that, it'll help me, allow me to develop that plane. And we've still got some bleeding here. You can see there's a bit of a tunnel and a vessel here, so and the vessels often do run in little tunnels like that. You can see it, right? But my goal here is to keep the flap, not the bone. So if I need to fracture the bone and get rid of it so I can see what I'm doing, I'll do it. There's the bone that I found before. There was a vessel running through it. I'm just going to get rid of this loose stuff here. This is the... Give me a straight iris, thanks. You can see the vessel coming through the bone. Give me a Blakesley, thanks. No, my apologies, Cottle, thanks. And sometimes when the vessel's snaking through the bone, you have to do the bone in multiple pieces. We are going to bipolar the vessel further back, but it's good form not to break it at the front here. And that vessel will always become part of the medial flap eventually. So if you're chasing it in and out of bone like we are here, it always has to be on your medial side. It's got to be part of the medial flap, because that's how it arises when it comes out of the SPA. So we'll see that all here in a moment. You can almost see the two vessels now running side by side. Okay, give me the straight iris now. Now, you've got to release this. Now, this will be surprising, I think, for some viewers on how aggressively we chase everything down here. Okay, give me a Cottle. More bone around the vessel. Still a little bit of bone around it, right? Can you see how there's like a little channel of bone? Now, when we get down here, still don't like that. There it is. There you go. Now it released. Give me a curette now. So now when we get down here, I'll show you, you want to find the vertical plate of the palatine bone. And you don't want to do this until you're all the way down here, right? Give me a straight iris, thanks. Curette now. See the vertical plate of the palatine bone? Yeah. So
Yes.
we're going to keep going. And for most people, you can find the exit point of the SPA through this flap. And I'll show you here in a moment. Have the sucker ready? There it is there. And I'll just suction it.
Okay.
And I think when we do this, you're almost doing like a little posterior nasal neurectomy at the same time. Yeah, there you go. And there's the SPA coming out up here. So a little bit more suction. Sorry. We're a fair way away from that step. I'm trying to get you a perfect view. I may not. Yeah, there's a tiny bit of blood around, but I'm not going to force it. Anyway, SPA, you can see this tissue's tethering right there. That's where the SPA comes out. But you should have it completely released like that, so the whole thing sits like a little, like the hood of a car. There you go. Now it allows me to take the bone out, the curved iris. So taking the bone out is important because it's what allows me to place then this new turbinate flap into a more lateral position. Because that's all. I don't want to make the turbinate hugely smaller. I just want to move it. I want to make it somewhat smaller and move it into a more lateral position. Now, by having already scored that mucosa, it's coming away. It almost strips away on me because I've released it already. And it also means that if the conditions weren't good, I was struggling, I would have a situation where it would be very easy for me just to sort of pull it without stripping it into the inferior meatus. Now, what is really important, give me a curette now, is what we call Linda's ledge. So we've got a nice publication coming out saying what's the difference between people who end up having, with allergy on immunotherapy, who end up having turbinate reductions and those that don't. There are some morphologic differences in their turbinates. And one of them is having a very thick bone and a very strong horizontal ledge. So you see this ledge here? This ledge is the ledge, the horizontal ledge is what's important to get rid of. Because it's what gives you, can I have the Blakesley, thanks now? It's what gives you that lateral displacement of your final turbinate. You know, so it's the ledge that's important. I think I see a lot of people do turbinate surgery where they don't take the ledge, they take the vertical bit of bone and they over-resect the front and the middle bit, and they end up getting this sort of coat hanger, harbour bridge looking turbinate, we call it. And it's sort of like a weird sort of, you know, arch they get at the end of the day.
Yes.
Yeah, big wash, thanks. And it's a look we try not to give patients, you know. And
another tricky area is the head of the turbinate. I would also like to know how do you deal with that head of the turbinate?
Yeah, the way we avoid it is bipolar now, is that we'll try to keep the medial flap even the whole way through, and then really take Linda's ledge off. So here we are now. So now we can see the two vessels, right? Can you see the vessels? And I've got the vessels, the branching vessels in the middle of my bipolar, and we'll seal it up. And then occasionally I'll just do the little the back bit here. Sometimes there's a little branch down the bottom there. Okay, big wash. Now, suction links. There's my turbinate reduction. And look how when I've got the vessel eventually, I left it to the very end, how dry it becomes. You know, really nice and dry. And the reason we do this technique, it's got nothing to do with avoiding empty nose syndrome and things like that. Empty nose syndrome is about patient selection prior to surgery. Do we do this technique because it provides relatively accurate volume reduction, very good vascular control, and very good mucosal coverage? This is the tenets of doing this technique. And I still think the head's a little bit big here, so you've got to remember that this whole area is under the effects of 1 in 1,000 adrenaline. So, you know, it doesn't... If it looks okay now, it won't when all the adrenaline wears off. See, it's a bit full here. So one of the things I'll often do, Louise, is I'll often mix my techniques. You know how there is a technique of using a like an intra-turbinate shave, well, with a smaller shaver. Well, you can do that here with just undermining it and sucking out some of the head, like you might do with a intra-turbinate shaver blade technique. And I just take out a little bit of volume. And at the end of the day, your turbinate head should almost be, I think, concave when you finish. So you should almost have a subtle concavity to it. Yeah, there you go. Very, very close, right? At the end of the case. And then that'll give us a really nice sort of, turbinate. Let's go back to the other side. We will do a turbinate on the other side. Here.
And why do you think this gentleman's had such a marked response on just one side?
Oh, no, this person's got AFRS on one side.
But why just on one side rather than
okay, so
both? If there's allergy there, why do you think such?
Yeah, we'll get it here in a moment. We'll do it from the frontal. Yeah. So is that's really a question as to why do people get a unilateral AFRS? Is that correct?
Yes.
Yeah. So AFRS, in my opinion, is classically unilateral. I think people who have bilateral AFRS, I think half of those patients just have type 2 eosinophilic disease. But there are classic bilateral AFRS patients around now. But AFRS is classically unilateral, and we think it's got to do with the fact that at some point in time, those patients unfortunately have an event that causes mucostasis. That, like just a cold or a virus, like this guy gives a very good story. They all happen after a cold. And then that cold produces mucostasis, as it often does in many people. Let me get in there. Sorry, let me get into my inferior meatus. Okay. And then during that period of mucostasis, Louise, the theory is that fungal elements live in the mucus. And because fungal elements are very different from simply dust particles or pollution, they're actively a living organism, just like when we leave bread or orange peel out on the countertop for too long, fungus grows on it. And it grows in the mucus. And then because it happens only in people who have this sort of skewed hypersensitive immune system, they then react to the fungus. They get an inflammatory reaction which further impairs mucociliary clearance of the mucus and fungus, and then the whole thing propagates and gets worse. They get more mucus plugging, more fungus continues to grow in the sinus cavity, and they continue their hypersensitivity response. And then they get caught in a cycle where even at that point they've got terrible mucus plugging with fungal concretions, and even if you give them a period of prednisone, even for many weeks, it doesn't really break it. They feel better when they're on it because you're suppressing the hypersensitivity response. But the minute the steroids finish, because the fungal plugging and mucus elements are still there, or the fungal elements, it just starts up again. So that's why it happens. And then it classically is not every sinus. Like, it usually is limited to a functional group of sinuses. And then what you'll often find is the surrounding sinuses are secondarily involved. But of course, you can imagine once one set of sinuses become inflamed, they cause obstruction to the other sinuses. It all sort of propagates, and you certainly see people, I've seen lots of people who've presented where every sinus is involved. But actually, if you go back to curved iris, if you go back and have a look at their original scans, they often didn't start with absolutely every sinus. They started with, sort of limited disease, and as everything got swollen and mucus trapping and plugging became a more prominent event through the whole sinuses, everything got involved. But that's my understanding about why AFRS is unilateral. And like in this, and in people who have unilateral disease, it's a really important thing to discuss with patients because it's really important to discuss how it's so important to suppress their immune response. And they'll say to you, listen, if it's an immune reaction, how come my other side's not involved? Now, the answer to that is that because right now, the mucus clearance is working well enough on the other side that no fungal elements are sitting around long enough to cause a reaction. You need a bit of contact time for that to occur. So that's the sort of answer in that. But absolutely, the hypersensitivity is part of the problem here. Give me a curved iris, thanks. And so it's very important to treat the underlying immune response. Now, the other side can become involved. And it's a bit of a debate in the world of, I think, AFRS surgeons. Do you prophylactically do the contralateral side or not? I'm not necessarily a big fan of that, but the data's, if someone wanted to do that, the data's there. Like, it's actually a relatively high chance that during someone's lifetime, they'll develop AFRS on the
on the other side.
Yeah. I'm a big fan of something ain't broke, don't touch it. But you know what? If someone want to do it, I think there's enough evidence for it. I always remind people though that if you sort them out perfectly, then if they do get it in the future, you'll be the first person that they will come back and see. So why make two operations one and make it longer and harder and more recovery? So that's my.
So can I get this right, Chad? That on this case, I get it. You're doing extensive right-sided surgery, but on the left side, because it is not involved, we're going to leave it alone.
I'm going to leave it.
Do you even consider doing a sort of a mini phase or that type of procedure where just a simple uncinectomy, middle metal anterostomy? Do you consider that? Or?
Yeah, if you're going to do something, Ashok, you do the whole thing or don't touch it at all. Because if you do a mini fess, you can absolutely trigger it off. I've seen that happen. Because by doing a mini fess, you create swelling and edema. You're creating the very trigger event for which sometimes AFRS will start. And I've seen people who've had limited surgery. Usually the surgeon wasn't really aware that it was AFRS, and they've done an OMC procedure on both sides, and of course haven't sorted out the ipsilateral disease. But by doing the OMC surgery, they've set off the contralateral disease, where it wasn't involved on the original scan. So yeah, I've absolutely said. So my advice would be, no problems. You either do it in the whole thing, or as an empiric thing, or you don't do it at all. Give me a curette now. So you can see I've done exactly the same procedure here. Give me a sucker, thanks. And I'm just going to find that plane now. There's that vertical plate. I'll get you to help me take it.
So you keep the medial flap intact as well, as much as possible, right?
Medial
Both the flaps are intact. Yeah. And just the bone removal.
All the way up to where the sphenopalatine foramen is. And then we'll come back, we'll just check our shelf. There's a little bit of bone here. Give me a Blake, see, thanks. You can see there's a bit of shelf here, Ashok. See that shelf?
Yes, yeah.
So we'll take that out. That'll hold the turbinate out a little bit in a funny position.
I think other advantage I can see with this technique that you're not creating larger raw surface. So post-operative crusting and all that must be very minimal. The healing process.
That's absolutely right, Ashok. And you know what? When Ray Sachs did the first publication here, he did the first RCT, and looking at in submucosal debrider technique versus diathermy versus medial flap. And I can tell you, I was around when he published that. That first study, he had such problem with some of the reviewers. They just couldn't believe that a diathermy technique had more crusting than a medial flap turbinate reduction. But the reality is that if you see it actually done, and if you've ever seen a diathermy patient a week on from surgery, you really completely understand why. Sometimes when people do diathermy techniques, they looks fancy at the time of surgery, but they really create, just necrosis of part of the turbinate. I mean, I remember as a trainee, seeing someone months later still taking out dead bits of turbinate bone from their nose after a diathermy. So it's really something I do try to avoid, and a real reason why the medial flap turbinate reduction heals so well. So here we are now. I think we're ready to go, right? Let's do the frontal now. So give me the sucker. I'll go the needle point diathermy next, thanks. So we've done everything. We've done full sphenoethmoidectomy on the affected side. It'll look amazing when we take all these patties out, right, guys? Because a lot of that mucosa I showed you before wasn't involved. We've done a bilateral inferior turbinoplasty, and now we're just going to sort out the frontal here. So I guess this is sort of our very just standard approach now we do for frontal sinusotomy. It's really a draft 2A, but via Carolyn's window. So when we raise the flap here, there's the root of the middle turbinate. Here, it looks like I'm behind the middle turbinate, but I'm not really. I'm actually directly vertical to it. And it's a bit of a visual illusion for many people when they see that being done. I'll swap you, thanks. Just wipe the tip because I'm going to show everyone. Give me the sucker. And we'll have a look here in a moment, thanks. A bit of mucus and things. So there's our first cut. The next cut here is going to be over here. Now, it's not on the lateral wall. If anything, it's on the septum. And then you can come across. So there we are there. And we see where the piriform is. There's the piriform. And so it's all the way to the piriform. Just give me a second. And that's very important. So give me a coddle, thanks. I think a lot of people, when they do this flap, they make this cut here. You can't do that. You need access to this area. So when you're raising the flap, it's really either at 12 o'clock, right on the midline, or if anything, it's slightly over on the septal side. And even then, I've got a little tag there. So we'll raise this flap. Put a drill on, please. Comes down. It's like a big DCR flap, right? Mm-hmm. Okay. Now, if you have to, say you're missing turbinate, middle turbinate, you're not sure of the anatomy, you can just dissect down here and find the first olfactory neuron, like you might. That's the emissary nerve, that one there. But you can find it if you need to, right? And this is a little bit of loose tissue, so we're going to get rid of this. So if you needed to find more anatomy, you can. We're just getting the drill ready. 2 seconds.
I agree with you, Richard. I positively try and find that first olfactory neuron. Then I know at least one of my landmark is there. So it's just an added safety and a reassurance.
Okay, here's my drill with great irrigation, which is terrific. Now, the first thing you want to find is just find the periosteum here. This is PJ used to promote a lot of this. The great concepts. Find the first olfactory neuron. Find this periosteum low down here. And the first thing you'll find here is the nasolacrimal periosteum. There it is there. Then you want to remove the bone going up, but you want to keep it really saucerized, right? You don't want to do it in a too small an area, Don't want to be looking...
Richard, I note that you have changed the burr here. I mean, from the cord cut. Now you come to, is it diamond or reverse?
Do you know what? I can't quite hear you. It's a bit muffled, the speaker, and I got the drill going. I'm sorry.
Okay.
Louise, can for some reason your voice is clearer. I don't know why.
It's clearer. It's maybe the Scottish accent.
You think it...
So can you hear me now? Is that better?
Stop. Yeah, give me that question.
Okay. Now, you said that you were using the cord cut burr up till now. So you seem to have changed the burr. So what is
this is, we changed from a shaver to a burr. This is a 15-degree, 4mm coarse diamond.
Okay.
It's the Medtronic choanal burr.
Okay.
Mm-hmm. And it works great. I don't use cutting burrs really, in most skull base. The coarse diamonds are so good now, and they really help with hemostasis. So you can see periosteum coming up there. Can you see how we've got yellow bone here?
Yes.
And they've got that white bone there.
You see that colour change.
Cortex, actually. Mm-hmm. It's not actually in through the soft tissue, but here we go here. So let's slowly remove this bone now. We found the lateral limit. And I'll talk about Ritter's triangle here in a moment. So now we're taking away the bit of bone that's in front of the frontal recess. Can you see this?
Yes.
Yeah.
Very important to remove this bone. It's not, Carolyn's window is not about making a tunnel up the top there. You can see the periosteum coming up there. So this triangular bone here is what we call Ritter's triangle. And a really good example of why it's important to, take away that flap right to the midline. Because very commonly, you are sort of almost just para-midline when you're doing some of this drilling. And it depends on someone's width of their nose and the shape of their beak. But what you really want to do here is just make sure, once again, that you don't create a tunnel. So where we've got this thick bone here, you really want to make sure you drill it back. And you've got to remember, it's very safe, right? The frontal recess is between you and anything else still, right? So it's very hard to cause a problem. And we're really creating a nice look to this Ritter's triangle here. So you can see there's my frontal recess. And Steen and team, I wonder if we can loosen my microphone. It's giving me like a vice-like headache at the moment. Can you just pull it for me? Just reach in and just lift it away from my head. Pull it out, yeah, just for a second. Oh, yeah. Yeah, oh my gosh, yeah, just give it a bit of a stretch so it loosens up, yeah. Oh my gosh. Yeah, I feel like I've been tortured with this microphone. I got one of those, like, they got a headband, it's too tight. Yeah, let's loosen up. And we got a pituitary next, guys, so that'll be fun. I think how I do pituitary surgery is very, very different than what I saw when I was a trainee, and it's a bit of a mix of techniques I've learned from Giorgio Frank, Aldo Stam, various people over the years.
Do you do that jointly with the neurosurgeons, or is it on your own?
Say that again?
Do you do that jointly with neurosurgeons or on your own?
Yeah, we got a neurosurgeon, but Dr. Yonka is going to join us.
Okay, great. Yeah, it'll be really interesting.
So you can see this block of bone. See how the frontal recess is slowly exposing it?
And do you use this approach as standard for all your type 2 inflammatory patients? Or?
Yep, 100%, Louise.
Yeah.
Can I get a washout? It's now it's so quick and easy for me to do. It gives me such a fabulous opening. I just don't do many times limited surgery. Now, of course, I can always find situations in which that breaks the rule, right? Like I'm doing a frontal recess opening in someone who's just got barotrauma. They've got almost no disease. You can almost do anything to the frontal recess, and it's not too complicated. I will just put my 70-degree scope on and do it old school. But someone like this who's going to have pretty significant problems in their frontal sinus, and I need to be able to irrigate out the frontal sinus.
Yes.
Absolutely will do this technique, But I still do Lothrop. If you need to do stuff actually in the frontal sinus, like you got tumor heading up into the frontal sinus, you have to work laterally in the frontal sinus. I'm blocked again.
So when you're doing a Lothrop, Richard, will you be sort of repeating the same thing on the other side and then join in the middle?
You bet, Ashok. And sometimes that's exactly what happens. So a lot of my fellows tell me, I've just done a draft 3 anyway, because I end up doing Carolyn's on both sides and they connect above. And it's almost like you've just done a Lothrop without doing the septal window. And 100%, it's the problem is that, though, is that you still don't square off the edges very well with that approach. And in doing that, you don't get very good lateral reach. So there's still occasions in which a proper Lothrop's required, you know, for lateral access and things. So here we are here now. You can see where we're coming up to. You can see frontal recess. We're slowly, the frontal recess is creeping up closer and closer to this area. And I'm intentionally drilling as much bone as I can before I open up the frontal recess. You know, I don't want to get into all that bleeding mucosa too soon, right? But we're going to be there soon. You can see the blue coming up here of the frontal recess. We're like very, very close. But it's very nice drilling, right? You know, it's your camera's sitting away from the area. Can I get someone just to loosen that headband again? I'm sorry, it's really problematic. I can barely focus. Unblock that, thanks. And you can see the blue coming up. Maybe just move it to another part of my head. Yeah, there you go. Yeah, over my ear or something. There you go, perfect. Yeah, for now. Yeah, perfect. There you go. And you can see we're coming up. You can see the blue coming up. Blocked. A little bit. I'm getting blocked at the moment, not because Jackie's not doing a good job unblocking it, but just because I'm drilling with the pole a little bit. And you can see the blue coming up, and I'll just finish it off if I can. And it is very important to get all the bone out here. I think some people think, oh, the Karen's just like a little bit of bone, like you might do an axillary flap, but it's really not actually. It's like a lot of bone. There's my frontal recess. And you can see I might have a bit of periosteum just there. I think it's periosteum, so we're just going to pretend it is for now. I'm not going to hold it for you. I'm getting there, though. Super close. Now that is a problem. You're not getting it free. Can't block that easy. Make sure it goes all the way through. Take your time. You can see there? Mucosa. So there, see there? See, I touch the frontal recess and there it moves there.
It's moving up there.
Yeah. So you can see it's all connected, right? So there's our frontal recess, and you'll slowly just connect it up. And you know what? Sometimes when I've done frontal recess, like the surgery like this, occasionally you'll come across frontal recesses where, you know, it's amazing, like the intersinus partitions come right down into the middle of this area. And you look back on what it would have been like had you done it with a 70-degree scope. It would have been so hard. Yeah. But here I am here just simply drilling away through this relatively thick beak.
So I think rather than going on and looking for the frontal recess, you are almost landing into the frontal recess with this approach naturally.
You see the mucosa coming through, and really thick beak. You know, actually, I should have shown you. I knew it was thick. He had this little, really high, thick bone. But we're almost through, and you get like, it's almost like I used to think I didn't do much ear surgery as a surgeon, but I used to remember canalplasty was a bit like this. You know, you drill through bone, and then all of a sudden you connect up into your middle the final bit, going through the bone and then finally seeing the skin on the other side. You can see it's all connected. And I'll get it really thin, and then I'll take the rest out with a hand instrument. And you might say, can you do a hand instrument now? Maybe, but my experience is that I'll get it really thin. Early on, I used to swap to a hand instrument too early, I would say. Yeah, look at this. There is like some sort of intersinus partition coming down here too. Almost through. You can see it down. There's a tiny little bridge left. I'm just looking for that last little bit of a bridge. You can see there's mucosa here. There's mucosa there. All right, let's go to a shaver here in a moment. All right, here we go. So let's go on a shaver, and we'll now use a kerosene, and we'll get rid of it all, and we'll connect it all up. And the nice part about doing that is that, you know, you're sort of working with your camera outside of the area. So you don't have your camera right in the middle of the surgical field, which is, I always found one of the problems working with a 70-degree scope. See, look at that. And you'll see how easy it is now to do the surgery. Kerosene up, thanks. Let's go down, please, team, on the suction. So I'll turn the suction down because I'm now coming up to what I call final cavity mucosa. And I'll just, with a kerosene now, just feel that front wall, the front wall of the frontal recess. And we'll get in here. And this would be great. Okay. This is why I do it this way, because now I'm sitting outside my opening. No? What was that, Martin? We're 10 minutes, probably. And I can just do my opening. Okay, give me, let's go up, max on the suction again. Give me a Blakesy, straight Blakes. See a bit of bone here, whatever that is. Okay, so you can see we haven't quite got it right up here. There's still like a lip everywhere. But you'll see in a moment. Give me up Blakesy, thanks, and I'll give you a sample here. So this can go off in formalin. Wasn't it? Can I have a kerosene up? I just need a bit more of a ridge. I couldn't really get a great. There is one. There's a specimen in there, but it's not a good one. I need a better one than that. There's a little ridge everywhere, Ashok and Louise. We're going to get rid of it.
Yes.
Let's go, baby Hoseman. And then we'll use a wash and a stick after that. There's a bit more specimen in there that can go off with the same right biopsy. And I'll get you to help me just clean the baby hose in here. Just can turn it on silent, thanks. Big wash. It's such a good case to show why doing it this way just makes frontal sinus surgery so easy. Because can you see when I'm dissecting here, guys? I'm just not really in that terrible inflamed world of that, that frontal recess, right?
Yeah.
My whole surgery's done a little bit outside of it. And you can see how inflamed it is here.
Yes.
Let's go wash on a stick thing. Let's wash that out a bit. You can see how lots and lots of secretions, mucus trapping, plugging. Let's go some nice patties. We'll pack this off here in a moment. And I'll go back to the drill. I've got a tiny bit more drilling I need to do here. Drilling first, then patties. Then we'll make some dressings while we pack it all off. And then we'll come back and inspect the final cavity. And we might even trim the middle turbinate here. How easy is that?
Yeah.
Who wants to be in there with
fantastic.
a 70 scope, right?
Yeah.
Oh my gosh. So painful. So painful. You know? And I thought maybe my lip was bigger than I thought. It's not much though. It's just a tiny bit of a lip.
Mm-hmm.
Big wash. Okay, let's pack that off. And then we'll make our dressings. And I'll show you what we do to dress all of this. Okay. Give me a frontal curette. 60. Another patty, thanks. There's a couple little things I need to do. After this, we'll put a 90 shaver on. There's some really thick polypoid tissue in there. A little bit of a ridge there. Not crazy about that. And then here we go. And we'll show you how we finish it up here. Okay, so a couple little things we're going to do here. So that looks really good. All right. Now see how there's a very thick polypoid structure in the maxillary sinus? In general, I leave minor things alone like that. But if you've got a lot of tissue remodeling, you know, it's asking a lot of medical therapy to resolve it. And it won't always resolve it. So I will very commonly, in people who have very, very thick polyp thickening, I'll get rid of it at the time of surgery with a... You can see how thickened some of this tissue is. You don't want to strip it, but just where it's really, really remodeled, it's undergone a lot of remodeling, it's good to get rid of it, because I think if you've got a very remodeled maxillary sinus cavity, Louise, it leads to getting mucus plugging and trapping.
Okay.
Yeah, because it's just weirdly uneven. You know, they've got these huge polyps. Why would mucus not get caught in there? So I'm always a bit worried about that. Okay, so let's make our dressings. Give me the silicone sheets. Cedric, do you want to come up the top here? Maybe focus something down here. I'm going to leave there just so you can see that'll point to where we need to be. So the first thing I'm going to do is give me a straight iris, thanks. Is I'm going to make some silicone sheets. Now, when I make silicone sheets for the nose, you have to remember the floor of the nose is much lower than the floor of the nasal vestibule, so they have to have that sort of shape to it. And then I'll make this up. I'm wanting to go right up and cover my septal swell body area. Okay, so that's what a septal splint looks like for me. And obviously, we've made 2 of them. Gillian speculum, thanks. Then we're going to make
Richard, on previous occasion, when we did a similar case, you had done a medial maxillectomy. So how do you decide about how wide you make your maxillary sinus androstomy? Yeah.
Yeah, in that case, I made a medial maxillectomy because the main area that was involved in the fungus was the maxilla. So, and she had a very deep maxilla. I rarely do a medial maxillectomy up front for people. It's Proline, thanks. You know, and antrostomy is such a big opening. For most people, it works really well. But if they've got a really big, deep maxillary sinus, and it's where the main fungal ball has collected, or in an AFS, it's the main area of fungus, then I will do something more aggressive for it, like a medial maxillectomy. Because getting rid of that fungal material is the key to getting AFRS right. Okay. So we're just using...
And the maxillary sinus mucosa, how would you treat the mucosa? Do you just clean all the fungal debris and allow the mucosa to sort of return to normal? Or do you do any sort of a reboot? Do you consider any reboot?
I didn't quite hear that, sorry. It's just
the
quality of the sound.
Sorry for my audio, Richard. But do you consider doing any reboot for a maxillary sinus mucosa?
Any what? What was that question? Any...
Reboot surgery for...
Do you consider doing a reboot surgery?
Oh, reboot. Oh, sorry, I didn't understand. Reboot. No, I don't strip mucosa ever.
Okay.
Yeah, no. I mean, I shave down the polypoid tissue. I love Thibaut and all the reboot theory, but to me, I actually think the difference between a reboot and a standard Australian sinus cavity is probably not a whole lot different. You know, I just don't think... you know, I don't think you need to strip the mucosa to achieve that, but you do have to remove the really thickened remodeling that's formed, no doubt about that. Let's take all the patties out. I think the reboot surgery, for people who want to give it a go, is a great idea, but if you ask me, what does it really achieve, Ashok? It forces people to do a full cavity. And I just don't think people are honest enough that most people don't do a complete cavity. They rarely get this sort of view where you can see the entire orbital axis from corner pocket to the very front, the skull base all the way at the top, and each ridge coming off and going down onto the turbinates, where we've preserved the superior turbinate, we've preserved the middle turbinate, and we can see, you know, all of the, and I'll take out my patty up here in a moment, and you can see the whole frontal, the whole limits of the frontal. Now, I will, in him, trim the bottom edge of the middle turbinate. And for most people in which I'm making it what I call a neo-sinus cavity, I will do this because I think it facilitates access. And if you said to me, what's the level at which we trim? I trim it at the level of where I've cut the superior meatus really low, and that bottom edge comes off. Can you see that section? Let's go straight shaver. Thanks. And we'll just bipolar the stump here. So I'm really not taking height off the middle turbinate any higher than where the superior turbinate was cut, but I like to trim that because I've got to absolutely make sure. I've met AFRS patients over the years where I've had them perfectly stable for years and years and years, and then they've had a cold and they get a flare, and they get a funny plug in their sinus cavity. And I'm sure anyone who's looked after AFRS patients will know this over time. And actually, one of the things you can have is just make sure you've got a sinus cavity that you can look after in the clinic. Can I have a Blakesy, thanks? Because if you do, then you can salvage them in the clinic. You know, you can just get in there, suck out a mucus plug and get them back to normal. By the way, if people go from normal to having those flares all the time, that's the group of patients in which I do fungal immunotherapy. So if they really go back to completely normal and they spend time in normal and then all of a sudden they get a flare, let's go up, Blakesy, thanks, and they just go in and out of that state a few times, then I'll give them fungal immunotherapy. But pretty much most of these patients get dust mite immunotherapy. I'll put the drill back on, thanks. Because they're highly allergic, and actually just putting them on dust mite immunotherapy is usually enough. Let's have a look at this frontal now, right? It was really sort of had that hyperplasticky mucosal look before. Look at that. So you can see the anterior wall of the frontal sinus. You got a good view of that on your end?
Yes, yeah. Very good.
We do.
What is this thing? Actually, put the I'll give you this tissue to send off. And I know it looks like
So somebody comes to your clinic, Richard. Sorry.
I was going to say, I know it looks like I've just got it is at a bit of a reach putting that straight instrument right at the apex of the frontal sinus. You could see me sort of reaching for that tissue, but I was struggling a little bit because I was hitting the chest. So it gives you an idea of the angulation that we have there. Okay, give me the silicon sheets. Yeah, that can go with the right sinus. Give me the silicon sheets, give me packing forceps. Yeah, go for it. What were you going to say, Louise?
Yeah, so when the patient comes to your clinic for the first time, endoscopic examination, do they have skin prick tests at the same sitting?
100%. They get it up front first time round they see me.
Now, and then what about, sorry.
You know, I was going to say, in people who don't see just rhinology, that might be a little bit trickier to institute. But if you've got a rhinologic really only practice, you know, you can almost make a case, unless someone's coming to see you with a forehead osteoma or something, you can really make a case to do an allergy test on everyone. So people get an allergy test and they get a pre-decongestion rhinomanometry beforehand.
Okay.
We got some fascinating stuff coming out in the research pipeline on AI image regression analysis of rhinomanometry.
Oh, fantastic!
Yeah, to show you that rhinomanometry, there's so much data in rhinomanometry that we're not really exploring. The rhinomanometry can predict someone's nasal symptom score from a SNOT-22 with like 85% accuracy. Really quite amazing. So
that's amazing.
Exciting data. So, you know, because we use such simple concepts from rhinomanometry, just use it a single number. And really there's so much more to talk about, I think. So here's our silicon sheets. You can see that shape on how I've made the floor lower than the bit that sits in the vestibule. You can appreciate that's a really important tip. Okay,
it curves up.
Give me the Proline. And you were Millen asking me a question before, Louise?
Yeah, so then do they have a scan same day, a cone beam CT scan, or do you send them for a sort of formal CT sinuses?
I have a cone beam CT scanner in my rooms. And so everyone gets allergy testing, rhinomanometry, and a cone beam. If all of them are indicated, they'll get it all as one visit. And you know what? Having all of that there has really changed my diagnostic acumen on sorting out people who don't have sinus disease and are complaining of pressure and pain because of things like the scanner. It's helped me sort out who's really blocked and who's complaining of congestion, where when the patient uses the term congestion, they're really talking about other things other than nasal blockage, heaviness in the face, mucus symptoms, you know, because you can see it in rhinomanometry. There's so many fantastic things. And then like this young boy here, where he's not like the barn door AFRS in terms of how it looks inside, because he's been heavily infected with Staph aureus, but you know that he is because you can see fungal sensitization, put it together with everything. So this is, you know, having all those tools really makes a difference. And I think I really do look back on, you know, my practice when I was, you know, a trainee on how little we knew about the patient, and then they'd go away with some sort of treatment and come back. And And even if you're an
Yes.
amazing doctor, it's so hard to remember the patient's situation and story perfectly when they come back. And, you know, I really do think having it all there at the time of surgery is so critical. Let's go the fluid, thanks, now. So here we go here. So you can see this sitting in there. I'm just going to, the Miracell's very stiff, so I'm going to wet it. I just wet it with whatever local I've got left over. And we'll stuff it into the sinus cavity now. So it's going to sit all the way in there. See, you thought it was too big before, didn't you? Give me a kerosene. I just still think there's like I don't like this little bit of bone. It's been annoying me.
What about things like nasal pore?
I'll use Nasopore in our case.
The absorbable dressings.
I've just never been happy. More Killian speculum, thanks. Or actually, maybe I'll do it with this. I've just never been happy with absorbing dressings. I use them in a pituitary surgery, but really not in FES surgery where I need to really make sure my middle turbinate sits nicely. Now, I mean, I think we could all achieve a similar thing. If you wanted to do a pexi suture and things and then put dissolving sutures in, I'm sure there's lots of formulas that can achieve the same thing. But in my hands, I like the sort of Miracell glove, the finger cot. It just keeps everything moist. It's got a bit of rigidity to it. I don't think patients are any more or less comfortable if you put Posicept or Miragel versus a finger in there. Okay, so here we're going to see us finish off. So give me our graphs, thanks. What's the best one?
And how long do you keep these packs?
Say it again.
How long will you be keeping these packs?
7 to 14 days.
Okay.
7 to 14 days for the dress. I'll probably take this out next week, like about 9 days out. A little bit depends on when my clinic and the operating day is. And then, so let's roll that here. Let me just focus. Give me a up Blakeslee, thanks. You can see, by the time I put everything back, you get very good mucosal coverage of everything. Very, very close. Give me the other graph, thanks. Yep. I'll use it. And I'll take the gel here. So I like to use these graphs. It's amazing how well these take. I can't tell you. You think that they just all come loose and not work, but it's amazing. They really do take very, very well. We're almost done. We'll have one last little look here. Hemostasis looks good. Anything else? Last chance, guys. Anything else you think we should be doing? I think we've bipolared the septum.
Looks good.
That's very good. Yeah.
Bipolared the middle turbinate stump. We got the tissue out of the maxillary sinus. I'll go another pure region, guys. I might put some. He's got a reasonably big frontal actually on that side. And now with this thing here, you can see I'm just desperately trying to make sure I don't move my graft. That's all the fluid that I use when I... Give me the pure region. I'll use that one. No, that one fine. So I don't like leaving a lot of this tissue is going to be a little bit exposed to, dryness and crusting. So I'll cover it with gel as best I can. And sometimes I'll put Doyle spaces in as well. In this person, I'm not going to. I'm going to leave some gel on that turbinate. I'll probably regret that, Cedric. And then finally, bit of perfection. See if we can make it really good. Done. Amazing. Give us.
That's
I'm happy to have a
great.
chat about it, but we'll get this gentleman off the table, and we'll get our next case ready. And I look back on that case. You could have made a case for doing his septal swell body, the bony part. The high septum might have been a little bit deviated to the left-hand side, but it's not really affecting his symptomatology at the moment, and it's very subtle. And I think what we've done will give him a nice outcome.
Thank you. That's really interesting. So, a great case again. That's a very different technique.
Yes.
So, variety of techniques that we saw over the last 3 days. And that really makes it very, very interesting. So how do you approach the frontal sinus? How do you find
That's
the frontal
it.
recess?
Yes.
Yeah. And the simple things like septal swell body, dealing with the septal swell body. That's certainly new for me.
For me as well, actually. And also, it was quite remarkable how much the septal swell body came down. You just realised how congested the mucosa was when he took it down. Yes. And
I mean, often, as Richard said, that you end up doing a limited septoplasty or something like that to improve that area. But just getting that septal swell body down. And if you notice that he didn't really go right up to the bone level or the cartilage level, he stopped short at the perichondrium level. I think that's very, very important. And that just keeps that base there intact for the mucosa to grow again, so regenerate. And again, you need to be really judicious, very careful in that area, because you can easily cause septal perforations if you're not very careful. So that's something new.
I think
even
seeing
the turbinate
the
technique was good.
The approach to the frontal as well with the 0 degree scope, which I know we've seen obviously from Richard before, which is fantastic, but just the Caroline's window technique, taking the flap down, very similar to the DCR flap that we saw yesterday as well, but also just how quick it is, and then the access that you got into that frontal sinus afterwards and the cavity that was left. And it's quite nice to see that in contrast to Jim yesterday, who did most of the work with the 70 degree scope.
Yeah, correct. But towards the end, he achieved a probably very similar outcome after doing the lothrop.
That's right,
nice wide cavity. But it's a very different way of doing it. Here, you have always wide access in front of you, and all work with the 0 degree, which Richard finds very comfortable.
Yes.
It's really about the surgeons, what their techniques and what they're used to. I mean, on the day one, we saw Dr. Satish Jain. He has this technique of just staying close to the anterior wall of the frontal sinus, the frontal beak. So he goes looking for the beak, staying to the beak, and just finding the recess just behind the beak. I mean, the same technique that PJ describes into the hand on the wall technique. So you always stay close to the frontal beak, and then you land into the frontal recess. So similarly, this Caroline window technique,
just go straight to
you have a wide approach, and you just get into that area. And rather than seeking the frontal recess or looking for it, he lands into it. with this
Yes,
approach.
yes. And you know you're safe, you know you've identified your first olfactory neuron, you know that you're underneath the nasal bone, so you know that you're not going to inadvertently go into the skull base. And again, I think, that was a difficult case. There was lots of inflamed tissue. It was difficult making out the anatomy. So for people that are not doing a huge amount, or they haven't yet done a huge amount of really bad inflammatory disease, again, these expert surgeons, make it look quite straightforward, but these are very difficult cases. A lot of the normal anatomy has gone, so it just highlights the importance of having a structured approach. So opening the middle meatus widely so that you can see the orbital floor, opening up the sphenoid, and then when you have those two pieces of anatomy, it becomes more straightforward to deal with the inflamed tissue in between.
Yeah, true. I mean, it's really knowing all these techniques and then working out what suits you best. I mean, often it is probably the most ideal to have all these techniques under your belt. And then depending on that particular clinical situation, you can adapt to it. Because every technique has a place. And there will be situations, depending on the pathology, the patient's anatomical variations, there will be a place for these techniques.
Yes.
Yeah, again, the turbinate technique was very good. I mean, you had a mucosa intact bilaterally on both sides. And I can see straight away that the healing will be much easier without much of crusting. Yeah, so again, it's coming back with the second case now, endoscopic pituitary surgery. Although on our first day, which is a center of excellence, we have seen extensive skull-based procedures. Then we've seen Dan Pravidello doing craniopharyngioma. So this specific pituitary surgery, we haven't had it for a while on GRN. So
it'll be nice to
that's
see.
another nice to see that, and nice to see Richard's technique on that. Yeah. So this is a great start for our day 3, and we'll be going through the night here in the UK, the morning in Sydney, Australia. We're staying with Professor Richard Harvey with a variety of surgeries and learning all these little techniques from him. So this event was really not possible without our supporters, which was Medtronic and Karl Storz. So we're really thankful to them for bringing this event and making it possible. So as a break, we'll be visiting their product information videos, and they'll be right back. Thank you.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more. Do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. Propel Mini is placed in the frontal sinus. Its spring-like design props open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. In the Progress Mini randomized clinical study, Propel Mini demonstrated a significant reduction in the occurrence of frontal occlusion or restenosis and need for additional surgical interventions. The Propel family of products allows patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes. The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour Delivery System has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, and especially in patients with severe polyps and Samter striate. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more. Do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. Propel Mini is placed in the frontal sinus. Its spring-like design props open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. In the Progress Mini randomized clinical study, Propel Mini demonstrated a significant reduction in the occurrence of frontal occlusion or restenosis and need for additional surgical interventions. The Propel family of products allows patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes. The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour Delivery System has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and samtostroid. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more. Do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't. With Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. Propel Mini is placed in the frontal sinus. Its spring-like design props open the sinus while delivering mometasone.
Hello. Hi, Luis.
Hi, Ashok.
Hi. So we're back in the studio. So we just had a fantastic first case about allergic fungal sinusitis, where Richard demonstrated his signature technique of Caroline's window. So we are with Professor Richard Harvey in Sydney. And we are really getting ready for the second case now, which is endoscopic pituitary surgery. So as I mentioned, Luis, that after a while we're having this pituitary surgery. Before this, I think Christos Eogalas from Athens, he had demonstrated, Mark Tufik from Canada. And of course, we had skull-based day recently, where we had seen advanced skull-based procedures. But this is Richard and his colleague neurosurgeon, they're joining, and really looking forward to learn and see how he does pituitaries.
Yes, definitely, because I've not seen Richard doing a pituitary previously, so I'm looking forward to seeing it.
Correct. And what is your pituitary practice like, Luis? How do you kind of do it? Do you do pituitaries with the neurosurgeon, or some of the pituitaries you do on your own?
So I don't do any pituitaries on my own as shock. So all the pituitaries that we do are done in combination with the neurosurgeons. They will do some of the straightforward pituitary cases themselves, but we are very keen to do as many cases as possible together, because I think you need to be able to build up that relationship for the more straightforward cases, so that when you then have the expanded approaches for the more complex, so the meningiomas, the craniopharyngiomas, you work well together. So I think you do need to practice working together as a team with the four-handed technique with the more straightforward cases, albeit the logistics mean that we can't always do the straightforward cases together.
Yeah, absolutely. And what is your standard technique like? Other thing that comes to mind is a nasoseptal flap. I mean, there is a practice that
Yes.
some surgeons develop the nasoseptal flap as a standard, deposit in the postnasal space, and if required, they use it. If not, then they put it back.
Yes.
But is that something you do, or
Yeah.
what is your practice?
Again, it will depend on the pathology and the size of the defect that we will be expecting. So we tend to raise the nasoseptal flap at the end of the procedure, because then you know the size of the defect, and so you can plan it out. Because often if you take it at the beginning, although that's easier to raise the flap at the beginning of the procedure, it sometimes just isn't quite the right size or the right shape. So perhaps it can be a bit too narrow at the pedicle, where you sometimes in that clival region want that broader part of the flap. So our practice is that we tend to do it at the end of the procedure. The only issue with that is it can be more difficult. You end up with quite a bit of congestion in the nasal cavity by that point, so it can be more difficult to raise the flap. We don't raise flaps for standard pituitaries. When I started doing pituitary surgery, we raised flaps and we used flaps for almost all cases, but we also used lumbar drains. So going back sort of 6-7 years ago in the west of Scotland. But we quite quickly reviewed our practice and stopped doing that, because we realised that that was excessive and it was not required. And I think that's what's important, whatever your practice is. I think it's important that every 6 months or 12 months you review your own practice. You look at your CSF leak rate, you look at what you're doing, and you question what you're doing. Because as soon as you put a lumbar drain in, for example, you're increasing the risk of meningitis from complications of the lumbar drain. So I think it's really important that whatever you do, it has a purpose, but that you review your practice.
Yeah, true. I mean, it's really, I personally feel it's a bit excessive raising the flap for each and every pituitary cases, and then not required to replace it back. But however, it's also very important to preserve the pedicles. And when you're making those cuts for posterior septectomy, so making sure that the pedicle is not damaged, and then elevating the flap downwards when you're reducing the sphenoid floor, when you're dealing with the sort of the sphenoid kill area, and reducing that to further down. So that's an important technique. Again, how far laterally you go. I mean, you go laterally as much as possible, as much as you need.
Yeah, exactly. For a standard pituitary, you can work down that sort of transnasal corridor and approach the sphenoid os, preserve your superior turbinate. But if you have disease in the cavernous sinus, for example, and there's going to be cavernous sinus dissection, you're going to have much more lateral dissection. That will also have an impact on your flap, because if you have a chordoma or chondrosarcoma, for example, and you need to do a significant clival dissection, then you won't be able to preserve the flap.
That's good.
So you need to radiation. I'll tuck it into the maxillary sinus, because again, you're going to be working down in towards your nasopharynx. So yes, I think you need to think about the access that's required, and then plan your reconstruction accordingly. So you definitely need to be making a plan for your reconstruction before you start operating.
We've got to move her across to me.
That's so true. And do you always use a mononostril or a binaural approach?
So in general, we would use both nostrils, yes. So we use both nasal cavities. It would be very, very unusual for us just to use a uninasal approach.
Yes, I think, as I said, some of the very straightforward standard, one may consider using a mononostril approach, but the binostril approach, that's really the standard of care to surgeons. The forehand technique, that's really, really helpful in that. And again, you may not need that in every standard pituitary, but working together and doing more cases together, that really helps when you're really required to be together. And that is those complex cases.
And I think inevitably the cases that we do together with the neurosurgeons do tend to be the more complex cases. So you need that bilateral access. You're often dissecting more laterally. You're sometimes as well coming from a kind of contralateral maxillary sinus, combining it with a Caldwell-Luck approach as well. So, there's the way that we approach the skull base is expanding year on year with all the different corridors that are used. We'll see the transorbital approach later, I think this morning or tonight, depending on where we are. But yes, I think utilising all these different corridors is excellent, and you need to then plan your approach. For example, if you're coming across from the contralateral maxillary sinus, you need to make sure that your middle turbinate is not in the way, because you make a nice opening into the front of the antrum, and then you can't see because your middle turbinate is there. So you need to go back into the nose and then ensure that you've resected the middle turbinate. So,
bit better.
Yeah, I think individual plans depending on the access that's required.
Yeah, very true. I think middle turbinate is also key for visualization. Yes,
Louise, can you hear me?
Yes, we can hear you. So we're just talking about different techniques, Richard, about endoscopic pituitary surgery. And we look forward to see your technique today and know how you do it and what is your practice like. So that's Professor Richard Harvey joining us from Sydney, Australia for his second case of the day. This is the third day of the live surgery event, GR-ESS 2025. And first case was about the allergic fungal sinusitis. He did his signature Caroline's window technique, fantastic technique that showed us a great approach to the frontal sinus and how to deal with that case. So second case, endoscopic pituitary surgery. So can you tell us more about this case, Richard?
Yeah, so this lady is a lady who has a relatively large, I'll leave the screen up here, you can see a relatively large pituitary tumour. She's getting a little bit of optic chiasm distension, not much though, and I think mostly her visual fields are mostly intact, maybe just on objective visual field assessment does she only have subtle changes. She's got a small rim of normal pituitary at the top of her tumour here, and you can almost see it here on this axial. You can see the normal gland and stalk stuck up at the very top here. That's that thin rim. It really is a tumour that occupies the full width of the sellar. It's a little bit expanded, and really when it comes to the approach, we do something like 80 to 100 pituitary surgeries every year here at St Vincent's, and we really have a very, very standardized approach, and we'll talk about getting access there. We raise a little modified septal flap. We'll talk about this, Ashok and Louise. But for me as a surgeon, there's not many things I need to know before the surgery. How well pneumatized the sphenoid doesn't really make a difference for me. I'll always drill out and see all the anatomy anyway. But the most important anatomy we'll find is the vertical paraclival carotid. So here on a T2, and as we go back here, go back in the other direction, the paraclival carotids, or you can see the parasellar carotid here, the cavernous carotid, but these paraclival carotids, can you see the sort of flow void created by the vertical sticks here, guys? So the tumor is absolutely right up against the paraclival carotid, and the paraclival carotid is your landmark to the cavernous sinus, and it's the only thing you can't damage. there's so many things. If you're a little bit rough with the mucosa, it all heals. There's things in the sinus that make no difference. If you damage the skull base, you can repair it. You just can't damage the paraclival carotid. Just like an ear surgeon, you can't damage the facial nerve. So therefore, that's the thing we're going to find. And so all our surgery is about finding the paraclival carotid. And so we've got the patient. We're going to set up the patient exactly as the same as the last case. It gets the same injection, same preparation, everything else. And so I'm going to go and scrub, and you'll have an endoscopic view here in a moment. But do you have any questions before we get going here?
Richard, will you pin this patient?
No, I don't use pins for most of my skull base surgery. There's very rare occasions that I'll put people in pins. Neurosurgeons love that. It's totally unnecessary. Yeah, like only occasion if I'm doing really deep petrous apex approaches, will I pin someone to because I'm really almost mobilizing their carotid and things like that. But really, everyone else, we don't do pins and things like that. Okay, so yeah, head ring again, and let's go and get started. Mel, are you good to get going? All right, awesome.
Ashok, I couldn't hear you then. I could hear Louise, but not you. Ashok, I could hear Louise, but I couldn't hear you.
Yeah. Ashok, I actually couldn't hear you either on that occasion.
Okay, I'm back in the room. Sorry if I missed anything. So same story, TXA is given IV, beds at 15 to 30 degrees. We drape and prep in the same way. We'll even use that same cocktail, the 10 mils of 8 mils of Narrapin 1%, 1 mil of 1 in 10,000 adrenaline, and 100 milligrams of tranexamic acid. Martine, can I get a head lift when you get a chance? Thanks very much. And of course, in the changeover time, our anaesthetist has already done an art line, set up the patient, gone to sleep. Martine's been very efficient, as she always is. And so all of that's happened in the changeover period. And we obviously put a catheter in. Patients go to ICU. I think a lot of standard pituitaries could go to like an HDU environment. Here at our hospital, we really don't have a huge interim HDU. It's really ICU or the general ward. So our patients go to ICU. And a lot of that is about monitoring for things like diabetes insipidus and other changes that happen.
And Richard, what about things like lumbar drains? So would you say, for example, if it's a kind of larger craniopharyngioma or something like that, would you put a lumbar drain in up front?
No, I almost never use lumbar drains.
No.
I only use them when I'm doing open craniofacial work and we're taking out huge parts of the skull base and orbit. So we're doing free flap repairs and things where, the defect is super complicated. There's no such thing as like a simple defect, and you really got a patient where you've got soft tissue against soft tissue creating, your seal between your cranial cavity. I put lumbar drains in when I'm repairing CSF leaks in people with IIH, but we don't actually use it as a drainage. We use it to monitor intracranial pressure.
The pressures.
And to see after we close the defect, how high the intracranial pressure goes in the first 24 hours after surgery. And if it goes super, super high, it allows you to know that you've got someone with very high ICPs, and you can intervene medically. If they get even symptomatic from it, then you can do things such as open the drain and allow it to drain off. but it's less about the repair and more about managing their underlying condition. Okay, so I reckon the start of this is going to be interesting. So can we go to the endoscopic view? Have you got a view now through the endoscope? Yeah, fantastic.
Yes.
How about you guys? Can you guys see that okay?
Yes, we can see that.
Yeah, so Mel's setting up nicely here. Every time we do surgery, we always do it on the same side. You know, one of the things I used to see a lot in this sort of surgery is that people would alter the side they were doing the surgery on all the time, you know, somewhat because of the anatomy. I really don't think that's a good idea. I really think it's good to do the same side every single time, because it makes it very consistent for your colleague and your neurosurgeon you're working with, right? They will, and Mel, can I swap back to a 25 gauge now? If you do it different sides every time, it's sort of weird for your colleague. They come in and the scope's down the left nostril rather than the right. My goal when I work with my colleague is to make it so simple for them that when they come in, every case looks identical. There's just a pituitary hanging in the breeze in the distance. Nothing looks abnormal. It just looks like every sphenoid sort of looks the same. And the reason we do that is just really for consistency, you know, so that all the movements are the same, where we're used to having instruments, various other things. This is really important about consistency, because really for skull-based surgeons, pituitaries are our tonsillectomy, you know, and it really is about making sure it's really straightforward. So this is what we're going to do. So you can see I'm injecting the septum, the back of the nose. Managed to prang an artery injecting. Great. We'll see how this all goes here in a moment. And now this is really important, because I'm about to, exactly like I did before, I injected under anesthesia. I'll go patting on a Blakesley, thanks. And now one of the first things I'll do, everything's now bleeding because I just injected, and I've created a little bit of, you know, tachycardia, is I'll go up and find, you can see that superior meatus in the distance. So you can see the superior meatus. I'm just going to fracture that out there. And then I'm going to out fracture the inferior turbinate. So I make a little fracture along the apex, and then hopefully it'll move across without me breaking the lateral mucosa. There you go. And I'll do the same here on this side. Fracture the... Yeah, for those who can't see what I'm doing, I should show it, shouldn't I, Louise? Because I think a lot of trainees perhaps don't understand. So what I'm doing is I'm just breaking...
Yeah, absolutely. I'm
breaking that apex. And I'm breaking the apex so that when I do go to move my my inferior turbinate laterally, I'm not breaking the mucosa. See that? So, you know, the last thing you want to do is just put your forceps in there and fracture it all out. I mean, that's not great. That's very rough when you do that, and then you just get a bleeding surface medially. Just ruin your surgical field. So if you're gonna make things bleed, make them outside of the area. And you can see this patty here. This patty's disappearing up into that superior meatus area.
Do you use any prep within the nose for these patients?
Any what?
Any prep, like a surgical prep?
No.
Like dilute betadine or anything like that?
No. Nope.
No.
Nope. The only people I use prep for is open rhinoplasty work. And open craniofacials. You know, because often we're accessing others.
Kind of bigger open.
Okay. So let's go and check everything. So we've got all the same instruments out, exactly the same as last time. Let's go artery clip, thanks. Let's go timeout, guys. You do our timeout. Do you have a little pouch? I'll go silastic sheets. Okay, thank you very much. Okay, so let's get going. Now, pituitary approach, you got to make it quick. You can't spend 2 hours on the approach, in my opinion. It's got to be like 30 or 40 minutes. Yes, ma'am. And so it's got to be relatively straightforward. Now, we've spent a bit of time there just injecting. I made everything bleed. And that's why it's great to do a timeout. We sort of then checked all the instruments. Yeah. And then I can always tell when the anesthetic screen's turned away from me. I know that it's numbers that I don't like. So she's a little bit tachycardic still. And so do you want to show us our little silicon sheets? I mean, I do acknowledge, Martine, that I'm to blame for that tachycardia by injecting. So I've cut the sheets exactly the same way again. I don't know if you can see that, that shape.
Yes.
Yeah.
With almost like a tail.
It's and that sits up in the vestibule. This sits down on the nasal floor, and hopefully we'll use the rest of it to protect the olfactory cleft. This is where we do use nasopore. So we do a transnasal, obviously, approach for pituitary surgery, something like this, and we'll stuff the whole sphenoid full of nasopore. I like it. I think it holds my little modified flap in the right place and everything. And what else can I talk about while the heart rate's coming down? So I was just saying
what was the...
keeping it consistent, doing the same approach where, the cameras and instruments are going to be down the same side. And if the anatomy for some reason is unfavorable for that, septal deviations, different sizes to the sphenoid development and pneumatization, I just modify it all. I don't let all of that then suddenly change the whole team's approach to the case. What were you going to say, Louise?
I was going to ask, did COVID have an impact on your endoscopic transnasal work?
No.
Because so in the UK, the British Society of Neurosurgeons came out and said, with a statement that said all endoscopic pituitary work or endoscopic skull-based work had to stop, and it could only be done with the microscope.
Really?
Yes, that kind of went on for about 6 to 8 weeks, and it didn't last long, thankfully, because everybody.
Have they backtracked on it?
Oh yeah, absolutely. They backtracked very quickly, but it was quite remarkable that this statement came out, and it made it difficult because we had to then apply to the medical directors of the trust in order to do the cases.
Yeah. Oh my gosh. Yeah.
Yeah.
That's like an example of a knee-jerk reaction without there being evidence to make the decision process. No, I mean 100%. I think my neurosurgeons I work with would have been up in arms. It would have been like asking them to do it suddenly with an old school microscope again would have been like asking me to do a FES with a headlight.
Yes,
would have been a disaster.
Yeah, thankfully, can you hear me, Richard? Yeah.
Yes.
Yeah. And thankfully, it didn't affect our center much, but that's the phase we went through. It was a very interesting phase. Now, my question was related like to know about acromegaly. Sometimes these patients can have a very edematous mucosa, they can bleed more. So that can become a bit of a challenge intranasally, isn't it? So do you have any suggestions for that, how you deal with it? Any different strategy that you adopt?
Look, I don't really think pituitary patients bleed any more than even the bad, I think Cushing's patients are the worst. And I think they represent a anesthetic headache for Martine's shaking her head, agreeing or nodding her head in agreement. And so they become very labile, Cushing's patients, getting blood pressure under control and things. I'm not convinced acromegalics in my experience are too bad.
Okay.
And in general, I think they do better than sinus patients because you're essentially working with normal mucosa, for most people. All right, we're going to get going. It's almost under 100, the heart rate. And Martine will normally have it perfect by the time the neurosurgeons arrived, of course. The poor sinus surgeon has to work with a slightly tachycardic field. But let's do it. I can just tell. One of my rules of thumb here, Louise, if you said to me, it's not just the heart rate I look at. I look at the injection sites. So you can see the little points where I've made injections.
Yes.
If they're still bleeding, then my general rule of thumb is that it's not ready. So let's go up, Kerrison, thanks. So if my injection points are still bleeding, then it's not ready. Let's go down on the suction, thanks, to 100.
We can see a good blanching though, where you inject
Here's
it.
my middle turbinate. Here's my superior turbinate. And now what I'm going to do is I'm going to do a little posterior ethmoidectomy through my superior meatus. So I'm going to tell you, there'll be a few different things you'll see here. Okay, so give me a shaver. So that's the first thing I'm going to do, is I'm going to see if I can make out. Is the suction down? Yeah. So you get stripping in a heartbeat, obviously, in pituitary surgery because everything's normal mucosa. So there's the, give me a curette then, thanks, and I'll point some things out for you. This is really important. I can't tell you, just doing this is so useful at starting the case. I know. Perfect, just in time, Martine. Okay, so here we are here, guys. Can you see this? That's the orbital wall over there. Can you see that?
Yes.
So that's orbital wall.
Yes.
That's skull base somewhere here. I might even give me a kerosene up. And sometimes I'll even open up this superior meatus a little bit higher. What I don't want to do is I don't want to come forward on it, right? I want to just go directly north. So I can now, I think I've got about a view about to where the top of the ethmoid will be. Give me a straight through cut. Now, next one is we're going to release the superior turbinate from the face of the sphenoid. Look how little I take. Curette. Kerosene. In we go. You don't have to see the opening. You can just feel it. And it doesn't matter if you go through, there's natural os, but I just run up, drop in, turn around 180 degrees, stretch down. Kerosene up. Now we go looking for the corner pocket, exactly the same as we did in FES. Okay, we'll take a little bit of that away. Let's go up through cut. Okay. Corner pocket. It's all the thing. It's the only thing I want to see. There's no joy down here. No dissection to be had down in the infromedial corner. You need to go up and find your corner pocket. Your corner pocket will tell you where the OCR, the orbital apex is. You can see here now. And you'll push it a little bit more. Give me a up through cut. Okay. Orbital apex, corner pocket somewhere here. Little bit behind a partition. So we're going to just straight through cut. Just complete the section here. Shaver. And now we're going to complete the spheno-posterior ethmoidectomy as a simple cavity. Because we've connected those cavities up together. There you go. Here's the ridge. Here's the ridge here. There's the orbital wall, which we found together. And don't you think, agree, guys? Really obvious sphenoethmoid cavity. There's OCR. Yeah, perfect, right? Okay, suction on max, please.
Yeah.
It's a very similar principle how we dealt with the anterethmoid and in the previous case.
Exactly, same anatomical principles. Yeah, 100%. And a little bit there, you know, we because it's normal mucosa, we're using a cheater's way, Ashok, of finding the orbital wall, right? We know we're going to find it easily in the posterior ethmoid, so we can sort of sneak in the superior meatus and find it that way. Like clearly, if there was a lot of disease, that would be problematic. But finding the orbital wall, suction on MAC, yeah. Let's go needlepoint diathermy. Finding it there is very important because actually in some patients, Louise, you know, the tumor is so big, it fills the entire sphenoid cavity, and you need some landmarks in the posterior ethmoid to even understand where you're going to be.
Where you are.
Yeah, you just don't even know because it's so full of tumor in a large expanded sphenoid involved tumor. Now, we're going to do this little modified flap. And it starts out here, above the inferior turbinate, on the vertical plate of the palatine bone. We're using our backup needle points, I can see. We didn't have any real ones. Don't go too close to the back edge of the septum. There's no bone there. There's the soft palate. Feel always where the soft palate junction is. And this is the part that's good for reconstruction, this bit here. And it's a modified flap, right? It's just a pituitary operation, so we only need to come to about there. Okay, suction, wipe, swap. Now, when we called it modified, it was really taking into account Rick Corral's idea of really preserving this olfactory strip. Can you see this? Can you see how this mucosa is very different to this mucosa down here? Don't you agree? You can almost make it out as different mucosa, right? It's got pale, it's thin. This bit below is very rugose and thick. And look where we are relative to the middle turbinate. Low, right?
Very low.
Low, Louise. Really low. Now, this is a bit of a trick. So when you get to here, the head of the turbinate, see how there's a swell body? We'll go vertically north now, as a direct vertical north, and then I'll just take the swell body off because it helps with the view. And I'll show you why here in a moment. But then we'll quickly go back.
I think your monopolar has a very nice angle to be able to do that, isn't it? It's very helpful for that.
It didn't come like that, Ashok. I finessed it with an artery forceps to give it the exact angle we wanted. Yeah, 100%. So here we go here. Just make sure it's really good to go all the way through. I think when you first start doing this, you don't really cut it properly. You're a bit nervous about going all the way through, and you just want to feel it. Okay, here we go. Let's go caudal dissector. So that's our flap. I'll just go through those landmarks again here. So we start on the pterygoid plate, come over the choana, not too close to the back edge, then onto the hard bone, then forward. We come really low and then go directly north to encompass the swell body. And I'll tell you why all of those cuts are made. Okay, we'll go here in a second. And you can see I'm just working around that little spur. So I'm going to raise that first. I'm going to always raise things posteriorly and inferiorly first, because they're the places that you'll get bleeding. Now, this is really important. You can see the sphenoid rostrum here, right? So whether we're making a modified flap or a full flap, you just go straight back and just dissect straight back to the sphenoid rostrum, right? So there we are there. There's sphenoid rostrum. This is the olfactory strip up here. And we'll just dissect this off. And now, I try not to tear my flap over crests and spurs, but in general, if you do, it's not a disaster, because the blood supply is running axial usually to your tear, but I try not to what I call trouser leg the flap. Trouser legging the flap is when you essentially create a tear on the edge of a crest like this. We'll see if I can do it. I heard Ben Blyer talk, and he was talking about working over the horizon. It's a very good concept. You know, you could see I stopped dissecting there for a moment because I couldn't quite see where I was, and I intentionally trimmed a bit of bone so I could get a dissector right on the bone again. Because 100% of the time, if you dissect and you can't see what you're dissecting or feel it, you'll tear. Okay, so that's all raised now. Give me a curved iris. So here's the top of my flap here. Now remember, it does a very sharp downturn now. Metzenbach. Caudal dissector. And there's my flap raised. Now, you can see how I didn't cut all the way through on the flap on the top side. That was intentional. You know, Louise, I wanted my flap to almost hang like a curtain from this top edge, so that it was easy to dissect. Now what I'll do is I'll take this smell-bearing olfactory strip and I'll intentionally fold it out of the way. And there's a couple of reasons. It's not just protecting it, it's great for hemostasis as well. So you've taken the fold edge and just fold it out of the way. Okay, now we've got this big thing here. Can I just put the drill on just very quickly? I'm going to drill this very quick, and then we'll cut through the other side. See how there's a big crest there? Now, if you just wanted to, take all the bone out and just remove everything, you could. But I like to actually leave a bit of the sort of thin bone and things intact, because if you're doing a flap like this, you got to remember that if you make a perforation on the other side, you end up getting a high risk of a perforation. You have to do things like leave some sort of collagen matrix or fascia in between to get it to heal well without perforating through. So just rather than just tearing it all off, you can see it's going to take a heartbeat here, and I'll have it all drilled down nice and thin. Okay, good. Let's go back to the shaver. And I'll go Blakeslee forceps, I got that. So I'll take out my patties on the other side now. Now, I worked with Aldo Stam in the mid-early 2000s, and I loved his approach to pituitary surgery. He did it somewhat transnasally, like through the septum, a transseptal transnasal approach. He used to have the camera down in between the layers of the septoplasty, really. But I love the way that he kept like a whole, let's go kerosene up. He kept a whole part of the nasal cavity intact. He just worked underneath it subperiosteally. And I liked it so much, I thought, look, whatever I do, I'm going to try to integrate that sort of technique to how I approach, pituitary disease. So when you see me do dissection now, we're going to expose the sphenoid rostrum here, but entirely from underneath. Can you see that?
Yes.
And now we're just, there's the rostrum here. And if there's any old school neurosurgeons, watching, they'll appreciate that's the view you get in a sublabial microscopic approach, right? Maybe all too recently for you, Louise, if you microscopically, right?
I know.
But I'm old enough to remember, don't worry. I'm old enough to remember that approach. Okay, give me coddle dissector. I'm leaving the sucker there just to show you it. Now, a really nice thing is that as you dissect over here, of course, you just drop into the sphenoid, down kerosene. And now you want to isolate this rostrum. So isolate it, come down, come down, come down. We're subperiosteal on this side because we've taken the flap off. Come down, come down. Kerosene up now. Now's time to take out my little patties. I need to see now that corner pocket, right? Because I want to understand where my skull base is. So now's the time to get rid of those things. I'm going to move my middle turbinate or my superior turbinate out horizontally so I can see my corner pocket. I can thin out the rostrum above, thin out the rostrum, give me heavy mayos. So Giorgio Frank mover right here. Out. Heavy Blakes. And out comes the rostrum. And this one here, once again, I used to work with a guy called Michael Besser and David Pohl. They used to do pituitaries together. And they used to always isolate the rostrum and put a giant forceps in and pull the whole thing out as one piece because it naturally does fracture at the palato-vaginal canal. And it is a whole lot quicker than sitting there trying to dissect. You see how that's just fracturing off now? It's almost cleaving at that level, at the palato-vaginal vessel. And whatever you can, it's just quick to do it now this way. Shavers back on, excellent. Go, good. And I'll show you here. You might actually see this. Oh, give me that Blakeslee back. Big bit of bone. You'll see it now. Suction on maximum if it's not. So there's that trough, right, from where the sphenoid rostrums come out at. Okay, so let's go big sucker. And now we just need to open up the face a little bit. And then what I'll do here for this is I'll make sure this goes all the way up. Now, I'll intentionally now bite, see how I'm biting everything, the full wall. Mucoperiosteal flap, front wall of the sphenoid, all in one go, because I just want to create a little window on this side. This will open up a door from the contralateral nostril. Give me a small Blake, so I've got a flake of bone or something there. You can see the OCR on the other side?
Yeah.
Just coming into view. But you sort of need to see it. And we'll even open up even more. Just a tiny bit of an opening. We might make a little septal branch or something bleed there. That's okay. Bipolar. Continue to mobilize that soft tissue off the front face of the sphenoid. You can see that little soft tissue going into the bone. That's the palato-vaginal nerve and artery, starting up there and ends up down the canal down here. Okay. I'm going to put a sucker now down the other side, and it's going to sit there now during the rest of the dissection. Big wash. Give him the shaver again. And I don't make much of a window, bipolar, thanks. I just need a little bit more. There you go, that's all. I just need enough to see, so when I've got my camera like this, I can see the other side. Let's go drill on now, thanks. Big wash. Fantastic. We'll just get this soft tissue off here. Can you see the bony wall just there? So my rule of thumb is you've got to be able to get a straight instrument down to the paraclival canal on both sides. So all of this needs to go. And it's getting this front face off is the key to getting easy access to the sphenoid. I will pick up the palato-vaginal nerve and artery, the artery in particular here. You can see it running in the bone. It's that soft tissue. It's not the vidian here running at 45 degrees. This is the palato-vaginal. There's a little vessel there. That's it there, that soft tissue against my drill now. Yeah. Getting rid of this intersinus partition is very useful. Blakesley, bipolar. You can see I've got a little vessel or something, one of the little septal branches at the very top edge of my flap. Good to bipolar that now while we can see it. Right now I'm leaving my sucker in that spot. You can see this is the palato-vaginal vessel in the bone. Big wash. Let's go back to the drill. I really like to make sure can we ask them that, just that, stop the conversation on the side. Just block there. You can see I've got a little, that palato-vaginal area is still bleeding. I'll come back to it here. But I might revisit it, the same vessel actually, so you'll see it bleed here in a moment. It's this soft tissue just there, Louise.
See that? And the drill that you're using, is that's different from
Same.
the drill that you were using earlier, is that right?
Yeah.
Or
Exactly the
yeah,
same.
this is exactly the same. So on the M5.
The M5, yeah, 100%. The M5 drill, same one as I used before. And you can see as we get into this bone, there'll be a bit of bleeding. Always is in that. And I always get rid of all the partitions. Big wash, just unblock that. We'll sort out that bleeding here in a moment. You can see it's somewhere between, it's really just venous ooze, really. A really important thing in skull-base surgery is not to stop all the time when there's a little bit of venous blood around. You know, you're best off to keep drilling until you reach a point where you see the next anatomical landmark, then stop and then move on to, then flow seal it at that point. And you can see I'm just looking to see where the sellar face is, so I can take all these off, no problems. Oh, I'm blocked again. I want to do a little bit more drilling of that partition. And of course, just the trabecular bone in this situation bleeds on you. And we have some thrombin gelatin foam. We use not flow seal, but SurgiFlow. We think it works really well. And we'll plug that in a second. But I don't want to do it until we're sort of there. Can you see that? It's just bleeding from that venous, that bit of bone. And I'll do the other side here in a moment. Yeah, okay, give me a little bit of SurgiFlow and a patty. It's going to ruin the day. Give me a patty on a Blakeslee. I'll thrombin it out, otherwise I wouldn't actually bother doing it if it wasn't for the live surgery, right? I just keep going. But it'll ruin pointing things out and watching things if I just battle on. So we'll just stuff a bit of SurgiFlow into that trabecular bone. Give that a second to work. Drop our sucker back into that little groove. We'll go and open up the other side now. So we'll leave that for now. Let's go and do the other side. So the same story here. We've got to get the bone off this face enough that'll allow us to get a straight instrument down the other side to the paraclival area. So all this space needs to go. You can see my palato-vaginal bleeding. Pulsating there. You can see the little blood vessel on my drill burr. Pulsating away. I hope that comes across in the detail of the video.
Yes, we can see that. Thank you.
Yeah, we'll sort it out in a second. But you'll always get that little palato-vaginal vessel. And as we get closer here, and as we get close to the sellar face and where the carotid will be, we'll stop. We'll get hemostasis, bipolar. Okay, big wash. Patty, take it out. Big wash. There you go. It's beginning to look like an operation now. Okay, so now I'm going to take off, we'll go to the shaver, thanks. And we're going to take off this mucosa just where we want it though. So I'm not a big fan of people who just strip the whole sphenoid out. Like, it takes a lot of bleeding when you do that. I really like to sort of control my mucosal removal, and as much as I can on the lateral walls, leave it intact. But you do have to remove some mucosa to do all the drilling. And you can see, look at me, look at the minute I become a stripper, Louise, I start creating bleeding. You know, it just goes to show how important it is to keep your mucosa intact if you want to have a nice surgical field. I really like using the shaver where you just loosely let the shaver bite the mucosa. Usually it won't strip the whole cavity out. You can control, you know, we need a good proportion of mucosa to be removed so we can get to everything. Okay, and there's just a little bit over here. Maybe it'll be all right. Okay, let's go back to the drill. So I'm going to take a bit more of this space and thin it down for us. She's in that same sort of head extended position. Maybe not absolutely extended, the head like when I do a frontal, but pretty extended still. You know, one of the really common things I see people do is they have their patient too flat, like the head's flat, and then when it comes to doing anything from about the posterior ethmoids onwards, they really struggle because they end up in a situation where they're hitting the chest with things like keratins and instruments like that. So, you know, really important, I think, to do head extension. It's the right orientation for the skull base. It's good for the ergonomics of the instruments and hands. You know, I was taught at a time of sinus surgery where people said things like, oh, you know, don't put the instruments too far in the nose, Louise. They used to say things like, don't extend the head. That'll just make you go to the skull base. I mean, that's like telling an ear surgeon, you know, position the head with the head angled away so you don't get through into the sigmoid. I mean, it's really, they're ridiculous concepts. You know, all that sort of thing. So somewhere in here, sadly, we've got this very thick partition right where our carotid's going to be. So that'll be interesting, actually. We're going to have to thin this out quite a lot, actually, and we'll find the carotid, and I'll show how we'll do this. So just creating a broad front here. There's a couple of ways in which I'll show finding the carotid. So I'll just flatten this all off, make it a flat surface. And when you strip the bone, the bleeding does settle down eventually, of course. I've still got this partition over here. Can you see this?
Yes, we can, yeah.
Really important to get this all flush. Before I use my keratin, I really get all these areas flat, because if you don't, it's very awkward to use a keratin, and you lose confidence that you don't know if you're taking too big a bite, you know, the shelf feels too solid. So it looks really good, and now we'll open an area.
So talking of the carotid, Richard, do you keep Doppler handy just in case?
Yeah, big wash, thanks. We do actually have a carotid Doppler when we do these cases. Keratin up. And now,
excuse me.
And you can see how we have this lovely view, and look at my you know, my camera, my instruments, nothing's clashing. And now we'll go and take off all the bone, and we'll find all the anatomy.
Good.
So very quickly get rid of all the bone just in the center of the sellar. Down, Kerrison. And then we'll go and find the paraclival carotids.
So did this patient present with visual disturbance? I know you had
No.
said that they had, no. Was it
No,
an
they
incidental?
they don't have any visual disturbance, but I think actually their visual feels slightly abnormal. There's a little bit of mucosa from the retroclavial recess. That's okay. Yeah, they haven't. You know, so it's big enough though. This lesion, even if if it was a non-functioning macroadenoma and it was discovered, once they start getting chiasm lift and they're a young person, you know, they're in for an operation. There's just no urgency. You know, they don't have to have visual changes to indicate an operation. The natural history of most macroadenomas is they'll continue to grow. Micros are a different story. So a lot of tumours that are less than 1 centimetre at presentation won't become so big that they require intervention. But if they've already shown, big wash, thanks, demonstrated growth to that size that we discussed, where they're a centimetre or more, then they're likely to need treatment. Kerrison up. It's all right. Do we have a neurosurgeon in the room? You just tell them we're not far away. Last chance to have their single origin Ethiopian, you know, espresso. Kerrison up. Yeah, and the heart rate's got to be perfect when they arrive in the room. Okay, we're still waiting. I've got to use the down. Keep going in the down. Coming up to where the paracellar is going to be, but I'll show you. We've had a Kerrison malfunction. Now this is really important here. I'm going to show you this here in a moment here. So can you see this? See this is the sellar floor? I want to go looking for where the paraclival carotid comes in. Oh, we got it. Fantastic. See there? See how there's no carotid there? Kerrison up?
Yeah.
But you're getting a hint of where the carotid comes in.
Coming in.
Over here. Because where the carotid comes in over here is the beginning of the cavernous. And I'll show you here in a second. Down, Kerrison, please, ma'am. Can you see that? Look at that.
Yes.
Can you see, does that come up clearly on the view? You can see this tunnel.
Yes. You can see it coming up. That's right. You can see down to the canal.
Oh. See that? That's the paraclival coming out of the bone from its canal. Yes? So once we know where that is, we can get rid of the rest of this bone. Sorry.
I think in this area, if you're going to use Kerrison, you, as Richard is demonstrating, you thin down the bone first. And then if you have to use a Kerrison, then you can. But it's best, safest is to use the drill and thin it down. Is that right, Richard?
Yeah, 100%. Use a lot of drilling, but the last little bit's done with a Kerrison. And Cedric can sort of make out the canal coming up. See how there's marrow here? Sorry, guys. You can see that. See how the marrow's here?
Yes.
Then we have
Yeah.
cortical bone over
Yeah.
here. That's
Yes.
the paraclival canal. That's the canal just there. See that white area?
Yeah.
So 100% certain. Let's go to the other side and do the same on the other side. But you can see it on the other side. It's a bit more obvious. We're almost there. Give me a kerosene up. Okay, what's happening there? I'm going to have to tweak her drapes there, just with another towel clip maybe. In a moment, kerosene up. And there's part of me when I do this approach, and as I get to the lateral margins here, I'm also thinking to myself, is anything, big wash, is anything getting in my way that would annoy my colleague, Dr. Yonka, down kerosene? You know, can I feel a ridge of bone hitting one of my instruments? These are the sort of things that I go looking out for. Let's have a look and see if we can see the paraclival canal coming in. There it is there. Can you see that?
Yes.
Yes. Yeah.
See how it's going down? Wonder if I can even display it even better for us. There it is there. Perfect. Give me a Blakesley. So once you know where that is, you'll now got a very good feeling about where you're going to find the rest of the anatomy. Kerosene up. So we still haven't found the sort of beginning of the cavernous sinus here, which we will in a moment. I can feel, so you can see I'm feeling something here. Got a bit of bone or something getting in my way. And that's not uncommon to really have to push the lateral exposure there. You can see we're almost heading up towards the orbit, Louise, you know, where we found the orbit, because in very well pneumatized or very well expanded cellars, because of big tumors, then the lateral limit is quite lateral. And this, of course, is the carotid siphon coming up here. Take off this last bit of blood. I left this to last, right? Because as I take off this bit and expose the superior intercavernous sinus, I might get a bit of bleeding. And if I'd done it early on, it would have been onto my field. So that whole idea about doing things inferior and posterior first. Big wash. You can see there's a bit of bone over that carotid. Kerosene up. Just the kerosene up. One we were using just for, yeah. Yeah, for all good, no worries.
Richard, would you do all this exposure for most of the pituitaries?
Everyone.
Okay.
Every single one.
So define the carotids and everything.
Yeah, 100%. Every single time. Hey, kerosene up. There is never ambiguity as to the limit of the dissection. And I really encourage all pituitary surgeons, especially those starting out, to do it every single time, because if you don't, and then the cases in which it's absolutely critical, they can't do it.
Yeah.
Yeah, because they're not used to sort of dissecting and feeling the bone up there. And you can see I've got little venous bleeding edges and stuff. And we're sort of right. I still think here, guys, there's a bit of bone. Kerosene up. It's just a little bit thick because it's becoming a partition. You can see I'm often letting go of the bone chunk. I want my gate to be clean when I take the bite. I don't want it to have bone already in it. Okay, and you'll see it now. We saw the blue coming up. You can see the blue there, laterally. Yeah, so that's the cavernous there. Big wash. I'll do a quick bipolar, and then we'll do a bit of surgery flow in the end. We're getting close though. It's blocked. I have to wait. It's blocked. You've got to do that first. 2 seconds, we'll just tidy it up. Now, bipolaring the dura is very useful. Tightens it all up, gives a bit of a nice ability to see what we're doing. Do we have a neurosurgeon? Fantastic. Bipolar down to 15, please. It's a big tumour, Ben. With sort of expanded carotids.
So you guys will be looking for any hint of superior and inferior intercavernous sinus?
We're going to thrombose some of the cavernous sinus, I think, here. We'll see that here in a second. Big wash. Give me a surgery. Give me a patty, a nice one. We've just got these little areas here just bleeding on us, so give me 2 seconds. I'm just going to get these looking pretty here in a moment. So normally I don't allow Dr. Yonka to see any blood in the sinus. It's all sorted by the time he comes in normally. Kerosene up. Perfect. We knew you'd come through. Curette, thanks. So just the shape of that bone over the carotid just makes it a little bit awkward to use a kerosene. Give me a patty. I'll put one patty in here in a moment. I know Ben's going to scrub in a second. I'll just do one little thing here. Oh, listen, let me just pack it off properly. We're done. It's good, Ben. I might have to get you just for the viewers just to point some anatomy out. No, I haven't thrombosed. I think both cavernous sinuses are pretty sort of probably packed laterally anyway. My colleague, Dr. Yonka, especially with tumours that are asymmetric or small, especially functional microadenomas, will very commonly thrombose the medial cavernous compartment next to the tumour, just because if you're doing especially micro work, you can get a lot of venous bleeding from the cavernous next to it. And it's nice if you proactively and preemptively thrombose that medial cavernous. I just don't think it's required here. It's a big tumour. Most of the medial cavernous is already compressed. I think it'd be just overkill. But if we get some venous bleeding here, Ben might have to do it. So. And the only thing I can say as I'm preparing for Dr. Yonka to take over, it's really important to work with a neurosurgeon who understands what's required in pituitary surgery, when to get a gross total resection, the importance of, complete surgery. There's a lot of patients, if they've got functional tumours, if you don't really get it all out, you haven't really advanced their cause very much. And endocrinologists are very aware of that. And so, I suggest anyone working out there, find a neurosurgeon who's, got a real commitment to doing pituitary work. And I don't think Ben does any spine work. Do you, Ben? Do you do any spine? Does no spine. He does cranial tumours, pituitary tumours, movement disorder, and trigeminal neuralgia and that sort of thing, decompression. Did I leave anything out? That's it. So you saw me put all those patties in, and you might think it's a bit overkill, but a little bit here, I intentionally do it just to make sure that, hold on one second, can I have this thing? She's just coming off her handrest here.
No, these patties just saline soaked patties, I take it.
Oh, no, they're adrenaline soaked. The same ones I used before.
Okay.
And I put them in there, yes, for hemostasis, but really compressing my surgery flow. But it's very much a target for Ben. I've been operating for 40 minutes, but Ben is just something coming in cold, and it takes even in really skilled surgeons, just a minute or two to get that depth perception, understand where your instruments are going, the orientation of the head, and just putting some patties in means that when he's doing this, it's the first thing he's doing is not putting the knife on dura without some sort of feel. Yeah, right. Yeah, so, carotid there, and I'll lift up just there, you can suck a bit of that surgery flow. You can see the carotid pulsating there, guys. So I've got the carotid exposed both sides, and then Ben will suck underneath this dura, and do you want to come underneath? Yeah, perfect. There it is there, canal. Yeah, it's a fair way apart. I've had to drill all this too. So we've got carotid canal here, carotid canal there. But this gives Ben then huge confidence about where the durotomy needs to be. Look at what's happening there. Let me get that out. You okay? How's the mobility? Good, yeah. So you can see where Ben's making his durotomy is perfect, right? He understands within millimeters. You can go straight down, yeah. A bit of flu. And it's got a little bit of a lake just there. Go on the edge of my thing. I think smiley it out. Yeah. Smiley it out into my thing. Yeah, perfect. And straight down now. So it's so important. The anatomy means that Ben understands exactly where he is, and he can really make that durotomy within a millimeter or so from where the structures are. Let's go large cups, man, or small cups. We send the dura off in every case. We do it intentionally to. I think the gland's mostly just the very apex. Yeah. I think the whole tumor is from side to side almost. Yeah. Yeah. And with a soft tumor like this, Ben's not going to attempt any sort of extracapsular dissection. That's really a concept for smaller tumors where it's really important for functional reasons to get a complete resection. And be very careful you don't leave microscopic disease behind. But we have lots of research going on, guys, so sadly Ben's not allowed to send it up the sucker. He has Anne McCormick, who's really an internationally recognized pituitary endocrinologist, who we have to keep all the tumour possible here. Might be a little bit attached to that, right?
Do you tend to use any ICG here?
Say it again. What's ICG?
The eye injection to delineate the
No.
normal pituitary or a tumor. Well, not as a routinely, but in certain cases.
Nope. No. Almost never.
Okay.
And really, in my opinion, it's only really aneurysmal work, isn't it? Like when did neurosurgeons use all of that? A large flat. Oh, you got me a selection here. See, as you can see, Ben didn't tug on that piece because there might be a thin pancake of a normal gland attached to the top. I'll lift it. Do you want me to lift it up for you? It was well picked, boss. I might come out with you. Yeah, and there you go, guys. Just goes to show how important it is. We saw that lateral extension in the pre-op images.
Yeah.
That if we hadn't made the gyrotomy even close to that, I mean, we'll be able to see it just, right? You can see the medial wall coming up just then. There's the medial wall of the cavernous.
Yeah.
Can you see that, Ashok? You got a good view of it?
Yes, nicely dissecting the tumor over it.
Yeah, peeling it away. So then Ben knows where he is there.
Yeah, it's a great angle as well, a great view. Thank you, Richard.
Yeah, and he's cleaning up that corner, corner between the floor and the medial cavernous.
And this all with a 0 degree, right? There's no angle
100%.
endoscope involved in it.
Same in the
That's
sinus
the beauty
surgery,
of the wide
Ashok.
exposure. Yeah.
If they can't see it, I just modify the anatomy so you can.
Yeah.
I got it. I'll hold it. Yeah, Ben's talking about sometimes when you have a big dumbbell above, you know, it's really important to clear all the low stuff first. You know the big 45? Might be easy to grab that. Bit of loose tumor on the normal gland there.
Yeah.
And we'll do a washout here at the end. This is, 100%. That's me, sorry. Look how Ben's defining the plane between the tumor and the normal gland. Superb. Yeah. Look at that. Perfect plane, boss.
Mm-hmm.
Perfect plane. I'm going to suction that thing up there. Yep. Beautiful. Let's have the wash ready, thanks. Getting very close. 1 o'clock over here. See how Ben can see the transition from the medial cavernous wall up to the roof, where there's a bit of normal gland on the roof. And just as Ben picked it, the normal gland is on the roof, but a little bit down in this right side. And in a moment, we'll do a washout, and it'll really show everything. And there'll be total conviction that we've got a complete resection. Looks pretty good, boss. Just while we're waiting, I'll take the bipolar forceps. Thanks, boss. No, it's okay. Good. ringers. Yeah, look at that. Really nice. Just allows us to have a look, guys, and make sure there's no loose tumor.
Yeah. It's quite like the idea of irrigation at the same time while dissecting. Yeah.
Yeah. So this side looks perfect. We'll have a quick look on the other side as well. I'm sure. You want to use peroxide? Yeah, we're going to do a bit more irrigation first. Just before you go in there, just let me bipolar. Suction, just that loose bit, yeah. And of course, we're inspecting Louise to make sure we can see how you can see the turn up there. You can see the medial cavernous wall become the roof. Very convincing. This is called the superior compartment up here. It's above that. That's the horizontal carotid. Can you see that? So the carotid comes up here, comes anteriorly here. That's the horizontal. I use Juan Carlos Fernandez Mirandez, whatever his name is. I forget. Forgive me if I got that wrong. His grading system for cavernous compartments, but that's horizontal carotid, superior compartment, sometimes referred to as the intersinus sulcus. Yeah. Yeah. Yeah, really clean, really clean. Great gland preservation team, and really clean. There might be a tiny little bit of venous thrombosis or venous sinus entering here. That's why there's a tiny bit of blood, but it's really nothing. And I'll show you when we reconstruct it, the flap will go right up into this area and will cover everything.
So what are you using for irrigation, Richard? Is it
yes, so that was just
cannula?
ringers. That's ringers, and now it's peroxide. So we peroxide out the cavity somewhere between tumolysis and hemostasis. Yeah, this is the goal. Yeah, not when there's open CSF, as Ben said. All right, let's come off.
And you're just holding that catheter with the forceps, is it?
Mm-hmm.
Okay.
You can go harder now. Wash the top side of that. Looks good. Should we give them one little view again of the... There you go.
All nice and clean.
They're all nice and clean. Carotid's obvious. This side's not as obvious, the carotid, because there's a bit of normal gland between us and the wall. Does that make sense? Yeah. But it looks really clean. Nice. I'll give you a call when we've got the next one. Okay, so give me a straight Blakesley, thanks. I'm just going to put that in there for a second, and I'll show you how we wrap up here, because I think this is very different. Martine, you got about 12 or 15 minutes. So here we are here now. Now, I've got this modified flap. In my opinion, it never goes back on the area. I'm just going to prepare a little area for it to go. Can I have a up Lakesy, please? So I'll strip a bit of the mucosa off here because my pedicle of my flap is going to run in this position. There you go.
So even if you don't have any CSF leak, you would line it with the flap, correct?
Yeah, I put the flap in because it helps with the healing and the repair of this area. I'm not a big fan of the whole rescue flap concept. I'm not, it doesn't really bode well with my philosophy. So I just raise this modified flap. And, you know, there might be a bit of micro CSF there, possibly. It's very small, so... Blakesley, thanks. My apologies. Give me a coddle. So this pedicle, my one tip to surgeons who are doing the occasional pituitary, do not run the pedicle in the retroclavial recess. It is not the quickest way to the sellar face. It's always quicker to do it along the lateral wall. And it's just a spatial orientation thing. I commonly see people put flaps in where they run up the retroclavial recess and the flap's really short. And Metzenbaum, we published a paper many years ago, and just one reviewer couldn't believe that a flap that was no more forward than the head of the middle turbinate could reach the sellar. And actually the reviewer asked us to produce a video. We produced a video, and then he thought we edited a part out, and he wanted us to include the edited video to show him exactly how it all went. It just goes to show that people develop very fixed ideas, like Ashok, like I can never see the vertex of the frontal with a 0-degree scope. You know, once you developed a fixed idea, you just don't believe it's possible. You know, and it's like doing this case. You said to me, you know, can you see the contralateral OCR without breaking the mucosa on the other side? Like you can. There are these things are possible, but they just require just thinking slightly outside the box. You know. So I actually think that looks pretty good. So you can see here, we're going to have. I might go one more. I might just put the patties in. I'm going to put the patties in once more, just to really compress the flap against the tissues. So I just want to make sure the flap is contouring my skull base nicely. You can see I've left this little free flap down here. I might take this out and put it back in again. Just leave it there, it won't be long. Let me put some patties out. So sometimes when there's a bit of ooze around and you've got the flap in place, it's nice just to put a patty in like this and just suck out all the blood, give it a chance to get hemostasis, and then I'll show you how we put everything back together. And you see my nicely folded olfactory cleft strip is slightly unfolding now after lots of irrigations and doing things, but it's sat pretty nicely the whole case, right? And it wasn't dripping blood onto us. It's well out of the way. We haven't made like a giant, you know, posterior septectomy and all sorts of things that some people do when they do pituitary surgery that I think is detrimental to smell in particular. You know, so I think, and you can see how good the access is here without pulling the whole septum and taking all the middle turbinates apart and everything. They just add to morbidity. And if you do 5 pituitaries a year, you won't see it. But if you do 100 a year, you see people who have these. There you go.
Yeah.
That looks very good. Very good.
Nice, yeah.
Yeah, and you see what I mean by the pedicle sitting in that spot? Really
Yes.
short. Lots of coverage, right? Right up to there, right up to here. Give me a nasopore. So this is when I do use nasopore.
You get that extra mobility of the pedicle by coming up over the posterior coena.
Yeah, and on that pterygoid plate, 100%.
Yes.
That's right, Louise. Yeah. By making this cut here, you're not making it. Some people make it at the 12 o'clock point in the coena.
Yes.
That's killing your options right there in terms of mobility.
When do you see this patient post-operatively? 2 weeks?
3 weeks. Yeah, 3 weeks.
3 weeks. Okay.
So you'll see. So I put nasopore in there. See how untouched this side is? Beautifully untouched, right? Then, my coddle. Yep. Okay, fold our olfactory strip down. Move our superior turbinate back. Almost like we were never there, right?
Yeah.
Maybe not quite. I'm going to leave that bit of bone there. Give me a packing forceps. This is what I got. Now, we'll put the silicone sheets in. Same shape as last time. Going right up into the olfactory cleft. So if you've had a hard tumour, Ben made that look super easy, but if you had a hard one and there are lots of instruments going back and forth in the nose, you know, you can often have a lot of adhesions up there, and if you don't look after the smell cleft, then it...
The sheet is very nice. It's very thin, because sometimes the sheet that commonly used, that at least I've seen, they're quite thicker sheets.
Yeah, I love silicone sheets. Silicone sheets primarily here to restore the olfactory cleft, because I've done all sorts of things to it. See there? See how it's sitting over the strip and the middle turbinate? Give me a suture. And I've got a couple of little things we'll do. It's important to suture them flat. You can't have the suture loose, right? You know, we're going to leave them in for 3 weeks until the re-epithelialization of all that area has occurred. You know, you can't be taking it out at a week. That's not going to work. Epithelialization of areas destined for secondary healing, Louise, takes longer than 7 days. So you've got to have your dressing in line with our science that we understand around wound repair. So we'll do this. And there's a couple of little extra steps we're going to do. You said to me, you know, what's the other little tricks? Straight iris things. What's the time there where you guys are? Is it midnight?
We are 1:30 a.m.
So we have one more pituitary. Do you want us to broadcast it, or are you done?
Yeah, what time are we starting?
Probably in about half an hour.
Half an hour, okay. Yeah, I mean,
you want to join us?
Pretty similar, right? What is the pathology?
And then here's the gel going in. So I just restore that area. I don't like the middle turbinate to be too lateralized. So you know, it's I'll fill that like that. And then here's the last little, you know, nuance, is that we've got a little bit of a raw area here from our flap harvest. And if you've got a bit of thrombin gelatin, I'll stick it under here. And smush it under all that raw area. See that? And it just helps, I think, with the ooze they get in you know, ICU and things like that, because we're not here. Can I have the dead space, please? That's my little graft. I'm going to put that back in. We're not.
And how long? Sorry.
We're not packing off the nose, so they'll lose like a sinus case a little bit.
How long do you keep them in for in general, just to really monitor urine output and some bloods, urine, kidney function?
It's mainly just looking for DI, you know.
Yeah.
DI is the main one. Occasionally a hematoma in the cellar. Not so common though. And so just one last little look here. Got a bit of thrombin gelatin covering everything. Looks good. This side looks good. We didn't manipulate this too much, this middle turb, but I'll leave a bit of gel here just in case. There you go. And we're done. We'll see you in half an hour.
Yeah, see you in half an hour. Great.
Fantastic.
Oh, good. Perfect.
Okay.
Can we put
Thank
some
you, Liz. That
Bactrin
was
oil in the
very
nostril?
nice to see that technique. So we'll get back in the studio.
Good. It's good to have a nice, straightforward tumour.
So what are the key things, Luis, you picked up from the technique?
So I think using the mini flap was excellent to see. Sort of modified that mobility, raising it up around the posterior choana, pterygoid plate. That really does give you an awful lot more mobility of the flap. And again, just this very similar approach to the sinus surgery, tranexamic acid, the nasal, the adrenaline-soaked neuropathies, taking the time to ensure that you have adequate vasoconstriction.
Yeah.
And the injection, like the sinus case with the tranexamic acid as well.
So very similar principle. I mean, I found it interesting that he went for posterior ethmoids as a first thing to begin with.
Yes.
And just on a very similar principle that he demonstrated on the previous case, how dealt with anterethmoid, lamina, and the middle turbinate skeletonized it and developed that corridor. So in a very similar way, developed that corridor for the posterior ethmoid corridor. So that's really gets you laterally. And then he went for the sphenoid. Usually we try to go to sphenoid directly and then
first
come laterally.
And work laterally, but actually he got that lateral access very quickly and really was flush with orbital apex. So there was no bone left really in the face of the sphenoid, which I think is really important for access.
Yeah, right. And if we went for the sphenoid first, that's the traditional technique followed. And then you go for the posterior ethmoid. So you're working against a little bit of an angle, isn't it? So while with this, you had everything end on, you could see the posterior ethmoid, everything defined, and then you go for the sphenoid. So that was a nice technique. Yeah.
I think what it really allowed as well was that preservation of the superior turbinate because he went through the superior meatus and got that lateral access early on. He was then able to just take that small amount of superior turbinate at the very inferior part and mobilize it up out of the way because he had the space to do that. Because I think that's often the issue. If you go straight for the sphenoid and then you're working laterally, the superior turbinate often gets unnecessarily damaged or resected. And also, I really liked the way that he lifted the mucosa, the olfactory mucosa, and just tucked that out of the way rather than resecting it as well.
Yeah, I think that's a very good point you picked up, Louise. Yeah, because very minimal handling of the superior turbinate, if you see that. Yeah. Otherwise, to begin with, we start with a resection of at least the lower third of the turbinate, if not to the lower half.
That's right. Yeah.
And then again, to get a better access, it gets trimmed a little further. So from the olfactory point of view, that's probably
much better.
Yeah.
And then often, if you've not got that good enough access, when the neurosurgeon then comes in, superior turbinate gets resected even more because they always want much more lateral access. So I think going for that lateral access first was really good to see.
Yeah. And some of the things really, we don't want to see them. We don't want to go anywhere close to them, like an internal carotid and all that.
Yes.
So I think, if you notice, that's the first thing he established. No?
Yes.
The internal carotids defined all that, the medial wall of the cavernous sinus. And then went for the...
And made a very good point. If you're not exposing the carotids and finding the carotids with the more straightforward cases, then in those cases where it's vital that you do that, it becomes more difficult and more stressful.
Yeah, it's very true. And overall, the final outcome, when he laid the flap and all that, hardly any raw surface left. It's all
I know, yes.
very natural. Yeah.
Yeah.
And this taking a little time. I think, have you seen how many times during the surgery he has used the neuropathies and waited for 1 minute or 2 minutes for everything to settle down, then you coming back. I think that gives a really good feel, in the long run it works better. So even the flap also, he then pressed it with the neuropathies. So it gives a good bony approximation.
Sort of palpated it down and massaged it out almost just to get that extra venous ooze away from it. So it laid down flat against the skull base, which was nice.
Yeah. Another thing on the contralateral side, he didn't really do all those inferior cuts and getting the flap down on the contralateral on the other side.
Yes.
So most of the endoscopic work was done on the right side, and that way I achieved a good sort of wide access. And maybe the neurosurgeons did work on the other side when necessary.
Yeah.
And then the irrigating the pituitary tumor. Now, when I was dissecting, I think that was a good technique. I mean, there's a continuous irrigation going on at that time, and it really gives a good visualization, very good hemostasis, clarity. So that was another little thing I found very interesting.
Yeah, I think if often some of the tumor can be hidden sort of up superior and laterally, so I think that constant irrigation allows them to ensure that they get good visualization. It get you almost see through the irrigation, don't you, to make sure that the cavity is clean.
Yeah, very right. So thank you, and I think again very another interesting case with lots of little techniques to pick from, and even if you're not doing the pituitary surgery, all these little techniques will be always helpful in any endoscopic scenario. Yeah. So with that, I think we finished our second case. So it's a time to visit our supporters, and after that, we probably can revisit Richard's technique that we talked about, the allergic fungal sinusitis. We did a middle maxillectomy. So we have recorded live surgery for that, and we can play that a bit till we join back to Richard. Okay. So thank you, Louise, and
thank you.
I think you have a session tomorrow morning, so we'll probably see you later. Okay. Cheers.
Thank you so much. Bye now.
Thank you. Bye. So soon we'll be starting the video, and just to remind that we'll be joining Como Hospital at 7:30 a.m. BST. So we'll be joining Paolo Battaglia and Mario Turizinani from Como Hospital. That's the Paolo Casnero team performing endoscopic orbital surgery for a very interesting case of hemangioma. So join us tomorrow morning.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB, or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more. Do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable cart, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. Propel Mini is placed in the frontal sinus. Its spring-like design props open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. In the Progress Mini randomized clinical study, Propel Mini demonstrated a significant reduction in the occurrence of frontal occlusion or restenosis and need for additional surgical interventions. The Propel family of products allows patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes. The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour Delivery System has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult, complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, and especially in patients with severe polyps and samtostroid. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Hello, welcome back again. So we're having a fantastic second day of our 3-day live surgery event. And for Professor Richard Harvey in Australia, it's the third day. So it's 8 p.m. in the UK, and it's early morning in Sydney, Australia, where they're getting ready for surgery. So far we have fantastic 2 days with surgeries from Spain. And today we had Rick Carra and Professor Daniel Prevedello performing craniopharyngioma from Wexner Medical Center, Ohio, in the USA. So I have with me my colleague, Louise Melia. She's a rhinologist from Bath in the UK. So how did you find the event so far, Louise? Do you enjoy it?
Yes, very much so. A shock. We've had great cases. So I was here for day one, and we had an excellent selection of cases.
Give me a towel clip.
Showed us how to deal with difficult cases, difficult fields to begin with. But then it was very interesting to see how the surgeons dealt with that. Gained a really good surgical field, and then obviously dealt with the pathology that was at hand. So been very interesting, and looking forward to the cases that we're about to see coming from Australia as well.
Yeah, great. And we have cases coming from Australia.
Let's go to the endoscope feed next.
Afterwards, we'll be joining eastwards.
Well, actually, leave the brain lab up. Leave the brain lab up.
Jaipur in India. So without further ado, I think we'll join the team in Sydney. And we're thank you the whole team for
just not
taking all these efforts to join us today. So Richard.
Okay.
Good morning, Richard.
Hey, good morning. Hold on 1 second. We'll just restart the endoscope machine. Just turn it off and on again. No, it's not clearing. So the white balance is not clearing. Just turn it off and on again. Yeah. Hey, so you should be able to see. Good morning. You should be able to see the scans up on the images. Let's get rid of any other feed other than just the brain lab scan, and hopefully you can see that.
Okay, correct. So we'll get the studio to connect to your feed, and then yes, we got your view. Fantastic. That looks interesting case.
Yeah, so this is a young 23-year-old girl. She's atopic and just has had progressive right-sided obstruction. And of course, all rhinologists and ENT surgeons will recognize this. She's got allergic fungal rhinosinusitis. And as it typically forms with the hyperdensities on the soft tissue view, expansile unilateral bone changes, and typically a young person with an atopic predisposition. And so she's really absolutely barn door classic AFRS case. When she saw me initially, her symptoms had been obscured by the fact that she's had long-standing She's had long-standing symptoms of allergy, and she's not only sensitized to mold, but also to dust mite. And so, when I saw her a number of months ago, the first thing I did is I started her on dust mite immunotherapy, because she's actually got bilateral symptoms, this girl, but it is her right side that's worse, and the reason it's worse is because she's developed in an atopic individual a secondary condition, and that's the AFRS. And that's a really important concept to remember, that many patients with AFRS have an atopic predisposition to start with, and that's, often masks their presentation. Now, it's pretty straightforward on the scan. Are there any questions, Ashok, before we go to the endoscopic feed?
Yes, I think the question comes to mind that over the last few years, have we seen any rise in these cases of fungal, even AFRS, after COVID?
You know what? I'm not the best person to ask for that. Here in Australia, we had so little COVID that, there were less cases of COVID than there were the natural respiratory viral event, flu season. So I'm just, and even though COVID is more severe than that, it just in terms of prevalence, it's just not so common in Australia. So I really can't comment.
Okay. Yeah.
How about you in the UK?
Yeah, so certainly I've seen more number of cases over last in the post-COVID era than I've seen before. But of course, that's my anecdotal personal experience. What do you think, Louise?
Yeah, so I think we've seen an increased number in the more concerning fungal sinusitis. So we've had several cases come in that have had invasive fungal sinusitis, and I think certainly in India, they noticed a significant rise in the number of invasive sinusitis post-COVID.
Correct, yeah. Okay, so what's the surgical strategy?
Let's go to the endoscope feed, guys.
Yeah, sure.
And we're about to start here. Artery clip, thanks. Thank you. And we're going to do a timeout, guys. Just mute the audio for a second, guys. Can we?
Sure.
A shock. What's interesting about this case as well is that it's unilateral, because quite often we see allergic fungal rhinosinusitis in its bilateral disease.
Exactly.
I don't know what
yeah.
your experience has been with that. Yeah.
Yeah, I know that's commonly see bilaterally.
Mm-hmm. And it can be really quite severe. We've had a few cases referred as query malignancies because they've actually had mucoceles and they've had, they've presented with visual disturbance, and it's been secondary to AFRS.
Yes.
You got me back on?
Yes, we got your endoscopic view, and I'd like to know what is your preparation for this patient.
A couple of little things here.
Yeah.
Really important is to sort of acknowledge that the whole bed's at a sort of 15-degree angle.
Yes.
That's 15 degrees. And I think a lot of people, when they put their bed in reverse Trendelenburg, put it into 5 degrees and think it's the reverse. We're very comfortable. We usually operate at sort of 15 degrees reverse Trendelenburg. It's very common for us. And it's one of those things, like when you look at preparation for sinus cavities, there's little things you can do. If you use high-dose adrenaline, this is associated with about a half a Bozert score of field improvement in terms of bleeding. If you put someone in reverse Trendelenburg 15 degrees, this is another half a Bozert score. If you use bradycardic anesthesia, that's another half a Bozert score. And if you use tranexamic acid...
Sorry, Richard, I think your microphone is probably shifted away.
What's happened?
Yeah, so that's good. I think the sound quality is... Yeah, I can hear you well now, yeah. The sound was reducing.
Yes, I was saying, reverse Trendelenburg's half a Bozert score. Bradycardic anesthesia is half a Bozert score. Reverse Trendelenburg's half a Bozert score. And tranexamic acid given IV is half a Bozert score. And high-dose adrenaline's half a Bozert. So I think I named 4 things there. So, if you do all those little things, you get a lovely view, and I think we all know these things, but I don't, a lot of times when I see people practice, they don't put them into their daily routine, There's 12 RCT supporting tranexamic acid, numerous RCT supporting just simply using adrenaline or a simple non-selective alpha blocker. Very important for bradycardia rather than hypotension. So these are the sort of things that I use for the field. Now, look here. Here's the right-hand side. And you can see, very typical for AFS, right? It's got some polypoid degeneration coming. Now, to me, this is not the AFS here, right? That's the AFS, right? Can you see the sort of eosinophilic mucus?
Yes.
Yeah, so to me, this little thing here, which we're just going to shave up very quickly, is just allergic changes, in my opinion, coming off the bulla and uncinate. And here's some allergic change. That's not AFS coming off the middle turb. That's just an allergy change coming off that area. So now, when I'm going to approach a case like this, give me a ball probe, thanks. Look, sometimes I'll make an effort to see if I can see where the old uncinate is. But you know what? It often doesn't matter. And I'm intentionally going to go just to the back here. It's broken through here, so just give me a backbiter. I think a lot of us get fixated with the idea of wanting to find the natural ostium all the time. And it's so important sometimes just to not worry about that. And you want to find your anatomy. That's the most important thing. So the first thing we did there is just run along the superior edge of the inferior turbinate. So we've released the uncinate here. And then we'll take off the upper uncinate. Now, I always do the inferior uncinate first. Let's go an up-through cut, thanks, Lenny. And then I'll up-through cut, thanks. And then let's take off the upper uncinate. It still reminds me that a lot of people go for the upper uncinate first, and even though they know it's going to bleed down onto them straight through cut, it's really not, in my mind, that's always going to make your inferior uncinate worse. And we have this general rule in sinus surgery that if we're going to do something in the sinuses, that we do something in the superior and posterior part of the sinus first before something anterior and inferior. Yeah, we're just shutting the sucker up there. It was sort of drumming out in this side there. Give me an up kerosene. So taking the inferior uncinate, take the superior uncinate. Now, it's really, I love the kerosenes. I saw Stamberger operate in Graz and he used the circular punch, but he used it in the same way. It's a really easy tool just to sort of quickly sort of munch away. So then when you come in with a shaver, and you can see I've got that classic crunch and gobble technique, right? So here we are now. There we are. We're going to open this all up. Just get rid of the polypoid change that's there. Get rid of the uncinate that I've just munched up. I'm not really trying to remove tissue with my forceps. And I can tell you, here's a tip for anyone doing cases like this. Don't fiddle around with a fungus right yet, right? You can now spend 40 minutes if you wanted to try to get that fungus out. That's not going to be very rewarding, in my opinion. The bulla is almost collapsed here. So what we're going to do is we're just going to find, there's the edge of the bulla here. So give me the backbiter. Oh, no, give me a kerosene, my apologies. Whatever's left of the bulla here, we're just going to nibble it away. So it's almost like going into the retrobular area there. And once again, just sort of munching it up. There's a bit of mucus trapped in there. I just want to find the orbit. That's the only thing I'm interested in when I do a case like this. I don't really teach sinus surgery anymore about all the developmental anatomy. I really just teach it based on finding key landmarks. And one of the key landmarks here when you're doing an anterior fess is just to find the orbital floor. And sometimes can be a little tricky when it's a edematous. But there you go there. See that? That's orbital floor there. Yes. If that's orbital floor, then that has to be orbital wall. And if you're not sure that you're right, that's orbital floor for sure right over there. So give me the kerosene up. I can't quite see, in my mind, where the orbital floor becomes the medial orbital wall. And so I'll often then just nibble it a little bit more so you can really see, and I'll go with curette here in a moment. There you go. Perfect now, right? This is what I teach people to find. You see the floor of the orbit? That's medial orbital wall there. Cannot be anything else. So automatically as a surgeon, you know that that's the orbit right there. Let's go some patties, thanks. So now I'm going to stop here, right? Because I said to you, I'm not going to fiddle around taking this fungus out of the sinus cavity. Over the years, I've found that if you try to do limited ventilation type surgery for AFS and have a big maxillary sinus, you have a high chance that they'll have persistent mucus in their sinus cavity. In AFS, you really need to create a single cavity that they can wash out. And if you said to me as a researcher and scientist of the sinuses, if you said to me, why is the left side not affected? The left side's not affected because on that side, mucociliary clearance is occurring, and it prevents fungal elements from making any prolonged contact with the sinus lining. And if there's not prolonged contact, then you don't get a reaction. And if you have prolonged contact, you get a reaction. And so something happened here on this right-hand side in the maxillary sinus where she had some mucostasis. I mean, it could have been any event, like a viral event or something else. And that's what set off then a period where she had prolonged contact in someone immunologically predisposed. Because that's a question I get asked a lot by people. You know, why does AFS occur unilaterally? This is the sort of thinking about it. So, Lenny, let's go with a artery clip now. So now we're going to do artery clip. Now we're going to do a modified medial maxillectomy, you know, and this is really to make sure that we give this lady a really simple cavity. Now, things that you might want to see here, just as a way of interest, that we, let's shut that up. Peter Lee, do you want to grab that sucker and just sort that out? Thank you so much. So that's the nasolacrimal opening just there. See the little slit in the wall? Give me a sucker.
Yes.
Let's just have a clamp, guys. Just put a clamp on it.
That's the classic Hasner's valve.
Yeah, there it is there. So look, I'll try not to beat it up too much, but you can see what it is. So for most people, Hasner's valve is just this little slit opening in the side wall. It's not a hole in the top that people see. Give me the artery clip now. Yeah, maybe a second one, like a needle driver, just to clamp it. Yeah, put a needle driver on that. Okay, yeah, sure. Okay, here we go. So we're going to put an artery clip on. Now, I like to just crimp it here. Give me a curved iris, thanks, just to help with hemostasis. So this section of the middle of the inferior turbinate, we're going to remove so we can expose the rest of the medial maxillary wall. And I just simply will amputate this section, and then I'll show you about raising a small, I like to preserve the inferior meatal mucosa as a small flap. Now, as you come down here, you can see the whole wall is slightly medialized. Now, as you get towards the back, there's no point leaving a really big back stump. I think if you do, it doesn't often function properly, gets maximally dilated a lot, and I'll just try to cut it off. But you don't want to cut it off so flush with the wall that you end up with, almost stripping it from the bone. You want to leave it, let's go with the medicine balm, thanks. You want to almost leave a little stump so you can bipolar the little artery that's in there. And normally, you can see the very end of it here. Let's see if we can actually just get down here. I think I almost got through it. There it is. There you go. Blakesy, thanks. Now we'll take it away. Okay, let's go needle point now. Next, thanks. I'll get you to get a clamp and put that on it rather than doing that. Okay, so here we are. This is the floor now. Yep, and I'll get you to grab it now and we'll get you to... Now, when I do a medial maxillectomy, you want to feel for the hard palate, soft palate junction, somewhere along here. And then we're going to make an incision really at 90 degrees to the area that we want to divide. And just really make sure we're on the bone. Yeah, you want to be right down. We're right on the bony junction here. Great. Now, up here, though, I'll get you to swap for me. Give me a wipe. Give me the sucker. Let's go. I want to show you. There's our nasolacrimal area. I'm not going to look with an angled camera. I think we can sort of see the slit area. And then on this one here, this is why it's called modified medial maxillectomy, because we're going to preserve the valve area. And so this incision then is at a real 45-degree angle. Can you see that? It's very different to the back incision. You want to come at 45 degrees. Let's go Cottle dissector now. There you go, great. And then we'll just throw a clamp on that when we're not using the sucker. Now, because I've made the incision already, it's very easy to raise. Now if the bone is very thin, actually it's good just to raise it on the floor first. So the floor is always a good one. If you're struggling to raise it, or the mucosa is thin or the bone's thin, just go to the floor first. And it should release entirely here, actually, because, if the surgeon had connected all my dots correctly, we should have no problems. And unfortunately, the surgeon almost did that. Not quite. There you go. And then we'll fold that flap up in this direction here. And you can see how the 45-degree anterior incision really helps us to fold that out of the way. Let's go curette now, thanks, guys. I love this maneuver. This we call Jessica's punch. I don't want to do all of this with the drill, so we just punch in. You got to punch somewhere comfortable. Don't be working really anterior and posterior in my mind. Kerrison up, thanks. And then we'll just come through now with a kerrison, and then we'll use a straight through cut, thanks. So you want to come in, obviously the bone's really thin here in this patient. We'll come then through with a through cut. And it's exactly the same technique. Make sure we have a 12 sucker here when we eventually get this guy open. Yeah, not right now. A 12 though. Yeah. Minji, can we get a 12 Fraser, thanks? Just disposable. Yeah, hopefully I'm going to reduce the pain of sucking fungal mucus out for everyone. I worked in the south of the US with Rod Schlosser, backbiter, thanks. And the amount of fungal material that I had to suck out during my fellowship was incredible. And I've really got an aversion now to sucking thick mucus out of sinuses. I don't like it to take too long. Here we go. So you can see how I'm going to remove that bone right up to our cut here. Now, I've seen lots of people describe this tuna saving, modified medial maxillectomy, nasolacrimal duct preserving. It's all of those things. That's why it's called modified. And how you do it doesn't really matter. But what you can't do in a modified medial maxillectomy, Ashok, in my opinion, it's not a big hole. One is not doing the drill, thanks. One is not doing this surgery for ventilatory reasons. Let's go 30,000 on the button, thanks, Minji. No, 30,000. Thank you. We'll just make sure our irrigation's working. Yep. And so the goal of the surgery is to create a sinus cavity that doesn't collect mucus. And is easy to wash out. And so we don't want any sumps to form. If you leave a sump or an area where mucus forms, this lady, unless she's on prednisone, will end up getting a reaction because she'll have a long contact time with the fungal elements. And I don't normally give fungal immunotherapy for these patients. They don't need it for most of the part. If you just restore their mucociliary clearance, the sinus will come good, like the other side. Now, they are a little bit at risk, Ashok, of, I think there's a few publications to show that you're a little bit at risk of getting it on the other side, you know, even if at some point in time. But I must admit, I'm not one yet of doing the other side, you know, prophylactically or anything, you know. I just try to just get it right. What about you? I mean, you're probably over the course of your career have seen people who come back perfectly normal side one time and then a few years later they get it on the other.
Yeah, yes, and there is argument by some that you can do at least mini phase type of procedure, uncinectomy, middle meatal antrostomy. But again, he said if it is not broken, why fix it? It seems perfectly normal on the other side in this case.
Yeah, I wouldn't even fiddle with it if it's normal. I wouldn't even do. I don't believe doing a simple antrostomy in my mind protects you from sorting that out. And you'll see once again here, you know, Ashok, I've really made a huge effort to not touch anything. Like I haven't touched haven't touched everything, you know, I care just as an efficiency as a surgeon, we'll just get rid of this little bit of posterior turbinate. It's much, much quicker if you just leave it all and get your opening right. And you can see I've almost got my opening right. To the point now, give me a ball probe, thanks. Let's take out the patty. And you'll see how much mucus is here, right? Look, from there. So imagine if you were a surgeon trying to remove this mucus plug from up here. Oh my gosh, I can tell you, Ashok, I've seen that, people do that, and it is the most painful thing to watch ever. So, you know, I always promote the idea of get your opening right, then remove the mucus plug. Let's go a wash on a stick, Linny, on a long, thin curve, and we'll get our 12 sucker on. And you can see here that I'm still going to have to struggle. I'm sorry, I'm going to have to put everyone through mucus removal. But now, at least, give me another...
So you're almost going through the normal anatomy surrounding the whole disease, and then making it easier to remove.
Yeah, 100%. So let's give me another washout. So I find that a lot of the time you got to put a bit of a wash in to get the lump going. And I've even been known to take the 12 gauge sucker off the sucker and literally just put in the. Just want to pinch it for me. Go for it. Let it go. See, look, I got a 12 gauge sucker. And look at it, right? This is why, for all of those watching who thought I should have been removing mucus 5 minutes ago, and it goes to show, though, why we're doing this approach. If you did an antrostomy and spent half an hour trying to get rid of mucus, all you would have achieved is creating an empty mucus-containing cavity that's likely to recollect mucus in the next, you know, little period after surgery, because they will sump and pocket mucus very, very easily. And this is, I think, why people used to, like I grew up in the days of Fred Kuhn, where he thought AFS was the worst condition ever and it was chronic. To me, AFS is the one condition that we can cure as sinus surgeons. It's eosinophilic, you know, type 2, you know, diffuse disease that we end up needing biologics for and everything else. Okay, I'm gonna do it. Pinch the sucker for me, please. Big Tilly Hankel. I have to resort to this sometimes. Doesn't always work, but let's have a look. Okay, hook us up, open up. Thanks, Lenny, open up. There you go. Hasn't put this 12 gauge back on. Oh my gosh. Alrighty. 12 gauge back on. Now, as I'm slowly removing this, the brain's trust of the panel, I'm open to any special techniques that people know of to remove mucus. I've never discovered one. My best one, I would say, is thick eosinophilic, a big hole, and make sure that you use the irrigation as much as you can, because irrigation sort of loosens up this tight attachment it has to the surface, I think. Let's go another irrigation. We might do a few more irrigations. I can see it coming loose here. And you can see with a nice big opening too, Ashok, I'm not struggling when it comes to, putting the sucker in and out. I see so many people sort of beat up the lining, when they're trying to suck something out and they're struggling. Have a nice big opening, you can suck it all out. It's a bit easier. Let's go that. Hey guys, don't worry about anything else here. Let's just go the wash and the stick. Thanks.
Yeah, and with this technique, almost the whole of the mucus is coming out like a ball together. You can dissect out from the edges, rather keep aspirating it. So when it is out, it will come out in total.
Okay, give me another wash and stick. And you can see it. I've loosened up the back, but this front wall has got diabolical amount of mucus in it. I wonder if I can come along the front wall. Oh yeah, getting there. It's always satisfying when it comes out. Just quickly grab it. Don't mess around. Okay, here we go. Wash and a stick, thanks again. And I might try my little direct sucker approach again if I can loosen up this side wall. But once again, just a great demonstration of just needing to get your opening right first, Ashok, just so important. Yes. And this is also too, those of you in the audience who think, oh, can't you just get away with doing an antrostomy? This is the pathophysiologic process you're fighting. And this is why people who do little ventilatory surgery, on conditions like AFS, struggle sometimes, and they have patients who get recurrence or don't settle down even to begin with after the surgery. So I'll get you now to pinch the sucker for me.
And can I ask, so post-operatively, what regime would you put the patients on? Would you use oral steroids? Would you use steroid-impregnated rinses?
Okay, let's go. Yeah, so you have to use oral steroid for AFS. Yeah. You got to at least for some period of time suppress the condition, and I don't think you can do it with topical corticosteroid irrigations alone. And so they all go on oral steroids for a period of time. Usually something like 3 weeks, but you don't need a big dose. 25 milligrams max dose is all you really need to suppress, eosinophilic inflammation of the airway. Mm-hmm. So you don't have to give them much. There's no role for antifungals, in my opinion. Mm-hmm. I wrote the chapter 6 in EPOS 2020, which was all about fungal sinus disease. And you know what? There were some fascinating things that when I had to do the review of that, and I did even a couple of meta-analysis plots for things to really show that, being on things
Hello, welcome back again. So we'll be joining back with Professor Richard Harvey, Sydney in Australia. So we just had two wonderful case demonstrations, one of allergic sinusitis, the second was endoscopic pituitary. And now this is the third case, another endoscopic pituitary surgery. He's doing it jointly with his neurosurgeon. So over to Sydney. He's operating from St. Vincent Hospital in Sydney. So hello, Richard. You're just getting ready? Yeah. The preparations are ongoing. So let's get back in the studio again for a minute while they get preparing the patient. So Richard has a very interesting technique for pituitaries. Of course, it does it jointly with the neurosurgeons. So lots of key points we discussed about the technique was raising that modified nasoseptal flap. I think that flap really helped in the end to line the cavity well, and especially to line expose the internal carotid
Don't know whether
and all
you
the
can
areas.
hear me, but we can't
Yes,
hear you at the moment. You are unmuted, so
Oh, can you hear me now?
no, can't hear you.
Can you hear me now?
I can only hear music.
Hello.
Still can't hear you. Oh, now I got you.
Yeah. Can you hear me
Yep.
now?
Yep.
Okay.
Loud and clear.
Great. So we're back in theaters, and we're ready. We already joined you.
We're just about to give Richard his microphone.
Okay, great.
Hey, Ashok. Hey, Louise.
Hi, Richard. Hi.
Hey.
Yeah, sorry, Louise had to leave because she had a clinical session this morning.
All
so it is just me for this hosting you today for this case. So
Fantastic.
it looks like you are nearly ready there. You see the reverse Tennisberg position.
So it's a very similar case, Ashok. As you look through here, though, this woman's got true lateral wall cavernous involvement, though. So she's got a little bit of optic chiasm distension, but she's got some true involvement of the wall here. Her normal gland is. Oh, hold on, I'll get that right. Okay. And just keep that. You see? Yeah, I just want to keep
Yeah,
it patient.
you can see the images here.
Okay, so so you can see here that there's true cavernous involvement on this side. Normal glands up the top and a little bit off to one side, off to this left-hand side. So really important that we see the paraclival, but particularly on this right-hand side. And then here, we're looking for the pituitary bright spot. It's somewhere at the back there. You can see here probably that's the pituitary bright spot. So the posterior pituitary gland, that little bright dot at the back. All right, and there's usually this posterior compartment of the cavernous has been entered by tumor. So let's get started. I'll be back in 2 secs.
Sure.
Sorry, that's all good. No, I'm just going to grab one of these. Already. Okay. You got it. Thanks. Jackie. We're going to have an early finish here, guys. Early start, early finish. Jackie's like, what? What? Okay, Martine, that looks fine with the head elevation. Our lady is a little bit older, this patient, our shock, so her head extension is not as much as we would normally have, but it's going to be plenty enough. And can we get a head lift, please? That's right. Now, just first of all, can we take out the head ring and put it on top of the sheets? Yep, perfect. Yep. Okay, I got that. Can we go table down, please? So once again, we're putting the table in reverse. Yeah, more. Max down, please. Tiny bit. Yeah, that's good. Tap clip, please. Let's go light on. Okay, we should be straight into it. So, the nice thing here is that, it's a bit of repetition, right? Especially when something like you saw me do the approach air shock, it's very structured,
Yes.
And it'll be exactly the same here for this lady.
And some of the viewers have just joined for this case, depending on the time zone. So maybe we can briefly go through it again for this case.
Yeah, 100%. We'll go through it
Thank
again.
you.
And really nice, sometimes repetition for things that are very structured is good. So I always start with a 22 spinal to do the injection. Injection going in, ma'am. Spinal needles are not the best for they're 22s. They're a little bit thick for getting into the tissues, but we'll swap to a 25 gauge here long in just a second. Yep, swap, here it is. So we'll very quickly swap. Mm-hmm. I know my focus is out slightly. We'll sort that out here in a moment. And it's so important just at the beginning of the case not to mess around too much, especially because we're going to inject. Mel's still setting up all the instruments and everything else. You can see how blanched the mucosa is already, Ashok, from just having the patty sitting in there for 10 minutes.
So does this have a tranextral acid as well, or is it just a local anesthetic?
No, it's the same as what we had before with the tranexamic and everything. Yeah, 100%. I just sent our first patient, just went home, Ashok. I went up and saw him. And
really? Oh, wow, that's incredible.
Yeah. Okay, I've got Patty Anna Blakesy, thanks.
It's always great to see that Caroline's into technique, the frontal sinus approach.
Yeah, no, thanks. It makes it so much easier. And people, people who look at that technique, and the reason I did it, Ashok, is I've taught, I've done all the 70-degree stuff. I've seen all the struggles of angled scope techniques, and occasionally when the anatomy looks great and you can do a great frontal, and times when it struggles. I've done that technique, because of the challenges that I think we face in frontal sinus surgery. Okay. Now, I quite like it. If you said to me right now, you said, Richard, isn't there a little bit of a high septal deviation here? I actually quite like it when it's like this, because it's much easier for me to work on the deviated side, and I'll sort of end up correcting the deviation here as part of the approach. It's better for me to do that than have the deviation on this side. If I have it on this side, often if there's a big spur and other things, it gets in the way of the other instrument, and it's at risk of then tearing the flap and everything else. So if I had to have a septal deviation, I actually prefer it on this side. I think they're the same patties, right? Not new ones, yeah. Same ones, yeah. That's all right. All good. Yeah, that's enough. Perfect. So, my needle does come like this, Ashok, so I do artery clip. Yep, thanks. So I do bend it. There's a couple of nice monopolar tips. We use a Megadyne 0016 AM. That's a nice length, and it's got this protected malleable tip that you can bend. I think our current one is what's the current make of our? And there's a Covidian one that's the same length that looks great as well. Okay, let's do timeout, guys. Can I have a look? Do you want to show me the Covidian? I'll just take a quick photo while we're waiting for all the people who turn it over. There you go. The Edge 1465-4, I think is the model number. Here we go. We're doing timeout. Perfect. Silicon sheets. Thanks. There you go. Perfect. Perfect, thank you. And Martine's got this lady's heart rate in the 60s from the get-go, so that's terrific. Okay, let's go down on the suction, please. Have a quick look at my injection sites, Ashok. Make sure they're not bleeding too much. That would be a sign that maybe the prep's not good enough. Okay, kerosene up.
So you always choose the right side to develop the flap and all.
Yeah, always the right.
Get the access.
So there's that same little posterior ethmoidectomy.
We're just discussing after the last case that most of the surgeons would start finding the sphenoid ostium first and then work backwards.
Say that again. Like, where would they start?
Finding the sphenoid and then working backwards from the sphenoid.
Yeah, but
so
you know what?
Quite a nice technique to get wide.
Sometimes in big tumors you can't. Okay. Okay, straight through cut. Curette next. So minimal as possible, right? This is for, trainees who are still up watching. You can go in and find the natural os through there, turn around and stretch like I did just then. But this is also Bolger's box, right? That back letter, you can just poke through. Either way will get you there. Here is it up. Okay, up through cut. Straight through cut. Carrots enough? Actually, probably straight through cut, actually. You can see we've found the corner pocket. There's optic. Carrots enough? There's still a tiny bit of partition. Padding on Blake, see things? %100% know where I am. That's the most important thing. I don't want that to strip in if I don't have to. So there's our posterior ethmoid sphenoidectomy. Just one more, that's all I do. I'll do one more then, and that's it. Yep. Suction on max, thanks. Needle point diathermy, thanks. It's a nice view here. We had that spur in the way last time, right?
Yeah,
yeah. So just, just to go through the cuts again. Just above the inferior, not up here, just above the inferior turbinate, right? On the vertical plate. It's not vertical plate palatine, it's really medial pterygoid plate at that point.
It was interesting to see, Richard, that despite the spur, there was no tear at all. The way you handled the spur and worked around it.
Yeah, you can see it just came out with the flap, right?
Yeah.
So
exactly.
Just work around it because it eventually will go. The soft palate's quite a fair way forward here. Okay, swap. Get a wipe on the tip. Now, we'll go looking at that lovely olfactory mucosa up there. We don't want to be anywhere near it. I sometimes just have a feel to make sure that it's not too thin. And then you can see here, I'm beating up the front little bit of mucosa here, but I'll show you what taking the swirl body does. So and then start heading back again. So I've come a little bit more anteriorly, but just near the swell body. Okay, caudal dissector. Start raising it posteriorly first, because it will bleed as you raise it. And this is what I said, Ashok, most important, there's the rostrum. Straight through to it, right? Shouldn't be taking people an hour to raise their flap. 2 minutes. That's how long it should take. Okay. Let's take this swell body off then. And I might not be fully through there. Good. Because we're going to take some of that swell body out here in a moment. Okay, give me curved iris. And you can see how it's hanging nicely. You know, it's hanging from this less than perfectly cut top edge, but intentionally so that I can do my dissection carefully now. And you do have to be careful here. You know, you can see that where we're headed. I can't quite see I know I'm still in front of the... If I needed to fix that upper septal bone, I would. There's the diathermy mark. There. Curved iris. You've got to make sure you understand what level you're at here so you don't go disappearing into the olfactory cleft as you cut back. This is why having that diathermy there is excellent. Even though it's not all the way through and I've still got to cut it, it tells me exactly the height I need to be at. There you go. That's done. Put the flap away. We'll quickly turn up our olfactory strip. There's our smell cleft. Little adhesions in the smell cleft. They're thought to be acquired, those adhesions, actually. We've got a little study looking at, you know, they're not seen in young people. We don't quite understand why people get olfactory cleft adhesions. They certainly happen in people who've never had surgery and things. Because I've made that vertical upswing to include the swell body, it allows the release of this olfactory mucosa to then fold up into that area. Now, you can see this is a bit strong here. So heavy mayo, thanks. Let's take out this high septum that's in our way. Now let's come across the other side. So we'll take all the patties out. Let's come now subperiosteally like we did last time. Ashok, we're a little bit further forward, yes. But there's our sphenoid rostrum. Give us a Blakesy, yeah. Thanks. There's our opening. See there?
Yeah, sphenoid.
There's a bit more bone of the posterior septum coming off here in this person. But we need to see that rostrum. That's what...
They don't necessarily go intranasally from the other side. So you just work on the same side. But
I love this approach because, it's so preserving of the other side. You know, I mean, I can't tell you the number of people who come and see me who've had surgery of older school techniques, and they get suction on max, please. Kerosene down. The same view we had before, Ashok, and they've lost smell and things like that, and they've got nasal dysfunction, and really pituitary surgery is no longer a surgery you should just survive and you'd be happy with. I mean, really, you should, it's a surgery where you should be able to do it without causing or minimizing functional deficit, to patients. Kerosene up. Heavy Mayer, then heavy Blakes. So I know where my skull base is because I've defined it before. There's my rostrum completely exposed. Yep, good. Let's take this out. Try not to butcher the septum too much. I mean, I'm all for making sure I don't traumatize the septum, but I have just stripped it of its lining on one side. So I'm practical that scratching it a little bit, as long as I don't make all the tissues bleed and make it hard for myself, is not going to make any difference. Okay, give me a down kerosene. See, this sphenoid rostrum is not really mobilized very much. So we might have to just bite it. And I'll go the big Blakesy again here. So you can see I've still got the keel. The keel's still intact. Ashok, here we go.
Yeah.
There's my midline. You can sort of see it, right? Where the keel is. Let's see if this thing can detach on me. It's great if we can get it to come off.
Quite hard, isn't it?
Not really, isn't it? You can see why it might not come off because of how the partitions are, the partitions are coming into it, they're holding it. Okay, we'll go kerosene up. It's all right, we'll drill it all. It's already, we've got a better view of here's that thing where we're going to bite the contralateral side. Just enough now so I can open up a little window, but just almost like a window that's not much bigger than... Got a little bit of bleeding there, that little vessel, one of the top branches. Okay, big drill on and big sucker, please. And I'll take a big wash. So we'll just drill that keel off. But now's the time to get my sucker in, just like we did last time. Blakesy fix. Get rid of that bone. Big wash. Here's that front wall of the sphenoid like we saw last time, Ashok.
Yes.
Very important on this side to get it out, right? Because we've got to work really laterally here. And here's a little technique for you. It's what I call backballing. So if you said to me, how do I drill without, munting my flap and pedicle? Is that when I put the drill in, I use the back of the ball and I drag it onto the ridge. So you drag it onto the ridge like that, just helps to keep the bulk of the burr sitting in the sphenoid, and then the cutting part of the burr is making contact with the bone, and as least as possible with the soft tissues.
Yeah, and working outward.
Yeah, exactly, sort of almost dragging it onto the tissues. And it's really important to do this lower bit first. You want the lower bit done first so that you can create a dependent drainage, a pocket where blood can go and your sucker can live. This is why I do everything low first. Because very quickly we'll get a nice cavity. There's the palato-vaginal vessel coming into play. Big wash. Got it. Thank you. But not quite, right? You can see there's still this big ridge here. And you can see, Ashok, it's fast enough. This is why I don't need to use cutting burrs and things.
Yeah.
I just personally think cutting burrs are pretty dangerous. They don't give very good hemostasis.
There's the same choanal atresia burr, 2.5.
And we're not orthopedic surgeons. We're not removing much bone. Very thick sinus in partition.
Yeah, when you're dealing with these partitions or septi, lateral septi especially, you need to drill it down rather than avulsing them, isn't it?
Yeah.
The possible
100%.
attachment to the carotid.
And it's so nice to just get all those partitions. Someone said to me, Richard, why are you so funny about all the partitions? They distort the anatomy, first of all, but they even do things like they let little light in. They affect the light getting into the cavity. And then finally, when I'm putting my flap back and I want the whole thing to work nicely, I don't want any ridges and everything else in there. So even doing these, just really make sure that I've got a really nice cavity. Even just drilling up here will help open up the light in the cavity.
Yeah, that's a very good point. The visualization is the key.
See how much light's come into it, right? Amazing, right? OCR, right? Looks like a sinus, like a proper cavity now. Big wash. Let's go back on the shaver now. We'll take the mucosa off. We'll do that little trick where I took the mucosa off, Ashok.
Yeah.
Got to display the area that we're going to take off. Look at my cavity start to bleed as I strip the mucosa. Okay, go back to the drill. Okay, now we've got to drill out and find a retroclival recess here. There's really no real nice retroclival recess, so we're going to create one, Ashok. It's very important to have a retroclival recess when you do pituitary surgery. It's where the blood will go, where my colleague's sucker will go.
I think the previous case it was a little bit clear.
This is just a bit of mucosa, but you can see the carotid canal there. Yeah?
Yeah.
So there's carotid. And when I take that lateral exposure, I've got to take it right back to the base of the sphenoid so that an instrument can get in, right?
Yes.
If I don't do it, my instrument won't get in. Like you might be able to see it, but you can't get an instrument onto it. There's the bottom of the sellar now. So you can see this is going to be our retroclival recess.
Yeah.
Now all this needs to go because I can't get an instrument in. This is what I was talking about, Ashok. Just really making sure that the sinus cavity has been reshaped in a way that makes it favorable for pituitary surgery, whether it's well pneumatized or not. We want to make sure it's still a great place to do an operation. A bit of mucosa stuck there. Retroclival recess, looking for paraclival number 2. This is carotid canal coming up. You can see the cortical bone that we saw before. I'll try to make it more obvious. Define the sellar floor a bit better. Just a bit of venous bleeding from here. Let's make sure this is all thinned out so we can just go and take it with the kerosene. We'll put a bit of Surgiflow in here and just quickly patty off that bleeding. Big wash first. I'll thrombose that off, that little bit of bleeding, it'll just annoy us. Patty on a Blakesy. And again. Big wash. And you can see our shock, it's exactly the same. Everything looks exactly the same anatomy as last case, right?
Yeah.
This is the beauty of this approach, in my opinion. Okay, give me a kerosene up.
You kind of have to develop a bit of anatomy here, isn't it? With the drilling, carving out the sinus.
I'll start taking off just the middle bit of this sellar, and then I'll take my patties off here. Because this can go quickly. I'll take the down then ready. I know you saw you had it. Go back to the up here. Don't put anything away. I'm just giving those patties and that thrombin just a tiny bit longer to work. When it's all been thinned out nicely, as you were talking before, it's much easier to take the bone off. I'll take out my patties now. They're sort of getting in my way. But we've got good hemostasis now. And even this is a little bit thick, right? But thinned out enough as we come up to that parasellar carotid. It's been thinned out enough that I can still use my up kerosene to get rid of it all. Big wash. Blakesy. And I think, for those who do a bit of skull-based work, we've got some very talented neurosurgeons. They know how to dissect in the cranial cavity, do a beautiful job. Kerosene up. But they really rely on me to define the anatomy in the skull base. Like I am their IGS. And I do it in a way that then they know where everything is, so that when they have to do the careful dissection that comes with intracranial, intraarachnoid dissection for bigger tumors, that they're doing so where they really know where everything is. And, you know, because that's where all the morbidity is imparted, really, in a lot of neurosurgical cases. There's our paraclival carotid. You can see it pulsating there.
Yeah. Yes.
Kerosene down. Kerosene up. There's not much venous bleeding on this side because I think the whole cavernous is already somewhat thrombosed. Now, if you didn't know where the parasellar, you can sort of see it here, but if you find the paraclival and then simply work your way up, you'll find where your parasellar carotid is. There it is. Perfect. Come to the other side. Let's find the parasellar on the other side, or the paraclival first. There's a bit of venous blue you could see just a minute ago. Down, Kerosene. Blakesy. See how there's a bit of floor here, Ashok? I'll take the floor off. It really defines then my paraclival canal. It was spot on where I thought it was. Kerosene down. Then kerosene up. That little wedge of bone is not something I can just get around. Bit of venous bleeding. This cavernous, remember I said this cavernous is more open because it doesn't have tumour in it. So we've gotten into bleeding a little bit easier on that side. And we don't have to push that side as much. Big wash. So we'll sort that out here in a moment. Let's go Patty here in a second. So I'm going to put a bit of Surgiflow over here. Curette first. But it is sometimes worthwhile to actually make sure, if you're going to put thrombin into a cavernous, it's worthwhile sometimes you actually got a proper opening. You can see the opening there. See how I can put my curette right into it? Sort of makes it, there's that double pulsation of the venous system you often will see. The double flicker. Bum, bum, bum. Just means that when I put that Surgiflow in, I know that it's going to go into that area. See how I've placed some thrombin gelatin into the actual... can we give Dr. Yonker a call? I've placed it into the actual medial cavernous. And you don't have to worry about, you know, it doesn't spread very far. You know, it's a very common approach in skull-based surgery to thrombose parts of cavernous sinuses and dural sinuses off. I mean, I don't think you should put all 10 mils in. Don't get me wrong. You know, I think over the years I've caused some pressure problems, like a delayed 6 nerve palsy, kerosene up, where you think maybe too much thrombin's gone into the cavernous, but really very few problems from simply. And you can see we're right on there. I'm not going to uncap the carotid on this side. We don't need to from a dissection perspective. We needed to on the last case. But do you see how I can really see the blue now of the cavernous just there? If you can see it. And you know, just because as you are working around here, you'll cause little problems. Okay, let's go bipolar now. Bipolar in 15, thanks. And look at that. It's like when Dr. Yonker comes in, it just looks like the last case with the pituitary sitting in a bowl. Big wash. Just a nice bowl. Bipolar. And with everything obvious, right? I'll just say, oh, yeah, there you go. See when I press the venous compartment, you can actually see the carotid. That's that white structure. I wonder how much that left venous system is actually going to bleed on us. What do you think, Cedric? Should we proactively open it up and have a look? Why don't we? We've got a few minutes. Hey, give me a sickle knife. So this is how we normally open up. Big wash, thanks first. Okay, have this. So if we have a venous system here, and we know we have to work next to it, what we'll often do is just make a hole in it, like this. Curetina. Make sure you've actually got a pathway into it, like that. But you can see how the venous system's not full on this side. It's been partially thrombosed already. And then we're going to, see, watch this, you'll see it go in. Whoop, I was trying to show it going in, 1 sec. It didn't go in very well because I don't think there's much venous system for it to go into. I'll come from a slightly different angle. Yeah, there's not much venous system here for me to thrombose on that side. And you can see how different it was to the other side, right?
Yes.
The other side would bleed very, very easily. And this side, not so. Let's put them all in. So here we are, ready to go. Amazing.
On this side, it almost invades into the medial wall, isn't it, on the scan?
Yeah, I think the lateral wall of the cavernous is truly involved here. And this woman's quite a fair bit older, and so we're not going to get a gross total resection here, I don't think. I think she's got true lateral wall involvement, and we'll see what her final pathology comes back. If she's got an atypical tumor, she might go on and have radiotherapy, like a single fraction radiotherapy dose. But if she has a very typical tumor, it's very low proliferative index, Ki67 is pretty low, we probably won't do much here. We'll just watch the lateral wall cavernous. It's unlikely that she'll get problems in her lifetime. If you give her radiotherapy, say, what's the downside of radiotherapy? Well, there is a hypopituitarism rate that comes with having radiotherapy. I think if you had cavernous involvement and someone was young and they had a reasonably benign tumor, you could give radiotherapy if it showed growth. But I think in someone who's in their late 70s, I think it's unlikely to be an issue. Okay, and you can see now, look at that. So that's a really good example of the approach, right? I might take that little bit of bone out, that cartilage, because it's loose already. Blakesy, thanks. And it's a little bit beat up on that corner because that was the old horizon, wasn't it? Of the little bend in that septum. But with this part of the septum is really not too bad. All of that septum is going to be fine. We'll fold that back down at the end of the case. And yes, look, this is where I took out that bone. You scratch it up a little bit, but although I don't want to scratch it up, I mean, look what I've done to the rest of the septum, right? So, put it into perspective in terms of, healing. You just don't want to beat up the turbinate so much that you make it bleed terribly. A lot of superior turbinate protected here. I can't say how important that is. And look at all this high, lovely olfactory mucosa intact. Other sides not even involved. And it really looks like nothing's happened on this side. It's just a little hole. A working channel is all we've really got. So let's go down to the small sucker. Let's get the instruments out. And Ashok, no delays here. We've got the neurosurgical team scrubbing up. And you can see the whole exercise takes about 2 hours, and we'll routinely do 4 or 5 on a list here in Sydney if we got the whole day for it.
That's quite a good number. So working through both the nostrils or working through the same nostril with a wider approach?
Your deep baritone voice, Ashok, somehow.
Sorry, will you be working through the same nostril?
It's hard to hear in my loudspeaker.
Can you hear me now?
Yeah, I can.
Yeah. No, we're just wondering whether both of you will be working through the same nostril or both the nostrils.
Oh, yeah, exactly. Yeah. Well, it's still sort of two, right? But I forewarn patients, Ashok, that their right-hand side will ooze more than the other side. It's very nice just to forewarn them that that don't be alarmed. Clicker. Right. I'll hide out of the way. There you go. So a little bit more exposed off to this side. I had to do that one, and I've done a little bit in this side, but the right side actually, it doesn't have much. That's a little bit off to one side. Yeah, but see, I've got carotid exposed there. That's a little opening, and it's been properly thrombosed on that side. But this side, I couldn't get much into the sinus cavity. It's carotid's. It's under that. Yeah, there it is, up there. I've already got the venous compartment, so I sort of stopped there, and I've got a little bit of the carotid. That's carotid, yeah.
Okay, cool.
And you can see how quickly Ben can orientate himself, looking at the at the anatomy. Maybe in a bit there. Venus Lake or something. Perfect. And look at that, Ashok. Within a half a millimeter of where you need to be. Yeah, there you go.
Okay. Really wants to pop out. You don't have gland.
Could be a little bit of gland, yeah. Do you want to see if you can lift it up or something? Maybe a ton. Yeah, I didn't think it was draped over that. Yeah, for sure. You can see there's a tiny bit of normal gland, Ashok, just draped over the front edge. It's very pancaked already, and most of the gland... What's that little bulky thing there? The white thing. Yeah, of course. Don't doubt it. But doubt it. Something that, the bulk of the tumour here, the normal gland's on the left, Ashok, so obviously we're not too fussed here. If we lost a little bit of thin gland at the front, it'll be okay. But, you want to pick it up, preserve it as much as possible. So that's the sort of the art of... A little suction, maybe. Just like that. Yeah, this top bit. I'll hold it back for now. At least it'll give us our plane early on. Yeah, so That's what I mean, yeah. Just be really cautious.
Okay, let's hit the 45.
And it's just very soft, the tumour. Yeah, see that? Could be, yeah. Do you want to just stay on the plane and maybe use a smaller 45, like a medium? Can you give me a half by half, Paddy? Let me just put a half by half on it. We'll give it to Ben. The cups. Yeah, there you go. Okay, perfect. It's like we're almost there. It's really suckable. So one of the things here, Ashok, is a very soft tumour, at least in this sellar compartment. And we might be looking at a bit of the posterior gland tissue on the left-hand side. So we're just going to put a padding on it for now. Maybe. Just finger off the hole when you do it. Yeah, so that's normal gland. Question is it worth it?
Yeah.
Oh, no, there it is there. See the opening?
Yeah, let's have a 45 medium.
Or even a small 90 even. You just got a bone flake, yeah, you saw it. Take a different route. Nice. I think that's going to be too big, but have a look. See, just not there, anterior to it, there. See that? Yep, there you go. It's your pocket. So there's often a little frame in here at the back where tumour enters the cavernous.
Yeah, I have a 90 now. I can have the same size as this, I think.
Do you want to give me the bipolar? Do you want to give Ben the straight through cut? Small one? Do you want to release this bit here? Do you want to suction me just above? There you go. A couple little snips, I think, is all you need. Yep. Yep. Yeah. Do you want to get the bone? Give a small cups, small. You just put a big flake of bone in that spot. Can you see that? Yeah. It's okay. I saw it just drop in. See, that's the posterior compartment, Ashok, of the medial cavernous. It's a bit of a tricky area to work in. Hey, give me the flat one. I'll just need to lift up that gland. There you go. There's a Yeah. Or the other one we could do, give me the monopolar. Just give it a bipolar, see if it'll... Sorry, bipolar. The problem is that the you'll end up in the you're seeing the back edge of the horizontal carotid. That's the only problem. So even if we bring it forward, this thing sort of goes lateral behind the vertical component. No, there's no approach there, in my opinion. Yeah, the carotid will be in your way.
The carotid looks like there's a bit of separation from the wall, like.
Oh, I know what you're saying.
That's carotid there.
Okay, yeah, I know what you're saying. If you just skirt the free edge.
That's carotid
Yeah.
just there, right?
Correct. There's the carotid wall itself.
Yeah.
Yep. Yeah, there's carotid wall, that white structure. I just always think that's... Yeah, and I think that's not where it is. It's coming from the other side. I mean, I think we're better off. I know it's suboptimal, but maybe get the medium flat and see if you can scoop it out or something. Because at some point we're not planning on doing a total resection in this area. What's the benefit imparted? Just reducing volume and maybe keeping her potential radiation treatment to a single fraction, something like that. Yeah, there it is there. Yeah, no, you're right there. I know what you're saying. You're like, let's...
Maybe we'll have a look at the...
You going to take that, though? The tumour that's come out? Yeah, there you go. Perfect. Bit of tumour there. Would you want to wash it and have a look?
Yeah, just at the end, we'll have a look and see what's happening on the other side. Can I just the cups for a second?
Let's wash it. I think. See that, Ashok? That could be the bottom end of the normal posterior pituitary. And that's what it looks like, that sort of colour. Actually, I think that's pretty good, Ben. I mean, look at that. Yeah. And if we've got the bottom edge of it, that'll be fine. Yeah, 100%. It's sort of getting to that point, I think. So Ashok, Ben's opened up that posterior compartment just to make sure there's not a massive lump of residual sitting there. But you can see on the scans, it involves the lateral wall. So we're not going to get it all. We're not going to attempt it. It's much better off, risks of cranial nerve palsy like a 6 if you go chasing it too hard. And really more important here is actually making, she's got beautiful normal anterior gland preservation, and then we've just got a little bit of posterior on show. But you know what? That'll be fine. That's not enough to cause a problem. And the posterior gland can sit in funny places, like it's a little nubbin off to that side, It's just been pushed by the tumour.
Yeah, it will be very hard to remove all of that. So
Ben was good to pick it up early there. You can see most of the posterior is still intact.
Yeah.
You want to wash in the other direction, and I'll hold that open for you. And once again, a really clean view here. We can see that whole turn of all of that. That's the normal gland plastered over the left medial cavernous wall and then turning on to the diaphragma. Just not quite as hard. Bit of peroxide? Sure. I think the gland's okay with it. That's good. Yep, just a bit of a dribble. And there you go. We're done, Ashok.
Oh, great.
You know,
That's lovely.
subtotal resection, always knowing that we'll probably leave a bit in the... Yeah, perfect. Yeah, lovely. Really good, right? Yeah, it does look good. Yeah, very nice.
Very nice.
Very nice and clean. Dry, clean, lovely, Dr. Yonka.
I think that irrigation is a great idea. So really
Potentially, or maybe just observation. Can I have a curve sucker, please? Curve sucker. I'll put a tiny bit of surgery flow in this section here, right? Just because we had a bit of bleeding before. Yes, please. Is it got a control? No. Okay, some surgery flow here. There's still tumor there because it's not bleeding very much. You'd get some venous ooze, yeah. Okay, let's do that little preparation again for laying down of the flap. Yeah, 100%. Where's the neuropathic? Oh, no, we're done. No, we're done. Yeah. Medicine balm, thanks. Keep this little bit as a graft. Nice coverage, Ashok, with that little flap.
Yeah. Yeah.
Strip a bit of that mucosa so that the flap's sitting directly on things. So we just want to cover that top bit. Nasal pull. Straight sucker, please.
The patient is likely to receive radiotherapy. So nice to have that flap. So.
Yeah, 100%. And you can see that, we push the gyrotomy every time, Ashok. So, we're right up at the diaphragma. You could see the thin diaphragma on that case. And that's what we do normally, right? That's our normal opening. And I do think, you can't just leave super thin diaphragma exposed. Putting the flap over it really helps to ensure that it heals as best as possible. I'll leave that. Let's go caudal dissector. Nice and firm. Have this straddle opening. Sometimes I'll bipolar down here, just in case we've got a little branch. Fold our flap back. Smell cleft restored. There's a bit of a funny bit of septal swell body still here. So I might actually take this out because it's just going to stop our flaps from sitting nicely. Blakesley. No. Just to the last bit of that swell body. And just not going to make my flap sit nicely. Might have pulled out my silicon sheets. That looks good. That goes back. Okay. Put our silicon sheets in. Suture. Once again, just really making sure we lay these flat. Fill the posterior ethmoid with a bit of gel. Make sure that's all filled. Sometimes the bit of the basal lamella has been taken as part of the approach, but doesn't affect the function of anything because it's all part of the wall of the... Nothing here. Dead space, thanks. Put a bit of flow, surgery flow on everything. Just helps to decrease the ooze. Patty count's good. All right, Ashok.
Thank you.
Good
Great.
night from you guys.
Good night.
And well done.
One of the
Very
three
impressive.
cases, lots of interesting techniques.
Yeah, that's right. No, well, in the NHS, you've got safe working hours, right? You're not allowed to work now until like sometime next week, I would have thought.
So that's more Louis already starting in the morning. But yeah, thank you. Okay.
Yeah, bye-bye.
Yeah. Cheers. Bye. Bye. Thank you to all team. Thank you, Steve. And all the theatre team, neurosurgical team. So that was Professor Richard Harvey demonstrating endoscopic pituitary surgery technique. So we will have our next session starting. Within around 3.5 to 4 hours, we'll be joining Como Hospital in Italy, where Paolo Battaglia and Mario Turizoni will be showing their endoscopic orbital technique. So we will soon visit our supporters. This event is supported by Medtronic and Karl Storz. So we'll visit their product information and then have some live recorded videos of Professor Richard Harvey and also the Propel implant from Professor Hisham Saleh. We'll see you shortly for the next case. Thank you.
Hello, greetings from the Scientific Committee of the Global Rhinology Network. I'm Ashok Rokade from Winchester and University Hospital, Southampton, UK. We are thrilled to welcome colleagues worldwide to our 6th live event in endoscopic sinus and skull-base surgery. As a non-profit organization, we are all about advancing professional development led by surgeons for surgeons. Distinguished surgeons from across the globe are showcasing cutting-edge techniques in this live event. With over 20,000 global delegates and growing viewership, it is generating quite a buzz. You can catch it now as a recording on our GRN Academy YouTube channel, highlighting individual clinical cases. For free access to our educational events and content, become a member of the GRN Academy by visiting www.globalrhinology.org. Now let's kick off today's event with my co-host, Catherine Rennie from London. And big thanks to Medtronic and Karl Storz for their strong support to our endeavor.
So we have the third case now. I'll show you the slide. Let's put the slide to show you the history of this patient. So this patient has Samples triad, chronic sinusitis, nasal polyps, and asthma. 39-year-old. She already had 5 previous operations. Last one is the 2018. I heard you talking about the biologics. She's been on biologics, but the biologics help her asthma, but not the polyps. And this is a specific one for polyps, the Pilumab, which is against IL-14, and it is supposed to be helping with the polyps. Just shows an example that biologics are not the magic for every case still. So she has not responded to various biologics, and currently she's the Pilumab. The polyps are large, she's got facial pressure, she's got frontal headache, and she's got obstruction in the frontal ethmoidal recess with polyps also in the ethmoids. And she's also on betnazole drops because that's the only thing that was effective for her. So when we examined her, she had grade 2 polyps in both sides. And she has some septal deviation, but interestingly, she had septal perforation before that we repaired. So I don't want to do too much to that septum. Let's show you the scan now with the next slide. So you can see the scans, the axial, the coronal, and the sagittal here. We don't show the axial. We show the parasagittal here to show the space, anteroposterior space in the frontal sinus, which is nicely wide. So we should be able to get a nice open Lothrop here. We'll do Lothrop because we want to open these sinuses and we want to improve the drainage and we allow the medical treatment to reach into the frontal sinus, which causes her a lot of problems. So we're going to improve, we're going to remove all these polyps and then do a Lothrop. And I will, in the end, put a Propel stent, which will secrete steroids for about a month, which is very useful in a patient like this who had multiple surgeries to try to actually improve the drainage in the Lothrop and prevent any inflammatory changes during the first healing period, in the first 4 weeks or so. So we'll go ahead with the case. I'll go and scrub, and then we'll see you during the case. Thank you very much.
Great. Thank you very much, Hashem.
Thank you.
So interesting to use the Propel stent in the frontal sinus there to give you a long-term steroid slow release to hopefully keep that Lothrop cavity open for longer. I've tried them in a few of the frontal sinuses and I found them quite useful, but again, they're expensive stents, and people as alternatives in the past have used fashion silastic stents in order to keep that frontal drainage pathway open, and using mucosal flaps locally can be quite helpful at trying to keep that frontal from closing down once you've drilled it out completely. Ashok, what techniques do you do to try and keep that big frontal recess wide open?
I think I try to develop the local flaps. I think they are important if you have vascularized flaps. They tend to reduce the narrowing of the frontal ostium. Then also, in addition, you can also, in certain areas, use a pre-mucosal grafts, making sure that the mucosal site is laid in correctly. So the combination of flaps and the grafts. So that's my technique. I don't necessarily pack it with anything. Certainly, I don't have any experience with Propel stent, which I have heard about it, I've seen it, but due to its cost and relatively they're new, so I haven't really tried anything. No experience of that. So have you tried them?
Yeah, so I've used a couple of Propel stents now for frontal sinus. I tend to use them in revision cases rather than primary, just because of the cost issues within the NHS. So first time round, I don't get access to it. Whereas if they're having revision surgery, we want to do everything we can to try and keep that frontal sinus as open as possible, especially where there's been new osteoneogenesis and things like that happening, and maybe lots of the mucosa is involved in disease, so the mucosal flaps aren't as good as you perhaps want them to be. I know that Shaz Ahmed uses sometimes nasopores soaked in betanazole to put in the cavity after surgery. I haven't tried that, but he finds that quite useful for slow release of betanazole after surgery. And as we were hearing from Dr. Jane earlier, he uses Marisol patties soaked in steroid for 4 days in the nose after all of his sinus surgery. So that's an interesting, similar thing. Rather than using a Propel stent, something like that could also give you that local steroid immediately after the surgery. The Propel is quite nice because it can hold your mucosal flaps in place and it sits in the frontal sinus opening really nicely. We've looked at a few cases we've done at Imperial, and I think we're about to start a trial with them shortly. So it'll be interesting to see what the outcome is from the trial for it. But certainly the revision cases we've done with it, they have had some really nice results.
And how long do you tend to leave them in?
Oh, sorry, Ashok, I didn't quite catch that then.
How long do you tend to leave the Propel stents?
The Propel stent reabsorbs. So when we see them back for debridements in clinic, you can still see them at the 2 weeks. At the 4 weeks, you're beginning to see that it's broken down, but there's still bits of it left. And then at the 3 months, the stent is reabsorbed. So you definitely see them there in the beginning. You can often see some mucus on the stent, but they sit quite nicely in position. And the shape of them, particularly the contour, is almost funnel shape, which kind of holds a graft in place quite nicely. And if you've got a very big frontal sinus opening, the Propel works quite nicely. But there's also a mini one if you're just doing a unilateral frontal sinus. So there are a few different options with them. I think they have 3 different types: the contour, the mini, and the standard. So, and as I say, you don't have to take them out, which is quite nice about them. They dissolve over time, and they slowly release mometazone, which is obviously what we use in our Nasonex spray, and really nice to help the mucosa heal and prevent that edema that you can get there.
Yeah, so I think we try and all these measures to try and keep the neofrontal ostium patent and as widely patent as it can be.
Yeah.
However,
and I don't want to,
it does have a, sorry.
I don't want to sound like a salesperson for Medtronic. I want to let everybody know I'm not paid by them, and I have no investment in the company at all.
Absolutely, same disclaimer from me. So,
yeah.
But the point I was making that whatever we do, all these measures are supportive measures. But there is still a tendency
for the neofrontal ocean to narrow down. So naturally, it narrows down by a third in a year's time. So it is absolutely vital to make your first low-throat cavity with the ideal shape, with going from skin to skin laterally. Then anterior posterior diameter opening is important, drilling all that frontal plate, making it really thin so you see it flat. So there should not be any ridges along that side. Then drilling it down further to your skull base, right up to the skull base, right up to the first olfactory neuron, making sure you have dealt with the interfrontal cell correctly, then reducing the interfrontal septum right to its very end as much as possible. The shape of the cavity, and also not to forget the T, when the posterior septal window that you create, the shape of that septal window. So all these things matter.
Absolutely, Ashok. These measures, then the propels and things, they won't make up for poor surgery, and it's really important that you get as good a diameter to that lothrop cavity as you can at the first surgery and when you first open it up, because no amount of local steroid is going to keep it open on its own. It has to have been a good surgical procedure at first. But I think they're back on in London, so I will hand over to Professor Sala. He looks like he's just decongesting the nose with those Maricel patties. Mm.
So I'm just prepping the nose. It looks horrible here, very inflamed. So I'm putting the topical adrenaline. It's very congested and it's very tight. So I'll just put it here and wait for a few minutes.
As you all can notice, all these patties have a string attached to it. And we would not be allowed to use free patties in the nose from a safety point of view in our departments. All have to have that radio tracer and also the strings attached. So I'll count it before and after. This is just a safe surgical practice.
So Hesham, can I ask, has this patient just prior to surgery had any oral steroids as a preoperative prior to surgery? And do you tend to use that? Or do you give any antibiotics preoperatively? Or do you just give them postoperatively?
Yeah, we didn't get any preoperatively, but intraoperatively, yes. Antibiotics. But no steroids, given steroids. Just dexamethasone intraoperatively, yeah, not preoperatively.
Right.
This looks very inflamed, you can see, and it's very tight as well. So we're just going to have a look around. Have the suction. So you can see the polyps here. So you see how the whole mucosa of the nasal cavity is inflamed, not just the sinuses, even the septal mucosa there. This is the antrostomy, the middle meatal antrostomy here. This is within the ethmoid cavity, which is already open. There's polyps here. And the septal perforation that was repaired looks intact here, but it's quite tight anteriorly on this side. also on the other side. I didn't want to try to do septoplasty because of the history of the perforation. We'll try to bypass this if we can. Let's have a Freya to have a look at this side. This bulge here, we'll probably have to do something about. But we'll just try to see beyond it first. So again, here you can see the roof of the ethmoids and the polyps there. So we may be able to just bypass this because we're going to create the window here anyway. So I'm going to have a look with the navigation because we're using navigation here. I don't know if this is showing in your screen or not. So I can't even see if there's a middle turbinate here. So it doesn't seem that she has a middle turbinate, but I am putting my navigation into the frontal smaller recess here. If you could see just there, next to the septum, there's no landmark at all. There's nothing here. There's no turbinate. So the frontal smaller recess seems to be here. And this is the right side, the left side, sorry. And I'll go on the right side.
Yeah, we're seeing it on the navigation screen now, Hesham. So we're just getting a view of that.
I am in the other side here. So we can just see we're just in the ethmoids here. If I go, because of the tight septum, it's a bit difficult to show you, but here. Again, I'm on these polyps here, but there's no middle turbinate. So that is like toward the frontal smaller recess there. There's no middle turbinate. So I'm going to have to start by removing all these polyps first. Then I plan a lothrob after that. So let's have a straight debrider. What's the speed on? Oh. No, we need to be on. We need to change that. Can somebody put it in a straight shot? Should be on a straight M5. We're just adjusting our debrider. No, not stylus. That's it. Let's put it a bit slower, 3000. That's it. Right, so now we're going to clean these polyps to start. So I can see what seemed to be a remnant of the superior turbinate here, maybe, but the anatomy is completely gone, basically. So we'll just try to gently remove these polyps here. And luckily we have a navigation here. It will be very useful in a case like this because you can see there, so sphenoid is here. These are like some of the posterior ethmoid cells in the back, just below the skull base, which is just there. It's just here. So we just gently clean this. Nina, can we connect the frontal sinus sucker? Here is the skull base. You can see it up here. So you can see the dissection is not reached the skull base previously, so we'll remove these a little bit more. Okay, let's now have a navigation. I'm going to show you. So posteriorly here, I could see the skull base. Yeah, so I've reached this. So I'm coming forward now. That's the safest way to do this. She also has some osteitis, so the bone will be a bit thick when you try to remove him. Let's have a navigation again, so we'll just find out where we are, I can see something looks like an agar nasal or into the frontal sinus here. So we have to link all this. So that seems to be the remnant of the middle turbinate. It's just there now. We can see it now. Okay, so that's here. We check that with the navigation probe. Seems to be about right. So frontal sinus coming that way in this area. Suction. So here it is. So we found the frontal sinus just there by following the landmarks, which what we have left, which is this tiny bit of turbinate here. And this here, as I said, it's an agar that is half open there. I mean, I appreciate that anatomy is completely destroyed, but you can see the shape of here. So lateral nasal wall turbinate, what's left of it. So I'm just going to drill a bit or debride a little bit of this mucosa to create a bit more exposure.
So Hesham, do you use navigation on all your revision cases? Do you use it on any primary or Lothrop? When would you get the navigation out?
All the Lothrop, I always use navigation. And in fact, when I started doing Lothrops many years ago, I wouldn't have been able to do it if I didn't have a navigation. And at the time, nobody in the UK was doing Lothrop endoscopically. So with the help of navigation, I was able to do them. And especially with cases like this, with revisions, obviously, but even, I mean, obviously, most Lothrops will have some surgery before anyway. But any case of revision, I'd like to use navigations as well. I mean, you see this, like here, because of the destroyed anatomy, you are very near the orbit and very near everything else. If you don't have a navigation, it's a bit more risky. So we're checking all the time with the orbit and everything. So I'm going to debride a bit more of this. This is just, again, on the lateral nasal wall, but it seems to be a remnant of the onset here, there. This is a remnant of the onset here. Let's have a 45-degree Blixley.
You mentioned about your Lothrops, you're doing it for many years now, and for one of the first surgeons to do it in the UK. So reflecting on your journey, what things have changed since you started?
Okay, the brother.
Hesham?
Yeah?
Sorry, I'm not sure you heard the question.
No, I haven't.
Sorry. So since you started doing Lothrops many years ago, as one of the first surgeons in the UK, what things have changed?
Well, not a lot, to be honest. Just availability of more of the curved instruments, probably. Because I did the first Lothrop maybe in 2002, and I had a navigation then. So the techniques changed slightly because you put flaps nowadays. So we didn't put flaps in the past, although sometimes I don't use the flaps anyway. And you have more of the curved debriders and so on. But otherwise, nothing much, to be honest.
The technology and definitely this fast bursts and all that. Recently.
So mainly it's with the equipment. The techniques are with the equipment. Yeah, see the orbit is so thin here. So if I'm pressing on the orbit, you see this is very thin, how it's moving here. So let's have a suction. So this is the frontal sinus. So the main thing is that we have this. And I think I cleaned enough now, all the way from the skull base posteriorly to the front. So let's leave it here now and go on the other side for a bit, and then come back. So let's have some patties. It's okay. Yes. So I'll leave this to dry out a bit and then come back after we clear the other side. So let's have the flares. I'm just going to push the septum out of the way. So you can see this is the side that is really tight. We'll try to bypass that septal deviation because beyond that point is okay. Posteriorly here. And it's actually bony, it's not cartilaginous, it's quite hard. This side seems to be a bit less inflamed somehow.
Yeah, it's really narrow access on that side. You can see with that deviation.
Nice one. So let's clear this now. So I've got the polyps here. Not much in this side, not like the other side. So we'll just clear them out. So we'll do the same. We'll try to find the skull base and just clear everything from back to front. Again, here is the very, very narrow sphenoid. She's got a lot of osteitis. Actually, let me show you on the scan. Can I have the navigation? You will see the bones of this sphenoid. This is a sphenoid sinus. You look at that, how thickened they are. Can we show that image here?
Yeah, we've got it, Hashem. We can see on screen. We've got you split side by side, the endoscopic and the navigation picture.
See how thickened they are. So the sphenoid sinus is very small. Suction. Let's see. Okay, so let's try to use the navigation to see where the frontal sinus is in this side. Suction again, sorry.
So, Hashem, a lot of people use the middle turbinate as part of their landmarks for creating their Lothrop cavity and where to do their septectomy and things. Without middle turbinates, what do you do, and what would you use as your marks for where you make your Lothrop opening?
Yeah, the only way is to use the navigation here because we have nothing. So I'll use the navigation to find my landmarks. So here I'm in the skull base. So I'm going to go a bit anterior now to see it should be where it should be, where I expect it to be, which somewhere here. So it's roughly there. So I just have to mark it with this navigation system. That's the only way you can find it. So what I'll do is I'm just going to keep clearing until we find some access to the frontal sinus, which is about there. And then I'll start opening things. So let's have the brighter. I may, if this septum keeps getting in my way, I may just have to start work on it in a minute, but let's just try to clear a bit more. So I can find the skull base just there. Here it is. So I'll just clear these polyps on the skull base. And try to come more anteriorly here. My maxillary sinus, again, the maxillary sinus is always a good landmark, is always nice because it's not going to go anywhere. So it's always nice to look at it. So at least you can tell where the floor of the orbit is. So our frontal sinus should be in this area, which we still can't see anything, as you can see, and there's no turbinate whatsoever. The other side, we found something, some remnant of the turbinate, but here nothing. So I think what I'm going to do, because I can't find it, it's a bit tight here. I'm going to have to try to remove that part of the septum because it's going to be part of the window anyway. So let's have a look at it. Let's have the navigation to try to mark where we're going to open that septum. So navigation is very useful because you can find where the floor of the sinus is. So if you put it up, try to find where the posterior part, which is roughly there, you can actually mark this bit on the septum. So I'm going to try to create like a little cut with this into the septum. See how tight it is, guys? It's not easy to put the scope with the navigation in the same area, but it's just there. So I'm creating a small cut onto the septum with the probe of navigation, right? Roughly where I want it to be. And I'm going to create a window here. Let's have the frieze first. And the suction. Try to get mucosa, a bit of mucosa from this area here. Let's have the straight suckers actually to use first. And the navigation probe again. Okay, let's see. Yeah, navigation is playing a little bit, so let's just create the window anyway. Let's have a knife.
Nisha, what's your plan for frontal? Are you planning to establish both the frontal recesses and then go lateral to medial?
I'm gonna probably go from the left side to this side because the left side I managed to find it, but here it's very tight because of the septum, and there's no landmark at all here. So I'll try from the other side. Let's have a frieze. So just lifting them because of left here. Okay, let's now have scissors if you got them. No, the Stamberger. So I'll just take this because if I can, to see if I can use it later on or not. Blakesley. No, it's straight, but it doesn't matter. So here's a piece of mucosa. Just keep that one for us. And Prius. So this part of the septum is interestingly bony. It's supposed to be cartilage, but it's very tight. Remember, she had multiple surgeons. She had a repair of a perforation of the septum. So it's quite hard. Let's have a navigation again. Yeah, so I'm pointing at the frontal sinus just about here. So we know roughly where it is, but we really need to find it from the other side. I'm going to remove a bit more of that mucosa here and try to remove some of that bone. Let's have the debrider. So I'm just enlarging the window really because I need quite a big window because of that septal deviation. Let's have the freers. It is very bony, actually. And I'm going to look on the other side now because I've removed the mucosa. I just want to make it equivalent on the other side. Let's have a teleforceps just to get it back out. So here we have a turbinate, which is in a way is good, like a part of the turbinate. So normally you landmark this part of the turbinate. Let's have a suction, just show you again here. Normally landmark is you go beyond. Here's that what's left of the turbinate, just there. Let's have a Freas to show you. So normally landmark is, see what's left of the turbinate is here. Normally you just go beyond that turbinate and you create a window from about 4 millimeter, 5 millimeter beyond the attachment of the turbinate all the way anterior for about 2 centimeters and down to back. So we'll try to do this here. We'll mark it and try to do it as well. Let's have the navigation again.
Hashem, here you're using the inside out. So you're starting with the frontal recess and widen it up. Do you ever use the kind of outside in where you start drilling on the frontal beak? And what would be, why would you want to use one technique over the other?
I use this from inside, like from find the frontal recess and go. When it's very complicated like this one, the ones that you have like a nicer anatomy, I just go to the floor. It's much quicker from the frontal beak itself, from the middle. After you create the window, the first thing you do the window, and then I go straight for the better anatomy. But this one is quite tight, and there's no landmark. So I'm now marking the window on this side. You can see I'm just putting my navigation right up here where the posterior part of the frontal sinus is, then going down, and then you follow that anteriorly here. So knife. So we'll clear this. So I'll try to get some mucosa from here. And normally the level of the flap goes at the lower border of the turbinate, but obviously we don't have it, so I'm just estimating it here. Prius? So try to get this mucosa out. It's quite scarred because she had surgery with flaps for repair of perforations, where it tears a little bit. But still, we have a bit of mucosa, which is not bad. So here it is. Let's have the scissors. And Blake stick, straight Blake stick. Okay, sorry, it's still there. Oh, let's have the scissors again, sorry. This is a nice piece, this one. It's better. No, can I have a straighter one? Or to the left? This is a nicer piece than the other side. Okay. So a nice piece to keep. So now let's see if we can create the window by removing the cartilage or the bone, or that bone really. So see the exposure here. Frontal sinus is here somewhere, and that should lead us to the other side that we created as well. We could check it again with the navigation. Can I have the navigation probe? So the posterior extension is just there, just where the floor of the sinus or the posterior wall of the sinus, and here, and then opens there. So let's have the FREERS. Maybe I will remove this. Actually, the brother for a second. So now let's try to remove this part of the window, the bony. It's actually bone, which is unusual in a young person like this. Usually it's just cartilage, but it's completely calcified. So we're probably gonna have to drill it. Let's have a chomper. This is very hard. So remember here, we are just under the nasal bone. So you're not at the risk of causing fracture into the skull base because you're very anterior here. But you still have to be careful. So it's best to cut it than pull it, basically. So I'm using a forward cutter. Here you go. You can see how it's just bone here. Okay, good. Let's have a Blakesley. So you start seeing the window now. It's always good to do that window early because then you could see where you are and you get access to the other side, because without this window it's impossible. This is really the most important step if you're lost. You have to open the window first. So I'm just looking from the other side, just seeing my window. It's there. So it is connecting. So just remove all the hard tissue, the bony tissue. And when it's complete, when you can see both middle turbinate, which we don't have, but we'll do something else, then you know you've opened a nice window that's sufficient for you to work from both sides. So we can start, we're looking at the other side, but we still can't see where the frontal sclerosis is, but we will see in a minute. We'll have to enlarge a bit more. So let's have a backbiter. Now this perforation is quite high and it's quite posterior. See, you can't see it when you look straight in the nose. You have to look up. So it's away from the air current. So it doesn't tend to crust or cause problems with the airway. So it is okay. They're just bony here. Okay, let's give you that again. So a bit more to remove. Let's have it again. See, it's all bony there. Here it is. And suction. Just trim a bit of mucosa just to get a bit more space from that window. So I've removed a lot of the bone now. So just don't stop making the window until you make sure it's big enough. So we just have to keep checking it until you know that you can see everything. I can start seeing both sides, as you can see there. So just clear all this. Until you reach right up in the floor of the sinus, which is about here. So it's still a bit of cartilage to remove here. So if we start looking, we can actually see from both sides now. It's something that looks more useful for us. Let's just remove this bit of cartilage here. Let's have the Blakesley, straight Blakesley. And the septum now is going out of our way a little bit. So let's keep this bit just in case. So this seemed to be a bit cartilage here. It's a bit better. Or is it bone? I think it's still bone. Yeah. So this is our window coming nicely. I think it's almost there. We will clean everything in a minute and show you a bit more, but let's just get all the bits out. Let's have the debrider. Just to clear everything, because all the area that you want to clear is where you're going to create that drilling. I mean, you could almost see where the lophrobe is going to be. You're going to start in the frontal ethmoidal recess like this, drill this, which is the floor of the sinus, and then join it to the other side. You see how everything is very inflamed here, not very friendly. The polypoid here, but we're probably not going to remove a lot in this area. So I think it's almost enough. Okay, so let's have a look with the navigation now. So we're looking at frontal sinus in this side, here, and that's the beak. This is the beak here. There. If we put the navigation in the middle here, that's like the floor of the sinus and then to sinus septum. So we want to drill that way, forward like this, and then like this, and then like this, connect to find this one. And this one is here as well. So we sort of found it as well. But obviously you see how horribly inflamed and bloody and everything. It's not the usual nice one that you want to do, but we're doing it for you. Can I have the backbiter? So I'm removing a little bit of that cartilage in the bottom because you don't like to have a lot of exposed cartilage. So, and I say again, without navigation it will be harder. Navigation is very useful to confirm where you are, just to find out and confirm where you are. So just remove this piece of cartilage so we don't have exposed cartilage anymore. And that makes your window big enough. A window that is not big enough will lead to closure or stenosis of the lothrop, and will cross and will know you so much. Will be on your way. Okay, let's have a irrigation now. Can I just have a 45 Blixley for a second? Just remove this bit here.
Hisham, if that is all right, Dr. Satish is just explaining about his case, so we'll briefly visit him and come back by the time we prepare for that.
Hesham, we're just going to go to India for their case introduction, and we'll come back and join you.
Okay, Doc.
Thanks.
Are we off?
Yeah, shall we connect to Nagpur, please?
Horrible case.
Yeah, you're still on, Hisham.
Where is Priscilla? This is horrible.
We can still hear you, Hesham.
Yeah, we're almost there anyway. We're going to finish.
Okay, studio, can you connect to Nagpur, please? Hello, Dr. Satish.
So what I'm going to show is, for the sake of demonstration here, we'll remove this and we'll be using pre-lacrimal approach to marsupialize this region. Okay.
Yeah.
Pre-lacrimal means our access would be anterior to the lacrimal system without damaging it. There are two approaches. One is the modified denture.
Yeah.
Funny. I think it's not accurate.
Okay, Hesham, we're back with you. We can see what you're doing now. We were just in Jaipur and they're about to do a pre-lacrimal approach for maxillary sinus. So they were showing us their scans, but we're now back with the modified Lothrop.
Function.
So it looks like you've got the frontal sinus ostium there. Is that right?
Yeah. So So I'm here. I'm looking now on the left frontal recess. A bit larger. So what I'm going to go forward.
Yeah.
Until I reach the intersinus septum, which will be about here, and then I'm going to go to the right frontal sinus to join them together. So
right.
Looking here underneath, do you have a suction frontal sinus? So I put the suction.
Have you got the frontal recess on the right side yet, or you're just going to go to it through the left from the left?
Yeah, but it's not as well defined. So it's not as well defined as the left side. Sorry. So it's just there. It's a bit tight here. So because of this, I'm just going to start on the left. It will be easier to do.
And Hesham, just out of interest, what angle scope are you using at the moment? You still on a 0? Have you switched to a 30 or 45?
I'll switch to a 45 soon, but not yet.
Okay.
Let's have an application. I'm going to show you if we can see the navigation. So here, it's not very accurate now. I should be pointing to the frontal beak about there. Let's test it. Stopped working for some reason. No, it's not working anymore. Now look, it's a bit off. But off now. So we need to readjust. Let's have the. So I'm going to open further. So now I'm using both nostrils. So my scope is in the right nostril and my debrider is in the left one. So I can basically open things a bit further here. Let's have a Blakesley 45 degrees. Suction. Debrider. Seems to be a cell. And I have a frontal sinus seeker. And suction. Okay, let's have a Blakesley 45.
Not uncommon entities. Still not under.
So I've enlarged the frontal sinus from right inside now. Maybe I can now change the 45 so I can show you the cavity. I'm going to change to 45 degrees. I can show you inside the frontal sinus. And then I'll start drilling. Oops. White balance. Right, so let's have suction now. You don't have the other frontal sinus sucker that goes like, the light goes from the side. It'd be easier, the endoscope. I mean. Yeah, the scope. So look at the frontal sinus inside, yeah? Look at all this polypoid tissue here. So in a minute now, I'm going to start drilling. So in a minute, I'm going to change into my Midas drill, which is a faster drill. So just remove that polypoid tissue here.
Is that the 40-degree debrider there, or 60?
Yeah. So here we are. This is the cavity of the frontal sinus. This is right up there. And you can almost see that we're not very far from the anterior wall. So let's have the Midas. So I'm going to use the drill. The faster drill, the Midas drill. We need to change it there.
And what sort of burr do you use on the drill, Hashem? Do you use a diamond or a cutting, and what size? Cutting.
Cutting. 4 millimeter cutting.
Okay.
4 millimeter cutting. Okay. That's it. Yeah, perfect. Let's have the suction. So this is very fast drill, so you have to be very careful with it. So don't start with the maximum speed. And the problem with these, you don't have suction, but they have irrigation. So let's see if the irrigation is working. Oh, yeah.
For the trainees who are watching, I would suggest if you're in the initial stages, use a diamond because it's a little bit of a margin of error for that. Cutting is okay for expert, experienced surgeons like Hisham. But do use cutting if you got enough wide space. But for a narrow recess like this, for surgeons in the initial stages, the diamond will be a better drill. You agree, Hisham?
Okay. So this is a very fast drill, so you have to be careful. So just, actually, it's too much irrigation here, so let's just decrease it a bit. So see, I'm not going full speed. I'm just gauging my speed first, just drilling forward. And if you see what I'm doing, I have my scope in the right nostril and the drill in the left. And then we can swap again. This is bringing my opening forward. So I'm drilling the frontal beak now. And I have my suction in the other nostril. I just leave it there. Nobody's holding it. Because otherwise it's too much irrigation anyway. So now I'm putting both of them in one side.
See how carefully is working just on the beak and avoiding any contact with the posterior wall.
Just the frontal beak.
You're feeling the reach and flattening it down. Just like we drill the mastodantrum.
So here we are. So we're already opening widely in the frontal sinus. We need to drill here laterally so we get to the subcutaneous tissue or the skin, like PJ1 will say. So this area here laterally. So I'm going to get this. So you need the widest possible loss drop or opening. So just clearing this soft tissue from it. And I'm not pressing full speed. With this full speed, the drill will just go too quickly for you. So if you're not sure, use a diamond burr. I like using the cutting burr. I control the speed like a car. Just press a little bit and you don't go full speed. So we started to see more into the frontal sinus. And when you see the frontal wall, then you know you reached your level. I can see it already. Look at that. So it means we can go toward the right side in a minute. But I'm going to just drill laterally first. That bone on the lateral wall there, I need to thin it a bit more here, a little bit here. And if you think about where this bone is, it's just underneath the nasal bone. So if I put your navigation, this, I don't know if it's accurate enough, but we'll, okay, so it's just roughly there. Yeah, maybe it's okay now. Or is this not moving? No, look at it. So it's not accurate. It needs to be re-registered. So maybe we'll just re-register it. Let's do it. We're just doing a navigation again so I can show you. Okay.
So that's the infrared navigation you're using there, Hesham, is it? With the surface matching rather than it being magnetic one?
That's right, yeah. I always use surface marking. It's quicker. The electromagnetic may be a bit accurate, but it's had a lot of wires and cables and takes a long time to register. So I've always preferred that. Okay. Check landmark. Can I check? Is good? Yeah, it's good now. So we'll now have a look with the navigation to show you.
I guess it shows that you can't just rely on navigation. You have to keep checking all the time.
And that's if I didn't know where I was, I said, oh yeah, here we are, and go for it. But obviously, I knew it was. So if I go with that bone I wanted to drill, just about here. So see where it's pointing. It's inside the frontal sinus, but also, I'm just going to put it from the other side to show you better. So here is the navigator. So that's the bone I want to drill here laterally. It should be under the nasal bones. Yeah, see the nasal bone is just underneath it. That's where it is, although it's not moving. So that's where we're drilling. It's a bit lateral, but that's gonna give. Let's try again. Yeah, let's try inside. Still not perfectly accurate, so, but we know where we are. So let's have a drill. So we'll go and drill a bit more here. Can I have some more anti-fog, please? Anti-fog. And let's check if we've reached the skin yet. Not yet. So I'm pushing in the skin from outside to see if it's moving, but not yet. So always move with this drill. Don't put it in one point and just drill because it will just create a deep. Now we've reached the skin. I can see it here. When I'm pushing, it's a little bit of movement. It's not very obvious yet, so we'll do a bit more. Why do I do this? Why do I have to reach the skin of the subcutaneous tissue? Then you know there's no bone there to grow back. That's the idea. And then also it indicates that there's no more you could drill. Yeah, it's quite thick, so we're doing it gently just to make sure we're not doing too much. Okay, more. In the scope. So we have a big opening here. I'm just going to show you the other side, then we'll come back to this. So let's see if we're going to go to the other side now. So we know that the other side is just going to be somewhere here, somewhere there. The other frontal sinus is just here. So we could just go from here and drill again and back there, forward like this, and then join them, or you can go from left to right. Let's have the navigation probe for a second. So we show you this. This is the frontal sinus on the right side. Yeah. Not accurate, but it is. Let's have the curette. So we could just bring this bone a bit forward here. Let's have the Blakesley 45. And suction. So it's a bit tighter in this side, the frontal sinus, but the bone is not very thick, so you can just remove it a little bit like this. So let's have again the 45 obliquely. So we're already seeing into the frontal sinus, already starting to make that shape of a Lothrop procedure, which is connecting these two sinuses together, basically. So it feels a bit tight. If you look at the scan, there was actually like another bar there, or another like wall. Let me have a navigation, I'll show you. So maybe that's what I'm hitting here. Somewhere there, but I'm gonna come that side now. I'm gonna drill this way to here. So if I'm putting this is the thick bone of the middle septum, or the sinus septum here. I'm gonna go through it. So I have the suction, so all the secretion will be sucked out. I'm trying to shake the blood out, but sometimes it doesn't come out. Sometimes I use the sheath, which is the endoscope. Sometimes I only use it actually for Lothrops. I don't use it for anything else. But we haven't used it today, so because with Lothrop you're working from below, so you're actually underneath the drill. So that's why you get a lot of things, blood and so on, that comes in your affect your endoscope. So we can start seeing more and more on the other side now. So I lift my sucker there, just staying there. Yeah, so one day they'll be invented one of these fast drills with suction as well. If you saw the scan as well, they are the left side, the sinus is bigger. So can we see the intersinus septum? So let's have a look inside now. So we just below it here, look, that's it. So we'll continue drilling. I'm just going to point it here. Put this here. So I'm in the intersinus septum. See exactly where I am now. Okay. So I'll see the right sinus is much smaller than the left one. So let's open that now. Continue with the drill. So that's where endoscope would have been useful here, but we're okay. No, I can't put it on now, doesn't it? Just this bit when I'm below that drill anyway. Suction. So thin bone here, so I'm just going to remove a bit more. Let's have the Blakesley, so 45. I'm trying to see if I'm close to the right side, I can connect them easier from the right to left, or just continue as I am. Suction again.
Kat said you could try some of the electronic burgers. They have suction.
Okay, well, we're always
it's only
thinking.
like only 30 kg.
No, I'm gonna have to connect it here.
Yes.
Yeah, well, soon we'll use the, after I do this bit, we'll use the finesse guard. So I'm almost there now. Because this bone, see how thick is this? Use the other ones, you take forever. Yeah, so that's good. We're almost there. So suction. So soon when I reach the other one, because this bone is so thick, I could use the other drills. This is the right side. I could use the other drills, which is a bit slower, but because the bone is so thick, I prefer to use this faster drill. When I completely open this, then I'll refine things with the finesse burr, which is the one that connects to the normal debrider and has suction in it. Here we are. So now we've got connection. Will it have suction? So see that other septum here. The sinus had two septums, this one and this one. You can see that in the scan. So obviously we'll bring this down as well soon, but this is the intersinus septum. This is another septum into the frontal sinus. So let's drill that one, finish it first. Okay, so let's get ready with the finesse because now I'm opening here. So now I have a big opening, but I need to enlarge it more. So let me show you first, and then we'll change burrs now.
So for some of the people just tuning in, can you just go through where your landmarks are now and show people the posterior table, anterior table, and lateral walls so they can see what's going on?
Okay, great. So this is through my septal window now.
Yeah.
Here is the left frontal sinus. This is the posterior wall of the frontal sinus, and this is the roof, and the anterior wall is here. And this is the intersinus, or what's left of it. And this is the right frontal sinus here. It has a laminated wall here, another wall there, just like a small one here, there. So that's the rest of the cavity of the frontal sinus on the right side. And this is the posterior wall here. And anterior wall is just, we can't see it yet. So I'm going to remove this, and it will be into the frontal sinus. This here, part of the posterior wall, which we're going to drill down, because we want to reach the anterior the most anterior olfactory nerve, which is going to be about here. Here.
Yeah.
This is and the nerve. See there? That's coming through a small cavity here. This one there.
Yeah,
So
that's nice.
So we could drill this bit, this bit as well. So I'm going to drill this bit more first on the right side. Open it further. Yeah. And then we'll change into the other drill now. Is it? No, it's not changing. You have to spray. Somebody has to press this. We'll just change the drills now. No, it should be 12 or 30,000. We need a drill. So I'll press from here. Yeah, put up, put 30. Perfect. So we've got the drill now. So this is the curved one. So this is 40 degrees. This one obviously just connects to the normal debrider, so it has suction in it. And like I said, I could drill a little bit here as well. Can we decrease the irrigation a little bit? No, down. Yeah. Maybe a bit more suction. So you can see now, this is nicely open in the left. We need to open the right side a bit more. We'll just continue with it. So if you look from here, let's have a drill. So again, my camera is still on the left, on the right nostril, sorry, and my drill is on the left side. You always have to be careful when you drill this. I'm not pulling on full speed. Remember I said the first olfactory nerve is just there. So we just anterior to it. And that's again the intersinus septum. We'll drill it a little bit more. And I showed you earlier, there's like a lamella here. Gently take it off as well. So the idea is to create a very large stoma, basically, as large as possible, and then we're going to reach the skin subcutaneously both sides. I'm going to now put my scope in the left nostril so I can drill more onto that right side, so I can see a little bit more into it. See how smaller the right sinus compared to the left one? Because the intersinus septum is toward the right side. You can see the intersinus septum, you can see where the right sinus is. So we need to drill a bit more here, so let's have a drill. Getting there nicely now. So we're almost opened the whole thing, but not yet. You need to get the maximum opening. Suction. So every now and then we check. So I need to drill a bit more here. Okay, drill. So I'm now putting my drill into the right nostril. This is unusual. Don't always have to do that. While my endoscope is in the left nostril. Just to drill anteriorly. So the whole purpose, as I said earlier again, just creating the largest possible hole. So let's check this. Should I smile? Excellent. See, now we almost have symmetric holes. But remember, obviously, the size of the sinus itself is asymmetric anyway.
Hesham, do you notice a difference between the previous 12K drills and the new 30Ks that you're using for the finesse?
Definitely, much better. The finesse obviously is much slower, but it's good. It's comparing to the 4K drills that we used to have. This is much faster, double the speed, more than double the speed. So it's a lot faster. So it is much more quick, really. Can I have the Blakesley? I'm going to remove that bit of mucosa here. For 45. Yeah, it's a lot faster. Take this.
Hisham, that was a great cavity. So in the meantime, can we just check on Nagpur whether they're doing a modified Denkers? So you just catch up with them and be back.
So let's have the drill again.
Hesham, we're just switching to India, okay? So we'll be back with you in a minute.
Next 10 minutes or so.
Thanks.
Hello, Dr. Satish. We were back to you. So can you just take us through the case that you just completed? Looks like they are nearly finishing that with the modified Denkers.
Yeah, it looks like they're just closing the flap
Thank
again.
you so much, Satish Jain.
Thank you,
sir.
Satish.
Was
A wonderful demonstration throughout the day.
Sir, thank you for your time, your attention.
So
and obviously,
we'll-
thanks for involving me for this.
It's always a
prestigious
pleasure
event.
to have you in Nagpur. And we'll meet personally at the banquet now. So thank you very much.
Thank you.
Thank you, sir.
See
May I
this one stitch. Put one more.
May I request Nandu sir to please step forward to felicitate our moderators, Dr. R.B. Deshmukh sir. So, President Eva is coming to you to felicitate you.
I think, sorry, we probably missed the case. They're just about finishing.
After an exhaustive
join back to
session.
London, please. Thank you.
Thank you so much, sir. Dr. V.P. Nikhar.
There we are. We can hear you now. That's a really nice wide opening there.
Everything. Now we got the big space here. So that intersinus septum that was here lowered it as well. The other one there. So that's all. This is the right frontal sinus now. It's all open. I think that's my limit for posteriorly as well.
Yeah. It's very asymmetrical, much bigger on the left than the right, those frontal sinuses, aren't they?
Just a little bit of cleaning here, and then I am going to put the mucosal flaps, and then I'm going to cover them with the propel. Let's have the 45 Blakesley. Piece of bone here. Here on. Here. Okay. So here we go now. So this is the cavity. Let's wash it. Before that, I'm just gonna trim this bone. You can't leave bone exposed like this. So can I have the chomper? Just trim that piece of bone. Okay, let's have some irrigation now. And suction in the nose. Another one. Oops. It's blocked, I think. Yeah, it's a bit blocked. It's okay now. Okay, so let's have a look. Just clean it first. I will probably need your suction again, that one we had. So I just cleaned it, wash it out completely, making sure there's no bits swimming around. Oh, it looks fine. Take them out. All these little bits of bone and cartilage or whatever. All the bone is covered. Bits of blood clots here. Just clean them out. All the bone dust, you don't want it to be there, obviously, because it will get infected and cause you problems. So we try to put some mucosa on the exposed bone now. So this bits of mucosa, I'll try to put them here. So let's have the mucosa. So that big piece of mucosa that I had with the Blakesley 45. And we'll try to put it in the anterior wall. And then I need the propel to open the propel. So we'll go like that. is here, and then try to move around. So let's have the freers. So if it doesn't stick, then don't do it, because otherwise you block your, because it's quite edematous actually. So we'll try to cover this. The surface is that one, like this. Cover that bone here. Now, can I have the frontal sinus curette? So we'll push it like this. Like that. So you're depending on surface tension here. That will keep it stuck to the bone there. It is obviously thick, but we'll see. Maybe we can squeeze it in a bit. Yeah, that's not bad. Like this. We're going to try to open it with the propeller as well. Let's have the seeker. Let's have the seeker. The small one, yeah. And then see if we adjust a little bit more. It's very, very thick mucosa, which is in a way good, but also bad because it can narrow things for you. You don't want that. But really, the mucosa, if you manage to get like grafts like this, it will decrease your osteitis and you get less of narrowing from the bone. So let's see if we can stick this like this. Yeah, so it's a pre-mucosal graft. Oops. That's okay. Let's have the freer. So it's sitting like this. I'm going to push it up, hopefully with the propel. We'll see. Seeker again. The propel obviously will decrease the edema because it decreases steroid. So let's have it. So here is the propel. This is the introducer. Put it there and just opens up. So let's see if it can just go. So I don't have a propel contour. So this is not the specific frontal sinus one. So we'll just use this one anyway. Just put it there where that graft is. See what happens. We push it right up and stays there, and we'll hopefully keep our graft stuck. It does that. So we can push it a bit. Can I have the seeker? It's good. I think it's working. It's holding it in place. Can we have a picture? Yeah, so it's holding our graft in place. Thank you very much. So it should be okay. Yeah, this graft will obviously shrink. This will keep secreting steroid, mometasone for a month. So we'll decrease the edema, hopefully decrease the osteitis and swelling and everything else. So that's it, done.
That looks great. Thank you very much, Hesham. They got a tricky case lined up for you today.
So luckily we managed now, so I think it's okay. Thank you very much.
It looks really good. No, excellent. Thank you. That looks really nice.
Hello, welcome back again. So we're having a fantastic second day of our 3-day live surgery event. And for Professor Richard Harvey in Australia, it's the third day. So it's 8 p.m. in the UK, and it's early morning in Sydney, Australia, where they're getting ready for surgery. So far, we have fantastic 2 days with surgeries from Spain. And today, we had Rick Carra and Professor Daniel Prevedello performing craniopharyngioma from Wexner Medical Center, Ohio. in the USA. So I have with me my colleague, Louise Melia. She's a rhinologist from Bath in the UK. So how did you find the event so far, Louise? Do you enjoy it?
Yes, very much so. A shock. We've had great cases. So I was here for day one and we had an excellent selection of cases.
Give me a towel clip.
Showed us how to deal with, difficult cases, difficult fields to begin with. But then it was very interesting to see how the surgeons dealt with that. Gained a really good surgical field and then obviously dealt with the pathology that was at hand. So been very interesting and looking forward to the cases that we're about to see coming from Australia as well.
Yeah, great. And we have cases coming from Australia.
Let's go to the endoscope feed next.
Afterwards, we'll be joining eastwards.
Well, actually, leave the brain lab up. Leave the brain lab up.
Jaipur in India. So without further ado, I think we'll join the team in Sydney. And we're thank you to the whole team for
just
taking
not
all these
clearing.
efforts
Can
to
you hit white balance
join us today. So, Richard.
Okay.
Good morning, Richard.
Hey, good morning. Hold on 1 second. We'll just restart the endoscope machine. Just turn it off and on again. No, it's not clearing. So the white balance is not clearing. Just turn it off and on again. Yeah. Hey, so you should be able to see. Good morning. You should be able to see the scans up on the images. Let's get rid of any other feed other than just the brain lab scan, and hopefully you can see that.
Okay, correct. So we'll get the studio to connect to your feed, and then yes, we got your view. Fantastic.
Fantastic.
That looks interesting case.
Yeah. So this is a young 23-year-old girl. She's atopic and just has had progressive right-sided obstruction. And of course, all rhinologists and ENT surgeons will recognize this. She's got allergic fungal rhinosinusitis. And as it typically forms with the hyperdensities on the soft tissue view, expansile unilateral bone changes, and typically a young person with an atopic predisposition. And so she's really absolutely barn door classic AFRS case. When she saw me initially, her symptoms have been obscured by the fact that she's had long-standing She's had long-standing symptoms of allergy, and she's not only sensitized to mold, but also to dust mite. And so, when I saw her a number of months ago, the first thing I did is I started her on dust mite immunotherapy because she's actually got bilateral symptoms, this girl, but it is her right side that's worse, and the reason it's worse is because she's developed in an atopic individual a secondary condition, and that's the AFRS. And that's a really important concept to remember, that many patients with AFRS have an atopic predisposition to start with, and that's, often masks their presentation. Now, it's pretty straightforward on the scan. Are there any questions, Ashok, before we go to the endoscopic feed?
Yes, I think the question comes to mind that over the last few years, have we seen any rise in these cases of fungal, even AFRS, after COVID?
You know what? I'm not the best person to ask for that. Here in Australia, we had so little COVID that, there were less cases of COVID than there were the natural respiratory viral event, flu season. So I'm just, and even though COVID is more severe than that, it just in terms of prevalence, it's just not so common in Australia. So I really can't comment.
Okay. Yeah.
How about you in the UK?
So certainly I've seen more number of cases over last in the post-COVID era than I've seen before. But of course, that's my anecdotal personal experience. What do you think, Louise?
Yeah, so I think we've seen an increased number in the more concerning fungal sinusitis. So we've had several cases come in that have had invasive fungal sinusitis, and I think certainly in India they noticed a significant rise in the number of invasive sinusitis post-COVID.
Correct. Yeah. Okay, so what's the surgical strategy?
Let's go to the endoscope feed, guys.
Yeah, sure.
And we're about to start here. Artery clip, thanks. Thank you. And we're going to do a timeout, guys. Just mute the audio for a second, guys. Can we?
Sure.
Ashok, what's interesting about this case as well is that it's unilateral, because quite often we see allergic fungal rhinosinusitis in its bilateral disease.
Exactly,
I don't know what
yeah.
your experience has been with that. Yeah.
Yeah, I know that's commonly you see bilaterally.
Mm-hmm. And it can be really quite severe. We've had a few cases referred as query malignancies because they've actually had mucoceles and they've had, they've presented with visual disturbance, and it's been secondary to AFRS.
Yes.
You got me back on?
Yes, we got your endoscopic view, and we'd like to know what is your preparation for this patient.
A couple of little things here.
Yeah.
Really important is to sort of acknowledge that the whole bed's at a sort of 15-degree angle.
Yes.
That's 15 degrees. And I think a lot of people, when they put their bed in reverse Trendelenburg, put it into 5 degrees and think it's the reverse. We're very comfortable. We usually operate at sort of 15 degrees reverse Trendelenburg. It's very common for us. And it's one of those things, like when you look at preparation for sinus cavities, there's little things you can do. If you use high-dose adrenaline, this is associated with about a half a Bozert score of field improvement in terms of bleeding. If you put someone in reverse Trendelenburg 15 degrees, this is another half a Bozert score. If you use bradycardic anesthesia, that's another half a Bozert score. And if you use tranexamic acid...
Sorry, Richard, I think your microphone is probably shifted away.
What's happened?
Yeah, so that's good. I think the sound quality is... Yeah, I can hear you well now, yeah. The sound was reducing.
Yes, I was saying, reverse Trendelenburg's half a Bozert score. Bradycardic anesthesia is half a Bozert score. Reverse Trendelenburg's half a Bozert score. And tranexamic acid given IV is half a Bozert score. And high-dose adrenaline's half a Bozert. So I think I named 4 things there. So, if you do all those little things, you get a lovely view, And I think we all know these things, but I don't, a lot of times when I see people practice, they don't put them into their daily routine, There's 12 RCT supporting tranexamic acid, numerous RCT supporting just simply using adrenaline or a simple non-selective alpha blocker. Very important for bradycardia rather than hypotension. So these are the sort of things that I use for the field. Now, look here. Here's the right-hand side. And you can see, very typical for AFS, right? It's got some polypoid degeneration coming. Now, to me, this is not the AFS here, right? That's the AFS, right? Can you see the sort of eosinophilic mucus?
Yes.
Yeah, so to me, this little thing here, which we're just going to shave up very quickly, is just allergic changes, in my opinion, coming off the bulla and uncinate. And here's some allergic change. That's not AFS coming off the middle turb. That's just an allergy change coming off that area. So now, when I'm going to approach a case like this, give me a ball probe, thanks. Look, sometimes I'll make an effort to see if I can see where the old uncinate is. But you know what? It often doesn't matter. And I'm intentionally going to go just to the back here. It's broken through here, so just give me a backbiter. I think a lot of us get fixated with the idea of wanting to find the natural ostium all the time. And it's so important sometimes just to not worry about that. And you want to find your anatomy. That's the most important thing. So the first thing we did there is just run along the superior edge of the inferior turbinate. So we've released the uncinate here. And then we'll take off the upper uncinate. Now, I always do the inferior uncinate first. Let's go an up through cut, thanks, Lenny. And then I'll up through cut, thanks. And then let's take off the upper uncinate. It still reminds me that a lot of people go for the upper uncinate first, and even though they know it's going to bleed down onto them straight through cut, it's really not, in my mind, that's always going to make your inferior uncinate worse. And we have this general rule in sinus surgery that if we're going to do something in the sinuses, that we do something in the superior and posterior part of the sinus first before something anterior and inferior. Yeah, we're just shutting the sucker up there. It was sort of dropping out in this side there. Give me an up kerosene. So taking the inferior uncinate, take the superior uncinate. Now, it's really, I love the kerosenes. I saw Stamberger operate in Graz and he used the circular punch, but he used it in the same way. It's a really easy tool just to sort of quickly sort of munch away. So then when you come in with a shaver, and you can see I've got that classic crunch and gobble technique, right? So here we are now. There we are. We're going to open this all up. Just get rid of the polypoid change that's there. Get rid of the uncinate that I've just munched up. I'm not really trying to remove tissue with my forceps. And I can tell you, here's a tip for anyone doing cases like this. Don't fiddle around with a fungus right yet, right? You can now spend 40 minutes if you wanted to try to get that fungus out. That's not going to be very rewarding, in my opinion. The bulla is almost collapsed here. So what we're going to do is we're just going to find, there's the edge of the bulla here. So give me the backbiter. Oh, no, give me a kerosene, my apologies. Whatever's left of the bulla here, we're just going to nibble it away. So it's almost like going into the retrobular area there. And once again, just sort of munching it up. There's a bit of mucus trapped in there. I just want to find the orbit. That's the only thing I'm interested in when I do a case like this. I don't really teach sinus surgery anymore about all the developmental anatomy. I really just teach it based on finding key landmarks. And one of the key landmarks here when you're doing an anterior fess is just to find the orbital floor. And sometimes can be a little tricky when it's edematous. But there you go there. See that? That's orbital floor there. Yes. If that's orbital floor, then that has to be orbital wall. And if you're not sure that you're right, that's orbital floor for sure right over there. So give me the kerosene up. I can't quite see, in my mind, where the orbital floor becomes the medial orbital wall. And so I'll often then just nibble it a little bit more so you can really see, and I'll go with curette here in a moment. There you go. Perfect now, right? This is what I teach people to find. You see the floor of the orbit? That's medial orbital wall there. It cannot be anything else. So automatically as a surgeon, you know that that's the orbit right there. Let's go some patties, thanks. So now I'm going to stop here, right? Because I said to you, I'm not going to fiddle around taking this fungus out of the sinus cavity. Over the years, I've found that if you try to do limited ventilation type surgery for AFS and have a big maxillary sinus, you have a high chance that they'll have persistent mucus in their sinus cavity. In AFS, you really need to create a single cavity that they can wash out. And if you said to me as a researcher and scientist of the sinuses, if you said to me, why is the left side not affected? The left side's not affected because on that side, mucociliary clearance is occurring, and it prevents fungal elements from making any prolonged contact with the sinus lining. And if there's not prolonged contact, then you don't get a reaction. And if you have prolonged contact, you get a reaction. And so something happened here on this right-hand side in the maxillary sinus where she had some mucostasis. I mean, it could have been any event, like a viral event or something else. And that's what set off then a period where she had prolonged contact in someone immunologically predisposed. Because that's a question I get asked a lot by people. You know, why does AFS occur unilaterally? But this is the sort of thinking about it. So, Lenny, let's go with a artery clip now. So now we're going to do artery clip. Now we're going to do a modified medial maxillectomy, you know, and this is really to make sure that we give this lady a really simple cavity. Now, things that you might want to see here, just as a way of interest, that we, let's shut that up. Peter Lee, do you want to grab that sucker and just sort that out? Thank you so much. So that's the nasolacrimal opening just there. See the little slit in the wall? Give me a sucker.
Yes.
Let's just have a clamp, guys. Just put a clamp on it.
That's the classic Hasner's valve.
Yeah, there it is there. So look, I'll try not to beat it up too much, but you can see what it is. So for most people, Hasner's valve is just this little slit opening in the side wall. It's not a hole in the top that people see. Give me the artery clip now. Yeah, maybe a second one, like a needle driver, just to clamp it. Yeah, put a needle driver on that. Okay, yeah, sure. Okay, here we go. So we're going to put an artery clip on. Now, I like to just crimp it here. Give me a curved iris, thanks, just to help with hemostasis. So this section of the middle of the inferior turbinate, we're going to remove so we can expose the rest of the medial maxillary wall. And I just simply will amputate this section, and then I'll show you about raising a small, I like to preserve the inferior meatal mucosa as a small flap. Now, as you come down here, you can see the whole wall is slightly medialized. Now, as you get towards the back, there's no point leaving a really big back stump. I think if you do, it doesn't often function properly, gets maximally dilated a lot. And I'll just try to cut it off. But you don't want to cut it off so flush with the wall that you end up with, almost stripping it from the bone. You want to leave it, let's go with the medicine balm, thanks. You want to almost leave a little stump so you can bipolar the little artery that's in there. And normally, you can see the very end of it here. Let's see if we can actually just get down here. I think I almost got through it. There it is. There you go. Blakesy, thanks. Now we'll take it away. Okay, let's go needle point now. Next, thanks. I'll get you to get a clamp and put that on it rather than doing that. Okay, so here we are. This is the floor now. Yep, and I'll get you grab it now and we'll get you to... Now, when I do a medial maxillectomy, we want to feel for the hard palate, soft palate junction, somewhere along here. And then we're going to make an incision really at 90 degrees to the area that we want to divide. And just really make sure we're on the bone. Yeah, you want to be right down. We're right on the bony junction here. Great. Now, up here, though, I'll get you to swap for me. Give me a wipe. Give me the sucker. Let's go. I want to show you. There's our nasolacrimal area. I'm not going to look with an angled camera. I think we can sort of see the slit area. And then on this one here, this is why it's called modified medial maxillectomy, because we're going to preserve the valve area. And so this incision then is at a real 45-degree angle. Can you see that? It's very different to the back incision. You want to come at 45 degrees. Let's go Cottle dissector now. There you go, great. And then we'll just throw a clamp on that when we're not using the sucker. Now, because I've made the incision already, it's very easy to raise. Now, if the bone is very thin, actually it's good just to raise it on the floor first. So the floor is always a good one. If you're struggling to raise it, or the mucosa is thin or the bone's thin, just go to the floor first. And it should release entirely here, actually, because, if the surgeon had connected all my dots correctly, we should have no problems. And unfortunately, this surgeon almost did that. Not quite. There you go. And then we'll fold that flap up in this direction here. And you can see how the 45-degree anterior incision really helps us to fold that out of the way. Let's go curette now, thanks, guys. I love this maneuver. This we call Jessica's punch. I don't want to do all of this with the drill, so we just punch in. You got to punch somewhere comfortable. Don't be working really anterior and posterior in my mind. Kerrison up, thanks. And then we'll just come through now with a Kerrison, and then we'll use a straight through cut, thanks. So you want to come in. Obviously the bone's really thin here in this patient. We'll come then through with a through cut. And it's exactly the same technique. Make sure we have a 12 sucker here when we eventually get this guy open. Yeah, not right now. A 12 though. Yeah. Minji, can we get a 12 Fraser, thanks? Just disposable. Yeah, hopefully I'm going to reduce the pain of sucking fungal mucus out for everyone. I worked in the south of the US with Rod Schlosser, backbiter, thanks. And the amount of fungal material that I had to suck out during my fellowship was incredible. And I've really got an aversion now to sucking thick mucus out of sinuses. I don't like it to take too long. Here we go. So you can see how I'm going to remove that bone right up to our cut here. Now, I've seen lots of people describe this tuna saving, modified medial maxillectomy, nasolacrimal duct preserving. It's all of those things. That's why it's called modified. And how you do it doesn't really matter. But what you can't do in a modified medial maxillectomy, Ashok, in my opinion, it's not a big hole. One is not doing the drill, thanks. One is not doing this surgery for ventilatory reasons. Let's go 30,000 on the button, thanks, Minji. No, 30,000. Thank you. We'll just make sure our irrigation's working. Yep. And so the goal of the surgery is to create a sinus cavity that doesn't collect mucus. And is easy to wash out. And so we don't want any sumps to form. If you leave a sump or an area where mucus forms, this lady, unless she's on prednisone, will end up getting a reaction because she'll have a long contact time with the fungal elements. And I don't normally give fungal immunotherapy for these patients. They don't need it for most of the part. If you just restore their mucociliary clearance, the sinus will come good, like the other side. Now, they are a little bit at risk, Ashok, of, I think there's a few publications to show that you're a little bit at risk of getting it on the other side, you know, even if at some point in time. But I must admit, I'm not one yet of doing the other side, you know, prophylactically or anything, you know. I just try to just get it right. What about you? I mean, you are probably over the course of your career have seen people who come back perfectly normal side one time and then a few years later they get it on the other.
Yeah, yes. And there is argument by some that you can do at least mini phase type of procedure, uncinectomy, middle meatal antrostomy. But again, he said if it is not broken by fixate, it seems perfectly normal on the other side in this case.
Yeah, I wouldn't even fiddle with it. If it's normal, I wouldn't even do. I don't believe doing a simple antrostomy in my mind protects you from sorting that out. And you'll see once again here, you know, Ashok, I've really made a huge effort to not touch anything. Like I haven't touched haven't touched everything. You know, I tell you, just as an efficiency as a surgeon, we'll just get rid of this little bit of posterior turbinate. It's much, much quicker if you just leave it all and get your opening right. And you can see I've almost got my opening right. To the point now, give me a ball probe, thanks. Let's take out the patty. And you'll see how much mucus is here, right? Look, from there. So imagine if you were a surgeon trying to remove this mucus plug from up here. Oh my gosh, I can tell you, Ashok, I've seen that, people do that, and it is the most painful thing to watch ever. So, you know, I always promote the idea of get your opening right, then remove the mucus plug. Let's go a wash on a stick, Linny, on a long, thin curve, and we'll get our 12 sucker on. And you can see here that I'm still going to have to struggle. I'm sorry, I'm going to have to put everyone through mucus removal. But now, at least, give me another...
So you're almost going through the normal anatomy surrounding the whole disease, and then making it easier to remove.
Yeah, 100%. So let's give me another washout. So I find that a lot of the time you got to put a bit of a wash in to get the lump going. And I've even been known to take the 12 gauge sucker off the sucker and literally just put in the. Just want to pinch it for me. Go for it. Let it go. See, look, I got a 12 gauge sucker. And look at it, right? This is why, for all of those watching who thought I should have been removing mucus 5 minutes ago, and it goes to show, though, why we're doing this approach. If you did an antrostomy and spent half an hour trying to get rid of mucus, all you would have achieved is creating an empty mucus-containing cavity that's likely to recollect mucus in the next, you know, little period after surgery, because they will sump and pocket mucus very, very easily. And this is, I think, why people used to, like I grew up in the days of Fred Kuhn, where he thought AFS was the worst condition ever and it was chronic. To me, AFS is the one condition that we can cure as sinus surgeons. It's eosinophilic, you know, type 2, you know, diffuse disease that we end up needing biologics for and everything else. Okay, I'm gonna do it. Pinch the sucker for me, please. Big Tilly Hankel. I have to resort to this sometimes. Doesn't always work, but let's have a look. Okay, hook us up, open up. Thanks, Lenny, open up. There you go. Hasn't put this 12 gauge back on. Oh my gosh. Alrighty. 12 gauge back on. Now, as I'm slowly removing this, the brain's trust of the panel, I'm open to any special techniques that people know of to remove mucus. I've never discovered one. My best one, I would say, is thick eosinophilic, a big hole, and make sure that you use the irrigation as much as you can, because irrigation sort of loosens up this tight attachment it has to the surface, I think. Let's go another irrigation. We might do a few more irrigations. I can see it coming loose here. And you can see with a nice big opening too, Ashok, I'm not struggling when it comes to, putting the sucker in and out. I see so many people sort of beat up the lining, when they're trying to suck something out and they're struggling. Have a nice big opening, you can suck it all out. It's a bit easier. Let's go that. Hey guys, don't worry about anything else here. Let's just go the wash and the stick, thanks.
Yeah, and with this technique, almost the whole of the mucus is coming out like a ball together. You can not dissect out from the edges, rather keep aspirating it. So when it is out, it will come out in total.
Okay, give me another wash and stick. And you can see it, I've loosened up the back, but this front wall has got diabolical amount of mucus in it. I wonder if I can come along the front wall. Oh yeah, getting there. It's always satisfying when it comes out. Just quickly grab it. Don't mess around. Okay, here we go. Wash and stick, thanks again. And I might try my little direct sucker approach again if I can loosen up this side wall. But once again, just a great demonstration of just needing to get your opening right first, Ashok, just so important. Yes. And this is also too, those of you in the audience who think, oh, can't you just get away with doing an antrostomy? This is the pathophysiologic process you're fighting. And this is why people who do little ventilatory surgery, on conditions like AFS, struggle sometimes, and they have patients who get recurrence or don't settle down even to begin with after the surgery. So I'll get you now to pinch the sucker for me.
And can I ask, so post-operatively, what regime would you put the patients on? Would you use oral steroids? Would you use steroid-impregnated rinses?
Okay, let's go. Yeah, so you have to use oral steroid for AFS. Yeah. You got to at least for some period of time suppress the condition, and I don't think you can do it with topical corticosteroid irrigations alone. And so they all go on oral steroids for a period of time. Usually something like 3 weeks, but you don't need a big dose. 25 milligrams max dose is all you really need to suppress, eosinophilic inflammation of the airway. Mm-hmm. So you don't have to give them much. There's no role for antifungals, in my opinion. Mm-hmm. I wrote the chapter 6 in EPOS 2020, which was all about fungal sinus disease. And you know what? There were some fascinating things that when I had to do the review of that, and I did even a couple of meta-analysis plots for things to really show that, being on things like antifungals makes no difference. This is a hypersensitivity condition. Now, whether or not you believe it to be a type 1 hypersensitivity, and so it's IgE mediated, I'm not really convinced that's the case, but it's an hypersensitivity. I mean, there are other types of hypersensitivity reactions like type 4 or delayed type hypersensitivity reactions. So I do think it's probably a bit more than just IgE mediated, and that's why drugs like omalizumab have never been the never been the the sort of panacea for AFS or controlling it. And certainly I've got patients on biologics who have been given everything from benralizumab to dupilumab with AFS, and unless they get their sinus cavity cleaned out of all the mucus, it doesn't really help them. They have ongoing problems. So if you don't get out the mucus plug, just make sure the suction's on maximum, isn't it? This is where I'd like 2 striker units to help me suck out this. You can see, look, this is what you're fighting, right? This is AFS at its truest. Let's go this here. So I might have to just break it up here. Just grab it. Just grab a sponge and just get rid of it. It's not a specimen or anything. Certainly not at this point. Alrighty, here we go. So actually, this one unusually is going to sort of. Let's get Lenny a sponge so she can really grab this properly from me. She's just struggling with a little Ratex. Yeah. Thanks. Yeah, so I will give them some steroid, but corticosteroid irrigation still play a big role here. So, but you should be able to normalize the sinus cavity. And if the patient comes back to you at 3 weeks and their sinus cavity isn't normalized, you've got to be worried. If you haven't normalized them early on after surgery, then you've either left a whole lot of mucus in their cavity, or you're not giving enough oral prednisone to suppress the reaction, and they're just getting mucostasis again. It's just really wipe it for me. Don't worry.
So for a patient like this, Richard, what will be your post-op oral prednisolone regime?
Yeah. So 25 milligrams, for 1 or 2 weeks, 12 and a half, and then 5, maybe, something like that. Sometimes, if it's very localized, I might just give 25 for 2 weeks with a cold stop. You don't need to taper doses less than 2 or 3 weeks. I don't give small doses. I don't give really high doses for 2 or 3 days and then like a 10-day taper. There's really a lot of evidence now that that's not really how we should be using anti-inflammatories like prednisone. It just ends up exposing patients to subtherapeutic doses, and they don't need it. 2 to 3 weeks is a totally fine period to have someone on oral corticosteroid without worrying about a taper.
And any preoperative prednisolone, do you consider that?
I do sometimes. It depends how inflamed they are, but not normally though, actually. And I tell you why, Ashok, is that although I agree a little bit of pre-op prednisone can help their surgical field, I don't like. Can you pinch it for me? Yeah. Give me 2 seconds to focus here. Okay, and release. To improve their surgical field, it doesn't really help their recovery, and I'd rather limit their overall systemic corticosteroid use to the post-op period to help with overcoming their AFS. Does that make sense?
Yes.
Yeah. Although I completely acknowledge that if you give it, it will make things better. See, that's the shot everyone wants to see. See, just to show you that after debulking it, and just make it clear, I've attached the striker suction machine directly to the sinus, to the mucus ball there. And let's go back. We can do the 12 then, and we'll have one last look now. But that wasn't too painful. The pain was relatively minimal. Let's go and do the rest of the sinus cavity then. You can send that piece off, Lenny. All formalin, thanks. Yeah, and that's a really important thing. Lenny just asked me, she said, do we send it off for formalin or for micro? Only formalin. Do never send AFS cases off for micro. You only totally confuse other doctors about what's going on. And so I think it's very important. Let's go to a 10, Fraser, thanks. This is not an infective condition. If you start sending off micro samples, you cloud the picture for everyone. And you might think our infectious disease colleagues understand what we're doing here, but they don't. They really don't understand AFRS. The only doctors who really understand AFRS, in my opinion, Ashok, are ENT doctors. I mean, I'm sure you've had that feedback. You know, immunologists aren't sure what to do with them, and respiratory doctors don't quite understand it. Now, here's something we're going to do that I do, and every time I do a medial maxillectomy, is that I'll really make sure that I dig out all the pockets. See how there's like a little pocket of mucus there?
Yeah.
Yeah, let's give me a curve sucker, thanks. That's very anterior. And that is an area that would cause recurrence. And so in people who have a well-pneumatized maxillary sinus, and you can see here, there's still like a little punny pocket happening.
You just wouldn't be able to reach that with an enterostomy.
Oh, yeah.
You know, as you said, did that
miles away.
Yeah.
And you would have probably spent an hour trying to get the mucus plug out. And then you would have thought you'd done a great job because you were trying to stare in with a 70 scope and looking at what you'd done. And then the patient would have had grumbling, ongoing inflammation in the sinus cavity. And the surgeon, very commonly, this is like 15 years ago, let's go the drill back on, would be dumbfounded by why it's not gotten better. But that this sort of phenomenon, what we're staring at now, is what's going on. Now, one of the things I'll do then, and we publish about this in dysfunctional maxillary sinuses, is that we really it's not a ventilatory condition. We're here to reshape the sinus cavity. That's what we're doing. We're trying to reshape it. So I'll drill this little bit of bone here. See this bit of bone? We call this Snidbong's wedge. It's just a little triangular bone where if you don't remove it, you can never see the front aspect. And then I'll drill off this whole side wall. And then we're going to carefully strip out the mucosa from this little pocket, and we'll get rid of it, like an obliteration. And I'll show you how we set it up at the end. We'll have some Surgiflow, thanks.
Is that the angled burr you're using, Rich?
Say it again?
Is that the angled burr you're using?
It's not actually angled, no.
No.
Like 15 degrees, yeah.
15 degrees, okay.
Anyone who knows me will know that I hate angled instruments and angled surgery, right? And you'll see here in a moment when we do the frontal, like what we do to make the frontal happen. Okay, look, we've got to go back to the smaller sucker, the 10, please. The 10 is what we need now. Let's stay with the 10. Big wash, thanks. Okay. Yeah, only like the 12 we need to do that really big area with all the mucus, and then let's not have a 12. 12's too big a sucker normally for sinus cavity. So here you go here, guys. Can you see this? So here's our little area. I've got a little bit more mucus here. And I'm not actually taking the mucus out now, guys. Can you see I'm taking the mucosa? I'm channeling my inner trainee and making sure I strip now, right? Okay, so this is here. This is the front wall. Let's go 90 curette, thanks. And this takes, if you take a bit of time to get the plane going, the stripping plane right, it makes it a whole lot easier. And you'd be surprised, look how deep some of these sinuses are, right? And I want to take it off so that I get rid of the very bottom sump. Let's go the curved long sucker on, thanks.
There's so many little nooks and corners, isn't it? It's not a flat cavity.
Yes, but it will be, Ashok. It will be at the end.
Yeah.
That's what we're going to turn it into. And we're going to make it a smooth bowl. There's a few little things we still need to do here. And this surprisingly is a big part of the surgery. A lot of people think medial maxillectomy is about making a big hole. It's not about making a hole. It's about creating a sinus cavity that has no area where mucus can collect and sump. What have we got on? Drill? Give me the drill and then we'll go to the shaver. And normally, with a nice modified medial maxillectomy, you can do it all just with straight instruments. Make sure that there's no little areas. Okay, give me the shaver, thanks. And now we'll shave that away. And at the end of the case, I'm going to leave it now, but at the end of the case, I'll show you how we fill it in order to actually make it smaller. Okay, here we go. And look, it doesn't take long. It's like a simple thing to do. It's really, what do we call it? An obliteration of the floor. If I can not suck up my flap, as you try to. Okay, give me 170-degree scope. This is for the audience, right? We'll show them the cavity. And you've got the curved sucker on. So I'll show you the cavity because we're going to finish there. But just for those of you who really want to see it. Now, you don't need to strip this mucosa any more than just the same level of the nasal floor. Anything higher than the nasal floor is sort of redundant in my mind as a concept. And we'll just make sure there is a little tiny bit of bone there. So we'll just make sure that that front wall is good. 70. Just for those of you who want to see, a few times I'll put a 70-degree scope on. There you go. See that front wall? Mm-hmm. And look how there's even a little bit of mucus getting caught there, right? Is there a bigger one? Nope, it's fine. And this is the thing with curved suckers. Curved suckers are always so fine. And this is why you need to give prednisone. Because even though I've maximally removed everything, give me the shaver. Just give me the shaver. Yep. All right. Now, I don't feel like this is blocked or something. Look at that. Look how there's like the remnants. Let's go the wash on a stick. Thanks. I'll go the 90, the small 90 on the wash. Yeah. Let's see if we can wash that last little bit out. And do you know what? If I can't wash it out, I'll see if I can get something else to remove it. And here we are, right? Even with my modified medial maxillectomy. Give me the 90, correct? Just got another wash on a stick, thanks. There you go. Oh my gosh. Everyone's going to say, I should have looked with this at 70. It was worth looking. After poo-pooing the 70 scope, it showed me that I haven't got everything out. Give me the wash on a stick. And you know what? That's that very most zygomatic recess, you know, where that's sitting in. That's not generally a big pocket. We'll get that now, I think, with the... So you've seen what I've done to the floor. That's really important. Look at that, and that's just the polypoid edema, and a little bit of mucus sitting in there. There's our mucus. Oh my gosh, right? And then I think we're good. That might be a bit of, that's like, look at that, guys. Can you see that, Ashok? It's mucus in the mucosa. Can you see that?
Yeah.
Yes.
That's why you fail. Right there, right? And so, let's see if we can shave all that off, right? That's such a diabolical situation, you know, for patients to have. Shaver. Doesn't always work, guys, so. Look at that though, right? Totally worth getting all that out. Oh my gosh. Okay. I can't possibly better operate with a 70 any longer. Give me a 0. Give me straight sucker. 10, thanks. Let's go big wash, thanks. That's what you were doing before, Peter Lee, wasn't it? Yeah. Fair enough. That's a good call. Oh my gosh. So, there you go, right? I've got all the tricks to sort out. I'm blocked again. Let's go 10. That's an 8. Can I go 10? Now, that is not how the sinus is going to be reformed. We're actually going to use some gelatin paste to try to obliterate the sinus, and I'll show you what that looks like here in a moment. Now, give me the bipolar, thanks. We've got to do a little tidy up back here. So often this back edge is often heavily expanded, as you would expect in this situation. You don't want to completely take it back. There'll be some vessels in here. Let's go a Blakeslee forceps first, and then we'll go bipolar. So here, though, you are going to have a few vessels in here, and what you don't want is a whole lot of raw bone at this back edge, right? So very commonly, not just in her, but in everyone, I'll actually make a little effort to take out the bone between the mucosal edges to try to really allow this area to come together as a mucosa to mucosa apposition. I don't mind if there's a little bit of raw bone elsewhere, but I don't want it right there. It tends to crust, takes a long time to remucosize. And then that's the vessel right there, right? So you can see the vessel. We're just using a standard bipolar force. It needs to be set at 25, guys, please. Minji? 25 on the bipolar, thanks, guys. Yeah, perfect. Awesome. Big wash, thanks.
And I agree with you, Richard, that sometimes when that crusts fall off, there's a risk of bleeding there, so it can open up the blood vessel behind it.
And you know what? That's why you need a bit of soft tissue there too. You know, Ashok. See how there's a bit of bone flake in there? That's got to come out. But Blakeslee, thanks. So really important not to leave little bone flake. See that bone flake? Really important. Give me a bipolar. Got to make sure there's no like little bone flakes and things. There you go. But you don't want to. You decide you don't want to strip that area. It's really important not to strip it. Okay. Give me some patties now. So there's our maxillary sinus done, and now we'll sort out the frontal, right? So we'll pack about 5 or 6 pads in here. We've got our terrible mucus plug, as well as the intramucosal mucin, right? You saw it there live, right? You do see that sort of thing, you know, it's crazy. And that's why you've really got to make sure that you've got a cavity. Like if you just washed out the sinus with angled scopes and angled suckers, and you'd never really picked up on that, that would have been a recurrence waiting to happen. You know, you just cannot expect submucosal mucus and fungus to be extracted from the sinus cavity. I think we get away with it in rhinology so often because we give them steroids, and during the steroid period, that helps to suppress, and then their own system kicks in, and we get away with it, you know? But if you said to me when it doesn't work, they're the sort of factors that are at play. Now, we're just going to open a frontal, and this is obviously, you know, something that we've promoted, a needle point diathermy. It's just doing a thing called a Carolyn's window, and it's really nothing fancy. It's just a version of what people have already described. Let's go 10 sucker, thanks, and just suck my smoke for me. So all it is just drilling off the front wall, right? So here we are here. We're just going to mark off this little point here. And we're just at about the level of the middle turbinate attachment. Then we'll come forward here. And then we'll drop down where we see the piriform. I'll swap you for a second. Give me a wipe. Now, Jared, I might get you to help me out here, Jared. We don't have enough head extension, so I might get you to take out the head ring here in a second. So you can see the piriform, guys? Then you're going to drop down right on the piriform to about the midpoint of the middle meatus. You don't need to be any lower than that. Now, if you've got a little funny swell body and things, you can always just shave it, but, you know, it's important to have a septal surgery if it's not straight up there. So Jared's just going to take the head ring out. Our patient's just slipped a little bit. We had them in a really head extended position. And it's really important to do that. If you're going to work with near 0 degree scopes, you have to have the patient in really quite a head extended position. And so otherwise your instruments are hitting the chest all the time. Very annoying. Okay, so here we go here. So it's a bit like a big DCR flap, right? Massive DCR flap, except it's based inferiorly. And I used to do this with little mini flaps. And then Ashok, one day I had Brad Woodworth was at our sinus course as an invited guest, and he just said, "Look, Richard, why don't you just take it all the way forward and make it inferiorly based?" And so I did what Brad suggested, and I actually even took it. I said, "Why even take it halfway towards the piriform? Let's just take it all the way to the piriform." And you know what? Ever since then, it heals much better. The bigger you make the flap, like in many other places in the body where you make flaps, if you just make it big, it actually heals better. It gets less venous congestion, it's got better blood supply, and it just totally clears the area ready for you to drill. Put the drill on, thanks. Now, the nice part about doing this is that we're going to now find our anatomy here. Now, if you wanted to, like say you were missing a middle turbinate and you wanted to do this technique, Ashok, you can always go down here and find the first olfactory neurone if you wanted to.
Yes.
And we'll see it's coming up almost. There it is there, right? Can you see it? The fascicle's going in?
Yeah.
Yeah, so I mean, that's how we described, like, when doing Lothrops about always finding the, the skull, some sort of landmark for the skull base, Now, so once you've got that, I've got like the world's, I think I've got some tissue stuck around my neck, Lenny. Can you see that? If I give it to you, you're able to get rid of it? It's sort of creating, we call it the whippersnipper approach. It's where you, big wash then while we're waiting. It's where you get a little bit of soft tissue around the neck of your drill. Weed whacker if you're an American. What do you call it? We call it a line trimmer. What do British people call that garden device used to trim the edges? Line trimmer, yeah. You get a line trimmer effect. So you can't have the line trimmer effect going on. It beats up all the water and irrigation. So what we're going to do now is just a version of what, PJ used to talk about doing, taking a bit of bone. I love Jim Palmer. Jim Palmer had described the technique of just removing the whole anterior face of the agonasi. And he used to be really aggressive with the kerosene. Really come out as laterally as he possibly could. And just get the stylet ready because I'll block it up here. That's all right. We're not blocked yet. Now, down here, the first landmark you'll find is a bit of periosteum of the nasolacrimal sac, obviously. And it's quite amazing, the bone here is very different for different people. And even in one person, it can be very different. And the whole thing is designed to give you like a really nice, clear view of... Unblocked, thanks. We're just going to unblock it. The line trim. Yep, thank you. Thank you very much. Very good. It's to give you a nice 0 degree view. Now, it's not just about doing the frontal sinus this way. It's also about leaving behind a sinus cavity that's really easily managed. Now, I look at the scans, and I actually think you could probably get away with anything here because I'm not convinced there's fungal elements in the frontal sinus. But you know what? Just like we did the maxillary sinus, Ashok, if there was fungus in the frontal sinus, we would not have much success with a little angled tiny opening, It'd be the same as doing an antrostomy on that maxillary sinus, right? Would be really hard to remove, hard to see it. You wouldn't be sure whether you got it all. Blocked. Yeah, don't clamp the sucker anymore now for me, thanks. Just leave it down there.
Richard, you're flattening the bone on a quite wider front, correct?
Yeah. So we that's what I'm doing. I'm saucerizing it.
Yeah.
Yeah, and you can see, I don't know if you can see, just have a stylet ready. Lenny, it just got blocked again. Leave the sucker where I left it last time, thanks. Yeah. No, just leave it for me. Yeah, and just don't fiddle with it when I put it down. And we'll leave it open now. So here, can you see this? Can you see this white structure here? There it is.
Yes.
There.
Yeah.
That's your periosteum, right?
Yes.
That there is your nasolacrimal. That over there is your first olfactory neuron. So you know, just leave the sucker, please, Lenny. Yeah, it's good. That this area here, we sometimes refer to in Lothrop drilling as called Ritter's triangle. It's this triangle of bone that's in front of the frontal recess. And although I've been trying to drill with my drill with the side of it for most of the time, at this point now you do start to drill a little bit with the pole. And when you drill with the pole or the burr, you do block it a few times. You just have to have your assistant, Lenny's here, she's got a stylet ready to go. And when it blocks up, she'll give me a big wash so I can wash the field, and then she'll unblock the sucker. And then we'll just do that, and you'll see it doesn't take long here to develop. So you can see here we're in front of the frontal recess still, this triangle of bone, we've got periosteum there. We know where the first olfactory neuron is. And as you can see, I'm blocked. And that's what happens a little bit when you start drilling with the pole of your burr. And you'll see in a heartbeat here, we'll take off this. I don't always find the first olfactory neuron. That's optional, guys, if you can always put it back. Leave the sucker down there. But if you think about where we are, and I think for surgeons who are really, most of their surgical orientation is about finding the sinus cavity, it is uncomfortable to do this for the first time because you really need to find the anatomy. You know, you have to understand where the periosteum is, where the middle turb or the first olfactory neuron is, and you need to understand that you're just in front of the frontal recess.
So for your draft trees or the Lothrops, do you follow the same technique but on the both sides, correct?
Yeah, 100%. It's almost like the same principles, Ashok. And I sorry, I didn't get the introduction to your guest commentator.
Oh, so sorry. She's Louise Meliak. She's a consultant. She's a rhinology skull-based surgeon. She was in Glasgow, just moved to Bath in the UK.
Yeah, Louise, is it?
Louise, yes. Louise.
Nice to meet you. I don't think we've met Louise, so.
No, we haven't.
Yeah, so look, so you just and you can imagine where I am now. As a surgeon, I'm in front of the frontal recess. There's my frontal recess behind me. I'm actually medial to this area, and this is the frontal beak, you know. Now, when you see this finish, you'll think, oh my gosh, that's an amazing opening. But the reality is it's not really, right? It's actually still a very limited opening into the frontal sinus, and it's great for this sort of thing if you just want to wash out a sinus cavity. But because it's in a tall, vertical corridor, it's not a very good approach to do tumors and other things in the frontal sinus. So it's not as if this is a replacement for a Lothrop, you know, because you're so vertically limited between, sort of medial-laterally, your ability to reach laterally is very limited, so I'm blocked in. You can see my sinus about to open up. Yep, let's go. Almost there. And we're almost there. And then can you see the nice part about this, though, Louise, is that I love opening up the posterior ethmoid and sphenoid to find the skull base, but you actually don't need to if you're doing something like this. You can actually... Yeah, I do it in a heartbeat. And I would say to any surgeon, if you're not sure where you are, you don't know where the skull base is, just, always open up the sphenoid, find the skull base, make sure you understand where the roof of the ethmoid is. if there's any sort of ambiguity. But the actual anatomy you need to do this type of Carolyn's window or sort of unilateral drill out is actually just all here with you anteriorly. You don't need to necessarily find it,
Mm-hmm. I think that, once you've found your first olfactory neuron, I think you know your posterior limit, don't you? And then you know anterior to that you're safe.
Well, the nice part about doing any sort of drilling from what we call outside in, and this is why we promoted it in Lothrop, is that it's really safe. You're always got the frontal recess or frontal sinus between you and the skull base, right? Mm-hmm. The only place you don't have it is right in the midline.
Yeah.
So right in the midline, you can see I'm getting that blue lining now. Right in the midline, of course, you've got your first olfactory neuron and the forward projection of the olfactory groove. So in that area there, that's where you might get into the skull base, especially if you were missing anatomy, like middle turbinates and things like that. So we almost always either stay entirely lateral to the middle turbinate if we're drilling, and if we are going to sneak across the midline like I have a little bit, it's actually one of the reasons why I found the first olfactory neuron. I didn't find it just to show you guys. I wanted to know what was my depth. And you can imagine that's frontal recess mucosa there. Here's frontal recess mucosa. And I've got a little bit of a bridge here left over. Can you see that?
Mm-hmm. Yes.
So we'll get that up. And it's like, I don't do anything else in sinus work, but I can always remember I've got some fantastic ear colleagues, and they used to do canalplasty, and I used to always be impressed how in a canalplasty, because in Australia we have lots of exostosis, they would open up the canal, and at the very end of the procedure you would see the epithelium, and they'd flick it out. And I sort of feel like that's what this is like a little bit. It's a bit like a canalplasty. You drill with, it seems like solid bone for ages, and then all of a sudden you're into the frontal sinus and the whole thing's open and you're done. And the nice part about it is you saw how inflamed everything is. When you do this sort of surgery, there's our frontal sinus.
Mm-hmm.
You open it up maximally. Is that? I'm thinking that is that a little? That's like a little lip, isn't it? I have to have a look. And this is almost through here, right? It's so thin. I've left it so thin. I'm going to come back with hand instruments here. Yeah, here. See, I've got a little lip here. Look how this little lip is coming forward. That'd be, nigh impossible through a 70-degree to get rid of, right? But look how quickly you can just get rid of it now, right? We don't like the lip. We can maybe even open up to the other side a little bit, which I'm going to have to do here. Inner sinus septum slightly on my side, so I'm not going to leave it. I'm going to open everything up so I maximize the opening that I've created. I'm blocked again. Big wash, thanks. And we're almost there, and we're in a moment. I'll just do a little bit more drilling, and then we'll put our shaver on, and we'll turn our suction down when we put our shaver on. Not yet, though. So can you see that, guys? Frontal sinus, contralateral side. But you don't want to leave bone, right? Here, this is an opportunity where we can drill more and expose less, right? So we will intentionally drill to remove raw bone. So by opening it all up, can you see that?
Yes.
And I do like sometimes the baby Hoseman here just to reach around the corner. I can see Linny's got it already. She knows us too well. You haven't lost your touch, Linny. You remember it. Our senior nursing scrub has joined us today. She's on admin duty most of the time, but she remembers. Here we go. So really, it's really the contralateral side opening now, right? But It just means, can you see how by drilling more, I've exposed less bone? Can you get that concept? And that's so important, I think, when you do this surgery. I think some people do it from inside out, and they've spent 2 hours drilling. They're just so exhausted and tired at the end of the drilling of that little bit of bone that they just, you know, they're just thankful that they've found the sinus and open it is. You know, when in fact, actually, you really need to get in there quickly and then spend most of your time finessing it and getting the shape and everything else perfect. Did we get some surgery flow? Yeah, fantastic. Now, I'll take 2 silastic sheets, and I'll get Peter Lee to make a 3/4 spacer, thanks. And I'll take 1 pure region here at the end. Just do a 3/4 spacer, single spacer, 3/4. And you can see I'm just drilling the intersinus partition.
And Richard, you can see that how the mucosa differs with the right and the left.
Yeah.
The left, it is entirely normal mucosa. You can see the edematous
it's all inflamed, right. Yeah. Let's go to shaver. Thanks, Lenny. Now, so let's I'll get a wash on a stick. But let's have a look at that, right? Because I don't think there's fungal elements up there. Louise and Ashok, I think it's...
Yeah.
I think it's just
quite clear.
It's a secondarily obstructed sinus, probably. But you know what? To me, it's heavily inflamed and could become AFS. So look at that. That's a bit of mucostasis. That's AFS waiting to happen. That's how AFS starts. You get mucostasis. All you need is a bit of fungal elements up here, and then away you go. Okay, so let's go now to. We've got our shaver back on. Let's go down on the suction, guys, to 120. Let's go kerosene up, thanks. Yeah. And so here now, we'll just take off the front wall, right? Remember I said to you, I've been leaving the front wall to do here. And so this is why in an outside-in approach, you can leave the delicate frontal sinus mucosa, and you're almost working out of the field here. Can you see how we're, I've got her head really extended, so my kerosene's trying not to hit her chest too much, because you can imagine the shape of a kerosene handle. Yeah, that'll do. And suction's down, guys, is it? Thank you. Thank you. Now, this Ashok is the joy of Carolyn's window, that you then get to do. You get to do your frontal recess surgery with a quad cut. This is why I love it. Not sitting there with articulating giraffes and everything else. And when you do it with a quad cut like this, almost slightly staggered out of the lining like this, it's just easy to do. It's simple. You preserve the mucosa. You can chase all the partitions and get it perfect. Anterior mortal arteries in the skull base, so we don't have to worry about it. That was right, Peter Lee, wasn't it? Mostly. It's not exactly. It's not sitting out. There's a little ridge here.
It's a lovely opening.
Mm-hmm. You get such a clear view of all the cells, don't you? So
yeah.
You've opened everything up.
It's just like doing an ethmoid cavity, Louise. Yeah. How easy is that? And we call it running the ridge. If you said to me, what am I doing? I run the ridge. I follow the ridge of this following up and follow it from we want to see it go from ethmoid across to the skull base. You can see there's a little lip here. Why is there a lip? There has to be a little cell or something in here. Mm-hmm. It's not a big cell, just a little one, right? There you go. Okay, and I don't like this. That looks ugly. Give me a drill, thanks. And you see this mass movement, guys, down here? See that? When you see that mass movement, you know it's on the orbit. We're going to drill. See this little shelf? I hate that. That looks terrible, right? It's going to get in my way and prevent us giving a nice healed cavity. We can probably put our mucosal flap back now. And it gives you, I'm sure, Ashok and Louise, you've done cases in your lifetime where it was just such an easy case. The anatomy was such that there was a wide pneumatized agonasi, the middle meatus was giant, and you just sort of think, God, I wish all cases could be like that. When you do a Carolyn's window, that's what you're doing. You're converting your unfavorable anatomy into a standard look every time. And everyone just then becomes the same. There you go. There's that little pocket, right? We'll open that puppy up. Okay. Now give me a wash and a stick. And now we're going to close. And I'll show you. The closing's important, right? Because, it's not like taking a submandibular gland out. We're here to create an endpoint for our surgery, right? We want it to be this healthy cavity it's going to be wash-outable, irrigatable by the patient so that because right now this mucociliary function ain't working very well. And so I'll just put a patty up here. Give me the 60-degree curette, thanks. Do you have a 60, not the 90? Yep, it's a 90. You've got a 60? You got it there? If it's not there, it's usually in the standard setup, Lenny. Yep, perfect. I'm just going to put a patty up into that frontal sinus, because you know what, that frontal sinus, Louise, hasn't had any vasoconstriction. And so before we call it a winner, right, I called the maxillary sinus a winner before it wasn't, and then I looked with a 70-degree scope and there was a big plug of mucus. So one spit and twice shy, right? I'll make sure this frontal sinus looks perfect before we call it done. Now, let's pull the dressings up here, guys, because while that is just baking, you can see our fellow Peter Lee Sachs has made a spacer. There's lots of ones that are pre-made, but I still love making them out of just a Miracell tampon, and we pull that out. Let's go to the second silastic, thanks. 2 silastics, thanks. And I'm going to cut the silastics in a certain way. Do you want to hold that for us, Peter Lee? You can have a look on the screen and just have it vertical, otherwise it's a bit disorientating. Straight iris, thanks. Now, I really love, you'll never regret, in my opinion, putting silicone sheets in the nose. It looks great at the end of the surgery, but 2 or 3 days from now, it'll be really inflamed and everything else. So look, I'm really a big fan of leaving silicone sheets in to make sure everything heals well. And I often make this sort of shape. You'll see why in a second. That bit ends up at the front of the nose. You need this sort of shape, and it will cover the nose. Let's coat everything in Bactroban, guys. If you said to me post-operatively, especially in AFS patients, but all patients, it's Staph aureus is your enemy here. Staph is the number one thing that colonizes Staph aureus AFS patients. And I certainly go to a lot of trouble to make sure they don't get, if they are colonized, that they get decolonized in the post-operative period, and that I prevent colonization of the sinus cavity. And that's a lot of the antibiotic regimes we use in sinus, is not to prevent cellulitis or meningitis or prevent an infection. It's about decolonizing a cavity that's really traumatized. The epithelium is inflamed. It's denuded in areas. There's lots of blood around. It just creates an environment to create colonization. And so let's go to the shaver on. Thanks if it's not on. I'll trim that up a little bit of that middle turbinate.
There is a question from one of the delegates, Richard, what would you describe this cavity as in draft terms? Is it called a draft 2B or extended?
I'm so pleased someone asked that. It's called a draft 2C.
C.
And I know that's not a real draft term, but I'm sure Wolfgang would pay it, if he was still with us. I met Wolfgang many times and we talked about it. And we actually refer to it as a draft 2C. It's not something new. It's actually a variation of what Wolfgang even did himself, Do you think I could get that lip a little bit more? Just give me a baby Hoseman and I'll just make sure. No, I'm pretty vertical. I always want to think, can I get more? But here, guys, have a look here at the orientation. See how we can see into everything? That's the vertex of the frontal sinus, just with a 0 degree. Have you done a graph, Peter Lee? Fantastic. Okay, so big wash now. Let's put everything back together, and I'll show you how it all puts in together. And 7 minutes, Jared. So, Blakesley, still got, this is the last one, Lenny, if you want to do a patty count. I think that's the last one. Nope. Big wash again.
The field has been excellent, and you mentioned at the beginning about bradycardic anaesthetic rather than hypotensive. So what sort of numbers do you try and, if the patient can tolerate it?
Yeah.
How bradycardic?
Yeah, no, I'm so lucky. I've got the world's best sinus anaesthetist. Look at this here. So Jarrett's so good. Essentially, I just tell him the numbers and then he makes it happen. It's amazing. And we don't go for. I actually asked Jarrett not to do extreme hypotension. I don't want hypotension. I actually want bradycardia, normally with a 6 in front of it. Can I get an up Lexi, thanks?
Okay.
And or up through cut, yeah. I have an up through cut. And so a 6 is fine. It doesn't have to be 50. It doesn't have to be crazy. But then I actually say to Jared, don't make it like an excessive hypotension. Because if you've got significant hypotension, you potentially are just dilating your systemic peripheral vasculature. And that doesn't help you as a surgeon, If you have a dilated field, like if anyone's operated when someone's had an anaphylactic reaction and everything dilates, it's a disaster. You can't operate. You actually want your peripheral resistance to be tight. And so this idea of having, mild, like what a mean arterial pressure, Jared, what, 90, 100? $70 then, 70, sorry. And you keep your systolic around what? Yeah, 90 and 100 on the systolic and a map of 70. 59 to 65, there you go. Okay, give me the surgery flow, thanks. Actually, we'll do the silicon, yeah, let's do surgery flow first because I have to do it. Sorry, not primed, all good. So you see this area here? You know how we stripped it all, guys? So we generally make up a very thick surgery flow mix. You can just use Spongistan or gel foam. You don't have to use thrombin-containing one, but we've just got a fancy thrombin-containing version. And we fill it so that then we place the flap over the top. And it's all about trying to obliterate that space. And so I actually intentionally want this to become obliterated. But like I said, you don't have to do that. You could just use Spongistan. But the whole idea is you're not trying to recreate the floor at the same level. You want it almost there. And Ashok and Louise, I'm sure you've drilled out the silicon sheets, thanks. All the dressings, thanks. Mac and Dough, thanks. I'm sure you've drilled out a papilloma from the maxillary sinus, and where you've done extensive drilling, the whole sinus has contracted. Have you seen that, Louise?
Yes.
Yeah. So
Yes, definitely.
It's only really channeling that sort of experience. Do we use then, this idea of sort of drilling off the bone and mucosa? Now, I probably didn't need quite as big a sheet on the contralateral side, but I just made them the same because I'm used to doing it. But you can't really suture just to the septum. You've got to always suture to a little buttress on the other side. I'm sure everyone does that, don't they?
Yeah.
And then if you just suture to the septum, it just sort of eats through. And I love silicon sheets. You know what? My opinion, Ashok, over the years, I think many people who've been blamed for septal perforations, suture things, have it's not the surgery that's caused it, it's the patient picking and doing things at the front of their nose in the post-operative period. Now, I think as surgeons, it's not like we're not part of the equation. We probably create a slightly anesthetic or numb front of the nose from surgery, and so they don't realize the trauma they're doing. But, you know, people who get that little bilateral little crusting and things at the front of their nose on both sides in the septum, that's not some vascular thing going on. That is the patient picking. They may not realize they're doing it, but they're picking it. And over the years, I've seen that, and I have taken patients back even to theatre at 2 or 3 weeks and put silicone sheets on it, and it all heals beautifully. But if you just leave it there to crust and just tell patients to use ointment, then it eventually becomes a perforation, because they don't really, especially if you don't educate them about the fact that it's them doing it. Sometimes just finger in the nose after wiping with a tissue. Sometimes it's outright cleaning of the nose. You know, these are the sort of things that we really see that that cause problems, you know. And so that's one of the reasons my threshold for putting silicone in is so low, because it just protects my anterior septum from any problems. Now, next one we're going to do, we're almost done. So this is my next step in getting it all to heal. It's all right. Is my spacer. Now, we usually like to use then the remaining part of our local and tranexamic, because the spacer is like ridiculously hard. The rest of the local things, yep. And you can't really move it in the nose. You can't mold it. It's too stiff. Now, I don't think putting the medicine on the spacer helps, but as I sort of just douche it all, it runs into the sinus cavity. So instead of simply just sticking in saline, I use what's left over of the dressings, and you can see here in a heartbeat.
And what is that that's surrounding the Medicel pack? What have you sutured onto it?
Too long. It's too long. Sorry. It's a glove. It's a finger from a glove.
From a glove.
Oh, okay.
Yeah, 6 glove. And it just means that when you come to take it out, it doesn't stick.
It doesn't stick.
Yeah. And you know what? The nice thing about the spacer, Killian, please, is that you know the smaller one? Yeah, thanks very much. Is that when you take it out, you only need to find this little string. I'll show you this string here in a moment. And when you find the string, you then cut it and just pull it out. And it doesn't matter, Louise, if you've got heaps of crusting and blood and everything else, because when you just pull it, it all just comes. And it's an amazing, very quick debridement. And then whatever's left behind the spacer is often really moist and easy to suck out. Mm-hmm. And so it sort of makes your post-operative care really straightforward. Unlike my American colleagues, I don't get paid for post-op care. So I don't particularly want to have patients coming in for debridements all the time. Mm-hmm. I want to make that whole process as convenient for myself and for patients. So, doing that. Everyone who listens to with our American colleagues, the dynamic is different in America. People get paid for post-op debridements in care. So give me the graph, thanks.
Yeah, we really struggle in the UK and the NHS actually trying to have regular post-op appointments for debridement. It's very difficult. We just don't have the capacity. And how long do you leave the spacer in for? Sorry.
7 to 14 days. And I've got a couple of other tricks. You want to cut that in half? Curette, thanks. Here's my other little trick. So we never leave raw bone. The frontal curette, Lenny. And where we have any sort of raw bone, we'll cover it with a graft. So we've got a little bit of raw bone there. That's our graft. That's our inferior turbinate it's been thinned out and repurposed here, for the sake of this area. And I can't tell you enough. Like when we first started doing this, you'd think that it wouldn't make a huge amount of difference. Grafts like this take really pretty well. I would say the majority of the time, these sort of grafts take well. And I'll have the pure region here in a moment. So even if you got
Richard, what natural healing would you expect for a cavity like this? Is there any natural narrowing?
It should look perfect at 3 weeks. That's what I expect. Not 3 months of exposed bone and granulation tissue. That's what I saw when I was a trainee, especially after Lothrops. And that's why people get problems with stenosis. You get this chronic inflammatory reaction at the site of your healing. And I just want to have one last little look.
So you won't expect much of a natural narrowing of the opening.
Very little. And you know what? Even if you get, Ashok, a little bit of blunting at the front here, it doesn't matter. You know, you've had the Carolyn's window, you're going to end up with you've done all your frontal sinus cavity really easily, and it'll leave you still with a giant opening. So even if you've got a tiny bit of webbing at the top, it's still a huge opening compared to what you would achieve with a angled instrumentation. And look, this is
pure region.
Yeah, pure region. I like it. I think especially behind a spacer, it works really well because patients don't wash it out. And then I'm just going to wiggle it up there, and perfect. See it, and now it's sitting across my flap and stuffed up in there, holding my grafts into place. And we're almost done, guys. I'm just going to fold that back. I just want to make sure this is tucked up. I always tuck the knots if I can behind the internal valve so that patients don't actually grab them. And then if I've got a little bit of space back here, if I've got a little bit of mucosa, I'll leave it across this area, and I'll take the Surgiflow, thanks, whatever's left of it, cover that area, even if it's just going to act as a biologic dressing. You know, that's another area that you don't want to have granulate and heal poorly. Can I get the dead space, thanks? And the nice part about thrombin-containing gel foam, it actually forms like within a day, it's like a little brick. I don't know if you, like mud. Have you ever seen that? It actually, if you ever gone back in on someone who's had like a thrombin-containing gelatin matrix, it actually it really does form like a little pack, doesn't it? You got to really make an effort. It's not soft like this. It becomes very stuck together. Okay, fantastic. And then a little bit of Bactroban at the end, and we'll get our next patient who's got a fungal problem, but a mycetoma, and a much more straightforward situation. But we'll talk about very similar concepts. We'll drill open the whole face of the sphenoid, create a very big opening before we then remove the actual fungal ball. And we'll be back soon.
Thank you.
My pleasure.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble. And that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield, and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G-meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly, or certainly they used to, less so these days, they used to fly from one radio beacon to another. And that's navigation in a nutshell, really. And these days, a lot of those systems are combined. So as I hinted at, the inertial navigation system will be updated by something like GPS. And GPS is very accurate, but it's not very resilient to maneuver. So combining those two, where you've got the inertial system, which puts up with the maneuvering, and you've got the GPS, which is very accurate over time, gives you a really robust system. So hopefully not too technical there, but the aim was to provide an overview of the various navigation systems.
Well, it's interesting. I sort of started training when navigation was being introduced and more accepted as routine, but we didn't use it in every case. It was considered quite fancy and high tech. And really what we've always used is key landmarks as a way to know where you are. So before you even consider operating, you'll do some form of scan, usually a CT scan. And a CT gives you better landmarks from bony anatomy, which is more reliable in surgery, because soft tissue anatomy can change. You can have swelling and shrinkage and polyps and infections and things, but the bony anatomy doesn't tend to change over time unless there's tumours, etc. So we usually have a CT scan, and before you operate, you'll go over that scan and identify those key landmarks, but also identify unusual anatomy or some changes in the anatomy that are unique to that patient. There's some key things we want to know: where are the blood vessels that supply the eye that can hang down in the nasal cavity, so we don't injure those, because that can cause blindness if not addressed. We also want to know where the base of the skull is, so we don't breach that if we're not intending to. We want to know where the eyes are and what the shape of that patient's orbits is, if they're a bit square or rounded, so we don't penetrate into their eye or injure any of their eye muscles. We also want to know where their optic nerve is, among other things, as well as their carotid arteries. So there's a few key things we look at as a routine, and we have a mnemonic called CLOSE, C-L-O-S-E, which looks at those key anatomic features in every patient, because they're unique in every patient. And then when you've looked at that, you've obviously examined the patient looking for other things like septal deviations or turbinates or big polyps. What we then rely on is, with the endoscope, we're relying on that anatomy. And as we proceed through the surgery, we're sort of ticking off those things in your head. Okay, I've identified that artery and I've left that alone. I've now worked out where the orbit is and I've cleaned that off. I've left that alone. I've now moved through to this particular sinus where I can now find the skull base or the optic nerve, etc. So really what we used before was anatomic landmarks and scans. Now, in dire situations where you really weren't sure, I have known of people to leave a metallic object somewhere, a CT or an X-ray, to confirm that that's where they thought they were, but that's pretty unusual. So we don't have as many fail-safes as they do in aviation. We really rely on anatomic knowledge and anatomic features as landmarks if we don't have navigation.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And it is the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and samtostroid. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more. Do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. Propel Mini is placed in the frontal sinus. Its spring-like design props open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. In the Progress Mini randomized clinical study, Propel Mini demonstrated a significant reduction in the occurrence of frontal occlusion or restenosis and need for additional surgical interventions. The Propel family of products allows patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes. The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour Delivery System has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and sample-striate. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more. Do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable cart, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. Propel Mini is placed in the frontal sinus. Its spring-like design props open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. In the Progress Mini randomized clinical study, Propel Mini demonstrated a significant reduction in the occurrence of frontal occlusion or restenosis and need for additional surgical interventions. The Propel family of products allows patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes. The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour delivery system has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there. And we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and samtostroid. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more. Do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. Propel Mini is placed in the frontal sinus. Its spring-like design props open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. In the Progress Mini randomized clinical study, Propel Mini demonstrated a significant reduction in the occurrence of frontal occlusion or restenosis and need for additional surgical interventions. The Propel family of products allows patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes. The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour Delivery System has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, and especially in patients with severe polyps and samtostroid. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Hello, welcome back. So good morning from the UK and wherever we are in different time zones. So this is our final session. So we're back after being in Sydney, Australia with Professor Richard Harvey. He performed interesting cases, and now we are joining Como Hospital in Italy. So we have with us our operating surgeons. They soon will be joining. They're getting ready. So Mario Turizanoni and Prof. Paolo Battaglia. So they're from Paolo Casino Group, and we have been waiting for a very interesting case of endoscopic orbital surgery. So it's a very interesting case with orbital hemangioma, and they will be telling us about the surgery shortly when we join them. So it has been a great 3 days. We all thoroughly enjoyed operating from various centers around the world and different range of sinus surgical procedures and some skull-based procedures as well. And we have seen how the different techniques can be adopted to achieve the same results by these our international faculty. So today I've been very privileged to be joined by my new hosts. So first time today joining GRN as a host is my colleague from Edinburgh, Rohit Gohil. So welcome, Rohit, and welcome to GRN live surgical event. So Rohit has been a consultant rhinologist and a skull-based surgeon. He joined Edinburgh around 4 years ago. He has been part of the GRN on a background. He has done some organizational work before and now joining on a hosting panel. He has a specialist interest in orbital surgery, and which he's developing in Scotland. Then I will soon be joining by my another esteemed colleague, Isma Iqbal. So welcome, Isma. So Isma is first time again on GRN. She is a rhinologist and also a skull-based surgeon. Very much interested in pituitary surgeries and other range of skull-based surgery in Newcastle. So Freeman Hospital, it's a university hospital in Newcastle. So welcome, Isma.
Morning, thank you.
So soon we'll be joining Como Hospital in Italy, where they're getting ready for the surgical course. But Rohit, can I ask you, how is GRN going so far? Sorry, we can't hear you. You're probably muted. You can unmute yourself for Isma as well, please. I think it seems like some connectivity issue with Rohit's microphone.
Can you hear me now?
Yeah.
Yes, yeah, we can. Yeah.
Perfect. What I was going to say is that GRN this year has been fantastic just because it's been spread over so many days. It's been fantastic just to kind of dip in and out and just have the time available through the course of the day to actually immerse yourself in the program. So it's been really good. There's been a big variety of cases that have been exhibited, and overall it's been a great educational experience.
Yeah, thank you, Rohit. And if you have missed part of this event, it is very likely because of different time zones and work commitments. It is available on our YouTube channel or on the website. So you can go back and review these surgical videos at your own pace in your own time. And it has been so heartwarming to see our faculty committing so much to organize this, to be a part of GRN. They've taken wonderful efforts to organize interesting cases. So just take the advantage of it. And we'll soon be also releasing the edited videos of these surgical cases. So Isma, what is your experience with the GRN event so far? How did you find the surgical videos? I think you're still muted, Isma.
I think it's difficult to go and watch different people operating, isn't it? Especially when you're in normal practice. So this is a perfect way of learning from other colleagues, but also different skills from other colleagues. We're always learning whenever we're teaching at courses or seeing somebody else operate. So I think it's a perfect way of actually, gaining some expertise without having to travel that distance. But also learning from such experienced people. So I think it's a very invaluable tool. Great resource.
So tell us a little more about your practice, Isma. How is your skull-based practice?
My practice is fairly varied. I have sort of basic practice with sort of rhinology, advanced rhinology and sinus cases, and then I have a specialist practice with skull-based cases. So that varies from sort of simple things such as pituitary macroadenomas to olfactory neuroblastomas, sinonasal carcinomas. So it varies. And that's also great because I get to operate with other colleagues, so neurosurgical and ophthalmology colleagues that working collaboratively. I really enjoy that. So it varies. I think the skull-based part is the most exciting, but I also have interest in rhinoplasty and facial plastics. So I have a big rhinoplasty practice. But the skull-based part I really enjoy because of the multidisciplinary team working, having your endocrinology colleagues to learn from the medical side of things, but also working closely with your neurosurgical and ophthalmology colleagues and specialist nurses, I think really makes it quite enjoyable. And especially when you've got very complex cases, discussing those with different colleagues in MDT meetings, I think that's really helpful.
Yes, I think that's the key in your skull-based practice, working in MDTs and different colleagues with the different departments. That makes it really a great fun. How did you develop interest in skull-based surgery?
I think it was my first rhinology job I did with Sean Carey, and I really enjoyed it. I found it quite challenging. I think the anatomy is really interesting in the skull base, and for that reason, although there's this kind of a standard approach, I think the challenges with the anatomy, the variation in the anatomy, I think makes it extra special. So I'd done a little bit of skull base with him and then decided to do a fellowship. So
yeah, interesting. Welcome to GRN. And we'll be looking forward to have you on board for many, many years to come. So Rohit, I think your interest in transorbital surgery. So how did you develop that interest, and what are you doing to take it further?
Thank you for the question. I think transorbital surgery is something that's novel. It's something that is slowly gaining more and more traction in common endoscopic skull-based practice. Certainly, different specialties have adopted a transorbital route to address specific problems, whether it be ophthalmology, max facs, neurosurgery, but using the skills of endoscopic surgery and kind of enhancing it further by using that method and that technique to get a more kind of enhanced view, a more comprehensive view of what it is you're trying to achieve is the next big step. So seeing surgeons such as Darlene talk about this very avidly on open global forums was really the first kind of experience that I had in this kind of surgery, and I kind of pursued it further. I discussed cases not just with her, but attended courses. I attended courses in Europe as well. But also, as Isma said, it's all about collaborative working. I work with a group where I've got my neurosurgeon and I've got a keen oculoplastic surgeon. So we all got appointed at more or less the same time. We all had the same idea. And so we kind of progressed things kind of slowly but surely, attending courses, ensuring that, we had the appropriate grounding and then selected our first few cases, did them, reviewed them, kind of audited our work, ensured that we were doing the right thing, did more courses, and we're slowly building on that. And the main pathology that we operate on are the sphenoorbital meningiomas. However, we've done encephalocele, other lesions within the orbit as well, adopting the same approach. And then in parallel with that, the work that we do just with the oculoplastic surgeons, decompressing orbits, both endoscopically, medially, inferiorly, as well as laterally, kind of hones on those skills as well.
Yeah, that's great. And you have long years ahead to build this career up, and we wish you all the best, really. And thanks for taking this up as new emerging subspecialty within the anterior skull base surgery. And it's really taking great shape. So that leads us nicely towards our first case today. So I think the Como Hospital group is ready to join us. Professor Paolo Castronovo, he has been always involved in GRN. He has always performed live surgical demonstrations and has been really a true mentor for us. His guidance over the years has really shaped what GRN is today. So we can't really thank him enough. So today, well, unfortunately, due to some personal reasons, he's not with us for in a live operating session, but he has organized everything behind the scene. And now Professor Paolo Battaglia and Professor Mario Tuizanoni, so both of them who have been tutor under his guidance, they will be joining us today with the transorbital case. So over to Mario and Paolo. Good morning, both. So we'll be joining at Como Hospital. So the hospital comes under the auspices of University of Insambria. It's close to Milan. So can we go over and join Como? We'll be connecting them. Can we connect to Como Hospital? Hello, Mario and Paolo. You are both muted. Can you please unmute for? Hello, Mario. We can't hear you. Can you please unmute? I think you seem to be muted on the system. Can you hear us, Paolo, Mario? So we tried to make audio connection with Como Hospital. They're ready. We can see they're set up for the patient. The patient is ready, so they're ready to talk about the case. I think while they're setting up, can we visit our supporters, Medtronic and Carl Stolz, for a very short product video? And we'll get this connection sorted out and we'll be back with you in a minute. Thank you.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more. Do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. Propel Mini is placed in the frontal sinus. Its spring-like design props open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. In the Progress Mini randomized clinical study, Propel Mini demonstrated a significant reduction in the occurrence of frontal occlusion or restenosis and need for additional surgical interventions. The Propel family of products allows patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
Mario?
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour Delivery System has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
Hello. I think, can you hear us now, Mario? Oh, great. So we're back. Sorry for a little hiccup to get started. So apologies, there was a technical issue in the audio connectivity, but we are connected now. Over to Como Hospital. So both Paolo and Mario are waiting for us. So good morning. Can you hear us all right?
No, we don't.
I think you still appear muted, Mario, on a live webinar.
Can you hear us, Ashok?
Yeah. Hi. Hello. Morning. We can hear you now, I think. Oh,
Yeah.
great.
Yeah.
So we're good to go now. Yeah.
Perfect.
So can you hear us all right?
Yeah. So
Yeah.
we are
So
really
just
excited.
introduce your team, and can't wait to get started. So thank you guys for organizing this for us. So I have with me Rohit and Isma. So Rohit is from Edinburgh, Scotland. He is developing interest in orbital surgery, developing the service in Scotland. And Isma is from Newcastle. So she's following Sean Carey. You know Sean, our
Great.
current TRS president. Yeah.
And so, welcome to Como. We are Mario, Professor Turi Zanoni, and I'm Paolo Battaglia, and we are very happy to participate in this great event. We did it last time, and it was a very great experience. And so now we will try to show you a singular case, an intraorbital intraconal lesion that
we would like to thank you for the invitation. We are excited to be here with you this morning. Greetings and welcome from our institution, Sant'Anna Hospital in Como, in Lake Como, and from our organization Rhino-Edu team. And this is the case of this morning. This is a young lady affected by right proptosis. This lady described a orbital swelling that increased day by day, month by month in the last 3 years. And in parallel, also some mild diplopia was worsening in the last few months. And this is the appearance of the eyeball of a patient, of a proptosis, of a unilateral proptosis of a patient on the right side. And this is the ophthalmological evaluation. So there is no visual impairment, but the patient complained a mild diplopia, which is worsening in the last few months. And so the patient underwent CT scan and MR scan. And this is the lesion that come into view. A 2 centimeter large mass in the retrobulbal area. So behind the orbital bulb, there is this large lesion, which is more or less same dimension of the orbital bulb. And also we have studied this lesion also with the magnetic resonance. And the appearance in magnetic resonance is a lesion capsulated, well capsulated, luckily, and seems to be a vascular malformation. Such a kind of lesion in the past was called cavernous hemangioma. But we know that since 2018, the new classification of such a kind of benign vascular malformation have changed the nomenclature. And now we can classify such lesion as vascular malformation, benign vascular malformation. And we can stratify such a kind of lesion according to the vascular pattern. And so in type 1, type 2, and type 3, according to the flow of the vascular signal in the lesion. And in such a kind of lesion, luckily, we have no connection with the cavernous sinus vascular venous plexus. And how to identify these? Our suggestion is to ask the patient to perform the maneuver Valsalva. You can see like this. The patient is going to do the Valsalva maneuver. And if you don't appreciate a vascular pulsatile lesion, it means that there is no connection between the vascular malformation and the cavernous sinus plexus. And so we can classify this lesion as type 1 orbital vascular malformation without connection to the cavernous sinus. Of course, it's time to perform surgery. We have to remove this lesion because the lesion is increasing in volume, because the lesion gives symptoms to the patient, and such a kind of symptoms are worsening, because standard management of this lesion are follow-up. We decide to propose and to offer the patient surgery because the lesion is increasing in volume in the last few months, and because the symptoms of the patient, proptosis and diplopia, are worsening in the last few months. The surgical option when to approach a lesion in the orbital compartment are multiple: endonasal, transorbital, and we have to decide which kind of surgery is better to do. And so now Professor Battaglia will show you CT scan and MR scan, and so together with Professor Battaglia we have select the kind of approach to be performed in this particular patient.
So Mario, can I ask you, what other orbital lesions you commonly find that you deal with endoscopically?
Other orbital lesions that might be encountered in this compartment are, for example, schwannoma, or in other cases, we can also encounter, for example, pseudotumor, inflammatory pseudotumor, or IgG4 inflammatory related lesion. But in this case, magnetic resonance is quite important to help us also in predicting the diagnosis. This is round lesion, round-shaped lesion. There is well-capsulated lesion. And also there are some vascular fluvoid inside of the lesion. All these aspects suggest us the possible diagnosis of vascular malformation.
Thank you.
Now we have to understand how to surgically remove this lesion. But of course, in doing this, we have to understand exactly where is the lesion in respect to the neurovascular structure of the orbit.
So here we have the lesion, you see. After the end of the ocular bar, the lesion starts here. It's located in the inferomedial part of the orbit. You see here, you identify the key point structures. Here, the optic nerve, you can see that it's pushed superolaterally by this kind of lesion. And you see one important thing is to see the relationship between the extrinsic orbital muscles. This is you can see the arrow, yeah, on the monitor. Yeah, I suppose yes. Yeah. So here is the inferior rectus muscle here, and here the medial one, and the superior oblique muscle with the superior rectus muscle. Here in the center, the optic nerve. You see, it's not located in the central portion, but it's pushed superolaterally. So the lesion is increasing in volume, and we are scared because of the possibility to push against the nerve and to have some visual problem in the next months or years. That's why we decide to operate the patient. We can say that the lesion occupies the intraconal here and extraconal area. So this is the extraconal area outside the circle of the extrinsic muscle, and here it goes inside in the intraconal area. So here the surgical approaching you can somebody could propose are, of course, the transcaruncular approach through the orbit, the medial one. You know, Professor Lube is one of the main surgeons that sustain this kind of approach. But we decided here to approach this lesion through a transnasal endoscopic approach. Why? Because the lesion here is hopefully easy to find, is just lateral to the periorbit, and it's located in the inferomedial area. And the lesion itself enlarges the window between the inferior rectus muscle and the medial rectal muscle. So it will be very important during the surgery to perform a good antrostomy here, type 1, to enlarge posteriorly, perform an ectomoidectomy, a frontal sinusotomy and to have as posterior landmark the sphenoid. In such a way, we will expose all the peperesia and then the periorbit, and then we'll try to incise the periorbit, not to open all the periorbit, in order to remove the lesion without having an important orbital herniation, so reducing the possibility of an ophthalmo postoperatively. One other thing important that I want to say, then we will move on. The ophthalmic, can I have? Yeah. One could say, what about the vascular structures inside the orbit? Here, we know that the ophthalmic artery comes through the intracranial area towards the orbit, and it will be, over the optic nerve. So it will go laterally to the optic nerve and then will turn up. So the lesion will push the nerve inferiorly, will not encounter the ophthalmic artery because it's superiorly located. If we see the here, you can see very well. You see, this is the ophthalmic artery that goes inside the orbit, turns up to the optic nerve, and then the ethmoidal artery. So the lesion push the optic nerve, and there will be lesion, optic nerve, and artery. So we will not encounter it during our surgery.
Yeah. So it's quite important to evaluate in deep the preoperative radiological exam in order to select out the best surgical approach, like this. And so when facing such a kind of lesion through an endoscopic endonasal approach, basically we can say that we can have two surgical windows, okay? We have one surgical window inferior to the medial rectus muscles and one other one over the medial rectus muscles. You can see my slides, yeah? So in this particular case, the lesion open itself the inferior window, I mean the window between inferior rectus muscle and rectus muscles. And so we will perform the surgical resection through this approach. Another surgical trick, we would like to use in such a kind of lesion, this kind of instruments. Do you know these instruments in your surgical experience?
No, can you tell us more about it? That looks very interesting.
Yeah, Ashok, you know this instrument is a cryoline probe. With the cryoline probe, we are able to grasp the lesion and to shrink the lesion in order to make it very hard. And this is quite helpful in order to remove the lesion without dissecting inside to the intraconal compartment with the bipolar. And so inferior window between inferior rectus muscle and medial rectus muscles and cryoline.
If I can say something more, the cryo probe will attach completely. They will become one only structure, the probe with the lesion. So you can pull. Previously, we have difficulties in pulling the lesion outside because it's vascular, so it bleeded, and then it's weak, it's squeezy. You could not grasp very well. So this changed completely the surgery of this kind of lesion through an endoscopic point of view.
Yeah. So we can say that we are confident to be able to remove this lesion via an endoscopic endonasal approach. However, to be sure, our patient has been informed fully about the possibility to switch the surgical procedure intraoperatively via an external approach. So the patient have been informed and have fully signed an informed consent about the possibility to perform an external transorbital approach in case we are not able to remove completely the lesion via an endoscopic endonasal approach. You know that we have also published some paper about this topic. In selected cases, we can combine an endoscopic endonasal approach with a superior eyelid transorbital surgery, endoscopic assisted transorbital surgery, in order to manage the lesion. So we are confident to be able to manage via an endoscopic endonasal approach, but we are ready to switch to an external procedure just in case we need.
So do you have your oculoplastic colleague on standby or in theater with you? Do you operate jointly with them?
With the ophthalmologist, are you asking?
Yeah. Usually we are able to manage alone without the need of ophthalmologists, but our ophthalmologists are ready to come just in case we need. But in the large majority of cases, we can manage alone.
Okay. So this case, I mean, you can see there is a nice widening of the corridor between the inferior and medial rectus. So if you have to retract the muscles, I mean, what is your sort of technique for that? Of course, we'll be seeing that in the case, but what are the different tricks and techniques that you use?
So there are two ways.
That you need to take.
One described by Stamberger. We don't use it, you know. He put it in stitches on the medial rectus muscles. Then he suggested to pull up the muscle to open the window, putting the stitch at the level of the septum. I never use this. We have a prototype, so a sort of instrument,
a forceps,
that
like for parotid surgery, the varication, that can be put inside the orbit, and the muscle can be enlarged. And we frequently use this kind of instrument. But I think in this case, the nature did it for us. It enlarges the window.
Okay. So I think will probably be interesting to see that during surgery. But I think, Paolo, you just mentioned that you deal with all the rest of the sinuses before opening the lamina. So you mentioned about the frontal sinus as well. So how extensive we need to go to these sinuses, and why are we opening the frontal sinus? What's your rationale behind it?
We need to open because if we leave some cells in the frontal recess, then when the fat will come out, it will cause completely the recess. So we will try, of course, in this case, to open the periorbit in the lower part. But if we extend a little bit in the upper part and we don't clean the recess, it will be closed by the fat. So we perform a draft 2A, so a pre-chambers surgery at the level of the frontal sinus.
Because of course, in the post-op, at the end of a procedure, we expect to have some orbital herniation inside to the nasal compartment, to the ethmoidal compartment. And so we would like to create enough space in the ethmoidal compartment in order to give space for the small orbital herniation inside to the ethmoid. If we leave ethmoid, is a problem because of frontal sinus, because we can have closure of a frontal recess. That's why we prefer to enlarge spaces. Okay. And another topic, another open issue can be related to the option reconstruct or not to reconstruct the medial orbital wall. And we will see at the end, but usually no need to reconstruct the medial orbital wall. Usually we can put a small free graft of mucosa to cover the orbital fat in order not to leave the orbital fat exposed to the air, but no need for rigid reconstruction of the medial orbital wall.
Sometimes we
use any nasoseptal flap anytime?
Sorry?
Any nasoseptal flap? Do you use that?
Any flap? We don't use flap. No, we don't use the
nasoseptal flap.
We used sometimes because we are pupils of Professor Castelnuovo, and he used to put sometimes silastic sheet inside the middle meatus just to push a little bit for the first 15 days the orbital flat laterally. So can be an option.
Yeah, we cover the fat with a free graft of mucosa, and we put silastic sheet round shaped in order to support the free graft and to keep the orbit in place. Because you know, in the 15-20 days, scar tissue formation help us a lot. And scar tissue formation will reconstruct itself the middle orbital wall. Of course, we informed the patient that it's quite mandatory to avoid to blow the nose after surgery for 1 month, because 1 month is the median period time for the scar tissue formation, and scar tissue is able to separate completely ethmoidal compartment, nasal compartment from orbital compartment.
Do you give any other postoperative?
Sorry, yeah.
Too many questions.
Sorry. Sorry. Do you give any other postoperative instructions other than not blowing the nose? Any rinsing, anything like that?
Yeah. So first, post-op prescription, avoid blowing the nose, mandatory. Other additional prescription is nasal rinses, of course, nasal rinses in order to clean the cavity, to clean the nasal crusting, and also some ointments in order to do some moisture and to clean the nose. Rinses and ointments, they are enough.
I think a post-operative, antibiotic will be suggested in order
to prevent
infection of the orbital fat because it will be exposed to the air. So for 10 days, we will give amoxicillin or clavulanic acid just to prevent, infection of the fat. Yeah.
Okay, thank you.
And it is such a relatively new specialty, so everybody's really excited. We have lots of questions. So I think if you're ready to start, we can have this discussion during surgery. Yeah.
Great.
It's the first time on GRN we're doing the transorbital case. So yeah, it's great. So thank you guys for organizing it.
Thank you. It's a
pleasure.
Okay.
Hope everything will be good.
So we scrub,
I'm sure.
Scrub, and we are ready to go. Okay.
Okay. Perfect. Yeah.
See you.
Yeah. See you. So great, Isma. How great is that? No, it's very exciting, isn't it?
It is exciting. I think it's what they're really honed in on is looking at preoperative imaging in 3 dimensions. I think that's really important.
Posso mettere la mascherina normalmente?
To go through the imaging beforehand, to really sort of in your mind get a 3D idea of where the lesion is, what the relationship to different structures are, what problems you may encounter. All of those things I think really help beforehand, that pre-planning, which I think, the more surgery you do, the more you understand that. If you understand the imaging and the anatomy, your life will be a lot easier.
Yeah, I mean, such an intricacy in the orbital anatomy. So they've really done a very thorough assessment. So you really need to have a look at that vascular pattern and that MRI scan that they showed, how important it is that when the vessel, when the ophthalmic artery leads into the anterior point, how important it is. And that thorough assessment is key for the planning.
I think what we didn't ask them is whether they use image guidance or not in any of these cases. That may be a question to ask because and different people have different practices, so that would be interesting to see if they use image guidance.
Yeah, definitely. And that cryoprobe, that really looks interesting, isn't it? Otherwise, these lesions can be very difficult to tease out and dissect through the fat. Yeah, I really love the idea. Had you heard about it, Isma?
No, I haven't heard about that, but to me it sounded as if they're saying it solidifies the lesion almost.
Yeah.
So it'll be interesting to see exactly what it does. I think it may be something that Professor Casanova has developed looking at it. But yes, I will certainly be finding out whether we have it available in the UK.
Yeah, it looks that it attaches to the lesion, and then when you're dissecting around, it just pulls the lesion out. So it's almost like a little suction cup, so it sounds like. So what is in your center? What's the status of the transorbital surgery? Have you started yet, or any plans to develop it further? Do you have forming any partnerships with oculoplastic colleagues?
So we do some sort of combined work, but I wouldn't say it's strictly transorbital. We do a lot of combined work. I think you've got to select the first few cases very carefully. I think it's a learning curve. So there are certain cases where we've had that idea, but it's, I think, selecting, making sure, because it's a learning curve. When you start off, I think you've got to collect the first few cases, have to be something that's going to be easy to tackle to gain that expertise.
I mean, we were a bit cautious when we started. So I think first cases with this transorbital hemangioma, of course, we didn't have this cryo probe. We were ready with our oculoplastic colleague in case we needed to go externally and help us retract the medial rectus muscle. And we were cautious in reconstructing. So we did use a nasoseptal flap. But I think looking at their experience, just the free mucosal graft seems to suffice. So that would be interesting to see.
Do you use the free mucosal graft with your skull-based surgery, or do you use a nasoseptal flap?
Well, it's really depend on the situation, but I think we err on the side of caution, and it's always good to have this robust vascularized medical flaps, so especially when we're talking about the skull-based CSF repairs and all that.
Yeah.
I try to err on the side of caution.
Okay. I asked that question because in my fellowship training in Australia, we use nasoseptal flaps for almost everything. But actually, since I've come back, I use free mucosal grafts for a lot of things, and it works really nicely. But yeah, it's I think selecting carefully.
Yeah, I mean, some of the small leaks and all that, if they're not high flow leaks, and if you just need to augment that defect, smaller defects, then probably nasoseptal flap will be a bit of an overkill. You can just get good results with free mucosal graft. Of course, multilayer closure, as you know, is important.
Absolutely.
Giving the fat as well, a bit of a support with the fat, and then the free mucosal graft. So, Rohit, do you have anything to add to the discussion? What is your experience? Have you done anything similar?
Yeah, so firstly, kind of in response to the reconstruction, I think having a nuanced approach is important. The more kind of simple reconstructions, I tend to use a free mucosal graft, and I tend to reserve the use of a nasoseptal flap or a pedicled flap, in fact, for revision cases of high flow CSF leaks, or indeed very large defects. But having a stepwise approach to reconstruction is important, I feel.
Yeah. Okay, so I think we are ready. Mario, can you hear us?
Okay, can you hear me, Ashok?
Yeah, we can. You're on the screen. We can see you set up your team. So, hello to all of your team, to your scrub team, to your anesthetist.
Okay, can you hear me?
Team. We can hear you.
Perfect. So we are ready to start. This is the setting of our operating room. You can see this is the navigation system. You can see with the environmental camera, yeah?
Yes.
Okay, this is our setting. The patient is in the anti-Trendelenburg position, and the patient is under general anesthesia, of course, and this is an hypotensive general anesthesia. Thank you to our anesthesiologist. Our anesthesiologist today is Dr. Daniele Corti from the team of Andrea Lombardo, which is the chief of anesthesiology in the Lake Como Hospital, Sant'Anna in Como, Italy. Our scrub nurse is a very skilled scrub nurse, is Francesco Rossi, which will work with us since many, many years. And also for the setting of the operating room, Alberto Gandolfi, which is our chief resident, helped us a lot in organizing and set up everything. This is navigation system. You can see the suction is navigated. Okay. Now we ask to switch off just a little the light of the room. Please turn off the light in order to see better the screen. Okay. And Alberto, The registration is on. We are registering. Stiamo registrando. Okay. So, yeah, we are checking all the data of the patient.
Yes.
Okay.
Asportazione endoscopica di neoformazione endorbitaria.
Dammi ancora un
Visualizzate.
cotonino.
Okay.
Sai cosa fargli
Sorry,
sette?
but we cannot start without the check. Also,
we have
during
checked,
this event.
yeah, we have checked the procedure, checked the identity of the patient and the imaging. I'm thinking about the possibility to correct the nasal septum because the spaces are not so good. And we need a lot of space to work here. Dammi un altro cotonino. And so probably we have to start the procedure with septoplasty. Che dici? We will perform a selective and conservative septoplasty in order to correct the deviation of the septum exactly at the level of the ethmoidal area. Okay, so it's an endoscopic endonasal septoplasty, but this is mandatory in order to increase the space to work. The first rule that Professor Castelnuovo teach us was to create enough space to work. If you have a small and narrow corridor, your surgical procedure will be worst. You have to create the condition to work in the best way possible. So, hypotensive anesthesia and enough space to work. Francesco, ready? Ready to infiltration? Franci?
Do you have any specific decongestant on your patties?
Yeah.
This is cottonoid, soaked with nasal decongestion, vasoconstrictor and adrenaline. And now I'm going to perform infiltration. Because, you know, in this case, it's not possible to work. No, metti grosso. Bisturi ce l'hai, Franci? So I would like to correct all this part of the septum. This is the injection with epinephrine. Okay, small injection also on the other side.
We never inject the lateral wall, only the septum in this case. We use only contact anesthesia for the ethmoid area. So just in this case, we inject.
Do you ever use intraoperative tranexamic acid to help with the hemostasis?
I'm sorry,
Can you repeat?
Intravenous tranexamic acid, do you feel that has a role in any of these cases?
No, we don't use tranexamic acid. No. We don't use intravenous tranexamic acid. Just cottonoid with or silometazoline or and with silometazoline and adrenaline.
Okay. So, Francesco, give me the scalpel. Ce l'hai? I'll do an incision like this. Okay, give me cotton. you see that we are working with 4 hands. Okay, like this. And now I would like to pass on the other side because it's quite important to preserve the other side. So I try to cut the cartilage like this. And pass on the other side of the cartilage because I would like to preserve completely the left side of the mucosa, of course. Aspirator. Un pochino.
Acqua.
So now I am on the left side because my task is to preserve completely the mucosa on the left side, which is the healthy side. Like this. I'm dissecting the healthy side of the mucosa. I'm grasping again the bony spine here in the lower part. And I would like to extend my dissection for the endoscopic endonasal septoplasty along the floor of the nasal cavity on the left side. So I mean in the opposite side. Small hole.
Yeah.
But no problem. On the opposite side, you can see like this. A small hole was created here, but no problem because I would like to preserve on the other side. Give me cotton. With this side of the cotton, I dissect here. Give me sticker da mascellare, Franci. I'm going to dissect all the mucosa on this side, like this. Dammi fra. And with the ball probe, also, I can try to complete the dissection on this side. Okay? Now we can say that the left side is completely dissected until the floor of the nasal cavity. You can see. Perfect. and is quite good. And so we can try to manage the septal deviation on the other side.
Acqua.
Okay, I have to create a window, and so I need the Damila-Fomon. I enlarge just a little over the anterior chondrotomy. Then I'm going to perform the superior chondrotomy. Like this. And inferior chondrotomy. Give me Blexley.
Dietro.
Okay. I detach just a little more. Okay. I enlarge with the section over, okay? Because we have to gain space in the upper part, you know? Dammi ancora la Fomon.
Mario, this really underlines the importance of creating adequate access. If you perform surgery with compromised access, your outcomes get affected. So you're really taking your own time to sort of create that access. It's great to see this technique as well, the endoscopic septoplasty.
I agree. Because if you're not able to create space to work, you cannot do a very good surgery. Dammi la Vine. Okay, so we have dissect here now because we have also to remove this spine. On the other side, we are safe. On the other side, completely dissected. But we have to dissect here. Tieni un po' chiuso. Ok, dammi lo scalpello. Hammer and chisel. Ok. Ok. Just a second more.
Tap, tap.
Ok. Black Levi. Okay, I think that can be okay. Then we check endonasally the final result in order to see if we are enough space to work. Okay.
That's good.
Now you can see that the middle meatus became accessible. Here there is a incision of the mucosa along the spur, but no problem because on the other side you have healthy tissue. I don't know if we need to correct just a little here in order to have much more space to work. Just a little.
No, this is a great demonstration about how a good septoplasty can make all the difference.
Yeah. This part, dammi cotton. I would like to remove this small part in order to have better access on the upper part. Dammi la file. Okay. Let's check. Okay. So we can expose all the middle meatus from the axilla of the middle turbinate. You can see. Now we can have a very good corridor from the axilla of the middle turbinate down to the inferior turbinate is well accessible. If you do not do like this, it's quite impossible to work. Okay. Now it's time to perform ethmoidectomy and papyracia exposure. This is the Usinet process. This is the bulla. Morso retrogrado, backbiter.
It's quite a lateralized turbinate, middle turbinate.
Yeah. Then we have to decide what to do with the middle turbinate, but probably we have to resect the lower part of the middle turbinate. Also because to have enough space to work.
Togliamolo.
Tutto?
Sì, metà.
Aspirator?
Yeah. I think it's better here to get quite good space and to resect at least the half inferior portion of the turbinate here.
Also because we need space to work. So more or less until at the height of the sphenoid.
Yeah.
Dammi biscotto. The cutting instruments. More or less here.
Yeah.
Also there is a pneumatization inside.
It's all three things really: lateralize with concha and also conversely turn.
Yeah. Also because we need space to work.
Yeah, exactly. I think the amputation is partial amputation is the right thing to do.
if you have, if the turbinate is not paradoxic, probably you can try to spare. But here also we will have removed the medial part. We will have the paradoxical part of the medial part of the turbinate. So
this is the tail of a middle turbinate, and we expect bleeding from here. And so we are ready with the bipolar forceps to manage. Okay, not much bleeding. Dummy vial, Blacksley. We preserve this turbinate because we will use this mucosa. Franci, metto in acqua che dobbiamo conservare. We will use this mucosa at the end of surgery to cover the orbital fat. The mucosa of the middle turbinate is quite useful as a free graft at the end of surgery. Okay? Give me bipolar forceps.
You can get a lot of surface area out of your middle turbinate, can't you?
We cauterize the tail. Okay. So we can see in a very wide way here the uncinate process projection and the bulla. So dammi la retrograda piccolina. Dove sono i pedali della...
So for our viewers who have joined late today, so this is third day of Grace Live 2025 live surgical event.
Retrograda piccola.
So we are with Paolo Battaglia and Mario Turizanoni in Como Hospital in Italy. They are doing wonderful demonstration of orbital vascular malformation in the right orbit. So they're doing it endoscopically. So at the beginning, we looked at the scan and they have demonstrated the whole anatomy, including the critical vascular anatomy in details with the MRI scan. Then they are working with the axis. There was a septal deviation, so they have corrected that endoscopically and also trim the inferior turbinate in its lower half to create that axis.
So with the backbiter, I have done the inferior uncinectomy. And now with the Stamberger forceps, I'm going to enlarge the uncinectomy like this. Okay. Give me a Jacurette. Jacuretta. I remove the uncinate process also in the upper part in order to completely remove the uncinate process up to the axilla, 4 picco tagliente. Then with the cutting instrument, a curved cutting instrument, I'm going to resect the uncinate process. Until the axilla, Vailina. It's quite important to resect the uncinate process as far as the axilla of a middle turbinate. In this way, we can uncover the area of the agar nasal, which is quite mandatory in order to approach the frontal sinus. Dammi Vailina, sblocca Debro. Okay. Perfect. Now we can put the 45-degree scope in order to check the maxillary sinus, because of course I'm not sure to have fully opened the natural ostium of a maxillary sinus. I have to check with a 45-degree scope if the uncinate process have been removed as far as its anterior insertion or not. Dammi la lunga. Dammi lungo retrogrado. Okay, so I'm going to check this part. You can see this is a remnant of the uncinate process, and we have approached the lesion here. So, natural ostium of a maxillary sinus is open. You see, is not in a vertical position. It is oblique in a 45-degree position. This confirms us that this is the natural ostium. I have removed the fontanella area of the medial wall of a maxillary sinus. This is the so-called type 1 medial maxillectomy. Removal of the upper part of the medial wall of a maxillary sinus as far as the posterior wall of a maxillary sinus. Good. Now we turn up our 45-degree scope like this, because it's time to check the frontal sinusotomy. Okay, but you can see when opening and removing the uncinate process as far as the axilla of the middle turbinate, everything becomes more and more easy. Ok? Mettimi molto curvo. Our suggestion is always this one. Remove the uncinate process as much high as you can. Uncover the axilla of the middle turbinate. This increase your possibility to expose frontal sinus. Dammi curetta frontale.
I mean, great you say that, Maria, because we have seen various techniques all during these 3 days. There is, despite using different techniques, different approaches, there is a basic consistency in all of your faculty surgeons that defining the landmarks, like Dr. Satish Jain, Dr. Janki Ram, Richard Harvey. So everyone really defined that lamina and all other landmarks before going straight into the pathology. So, I mean, Dr. Janki Ram has nicely emphasized that as well, that rather than jumping into the pathology, as Mario and Paolo are showing us here, is working on all the other aspects of surgery, like getting your access sorted out, addressing the other parts of the sinuses, like doing the uncinectomy thoroughly, right from its inferior to superior edge, doing your middle metal antrostomy properly, defining the frontal, and then going for the pathology. And that's the consistent theme emerging over this last 3 days. So thank you for reiterating that technique, both.
Marina poco curva. Ashok, I fully agree with you. This is the main concept. Check landmark, check anatomy, create enough space to work. And the lesion should be approached only when all these issues have been managed. Otherwise, you can have big issue. For example, when dealing bleeding, how to deal with bleeding if we have not enough space to work? How to deal with complication if we have not identified fully all the landmark? So I completely agree with you. And this is probably anterior ethmoidal artery. You can see?
Yeah, very nicely seen. Yeah.
Anterior ethmoidal artery, which run on the roof of ethmoid.
I mean, what are the most of the sinus surgeons are concerned about or worried about, so to say, is the anterior ethmoid artery, your internal carotid optic nerve. But all of these techniques that you've seen over the last 3 days, they are consistently saying that define these structures. So once you know where they are, once you've seen that clearly, then you can work around them. So similarly, anterior ethmoid artery, Jim Palmer, Dr. Satish Jain, then Dr. Jankiram, all of them really found that artery first. And then once you know where it is, you can work around it.
Uno fa tagliente frontale. So anterior ethmoidal artery, and we try to keep the artery covered with the mucosa. And so once the anterior ethmoidal artery has been identified, I'm safe in cutting these. You can see, because first I don't know exactly where is the artery. First, I check the position of anterior ethmoidal artery, and after that, I cut like this. And so we can say that this is the first ethmoidal fovea between the frontal recess and the anterior ethmoidal artery position. In this case, we are managing an orbital lesion, so it's important to have under view anterior ethmoidal artery, because in case we need, we are ready to cauterize and cut the artery if we have some complication. I think that now it's okay. Give me the circular punch for frontal. Ma che faccio di più per frontale? No, frontale. Sì. 40. Okay. But it's quite enough. The roof is exposed, ethmoidal artery, foveola, and frontal.
It's a great exposure. Very nice.
Potrebbe essere spaccialettina, bisogna capire.
Vabbè, proviamo. Mettimi il navigatore. Navigation. Sì. We can check the frontal sinus. Sì. We can check with a navigation system.
Yeah.
Okay, we are inside. You can see with the navigation system. Yeah. We can zoom with the camera on the navigation system. We can see that we are inside. And in this particular patient is low pneumatized frontal sinus. So it's not so well pneumatized. So enough. We are completely inside. You can see. I'm checking not to leave some small cell, but we are inside. And navigation system confirm that we are inside the frontal sinus. It's a small frontal sinus. So with a navigation system, we can check also these. And also we can check the position of anterior ethmoidal artery. We can see on the CT scan, we are sure that this is anterior ethmoidal artery. Perfect. And that we are inside to the frontal sinus. Okay.
So anterior ethmoidal artery, as you know, it's one cell behind the frontal recess. So it's quite reasonably consistent. And both of the frontal recess and anterior ethmoid serve as a landmark for each other. So if you find one, then you can find another.
I would like to emphasize another things. In these particular cases, we have to keep in mind that there is no disease in the frontal sinus, no pathology in the frontal sinus. I have opened the frontal sinus only because I am afraid that at the end of surgery, the collapse of the orbital content inside the ethmoid may reduce the ventilation of the sinus. But no disease in the frontal sinus. That's why we have kept all the mucosa intact on the frontal sinus. Much more the mucosa is intact in the frontal sinus, much more is probable that we will have a good healing of the cavity. Of course, when there is a disease, chronic rhinosinusitis, polyps in the frontal sinus, we have to remove the affected mucosa, the inflammatory mucosa. But in particular cases, no disease of the mucosa, no disease in the frontal sinus. That's why we keep all the mucosa. Much more mucosa we keep, much better is the healing. Okay? Dammi biscotto.
So you're
Now
going to
we are
sorry.
Yes, please.
Yeah, you're going to expose all of the lamina now, is that correct?
Yeah, but before exposing the lamina, I would like to see the sphenoid. Because sphenoid, optic nerve, carotid artery is another important landmark to have fully under view. In this way, we have all the cone of the orbit exposed.
Mm-hmm.
And just in case something happened, we have the cone of the orbit exposed, we have the optic nerve exposed, we have anterior ethmoidal artery exposed. If we have complication, immediately we can manage the anterior ethmoidal artery. Immediately we can manage optic nerve. You understand? So first, clean everything and expose landmark in order to be ready for all situation, complication included.
And his map, Professor Richard Harvey this morning, when he operated, he did a pituitary. But those are the first things he did. He exposed his orbit lamina all along, especially in the posterior ethmoid, and then they defined the internal carotid artery. So any eventuality, everything is in the view, and you can deal with it. So very similar principles.
Because this is a very large lesion in the orbit, so we have to be ready to manage everything. This is the superior turbinate, the tail of the superior turbinate. I will expect my sphenoid sinus natural ostium in this area. Cutting instruments, biscotto. Tail of the middle turbinate that can be completely removed. And now it's time to look for the natural ostium of the sphenoid. Give me bipolar, just a second more. I would like to manage this area of the tail of the middle turbinate. Okay. Okay. Now we have to look for the sphenoid. Is that correct? More or less at the level of the superior turbinate tail at the height of the maxillary sinus. This is the area where we expect to encounter the sphenoid. Funghetto dritto. Ok, dammi ancora. Sì, e poi preparami la citelli. So, the cone shape of the orbit should be exposed from anterior to posterior. Citelli. With the carries on rangers. We can extend the opening funghetto dritto intanto. Ok. Optocarotid recess. Dammi funghetto dritto ancora. Optic nerve and carotid artery. Dammi la citelli allora. So, to harvest the corridor, as you can see, we have done septoplasty. We have done complete ethmoidectomy with the frontal sinus, maxillary sinus, and sphenoid sinus opening. We have completely under view frontal sinus, which is small and low pneumatized in this case, and anterior ethmoidal artery. We have completely under view sphenoid, optocarotid recess, also sellar floor here and clivus, but no need, of course. Okay, so sphenoid and optocarotid recess are well visible. Remnant of a middle turbinate that we can probably drill out just. Dammi un biscottino un attimo. We can trim just a little this remnant of a middle turbinate because no need. And also is a little pneumatized.
And you're doing all of this on a 45-degree scope, so you don't really use a 0. And
now we have 0-degree scope.
Yeah, yeah, 0.
I have put 45-degree scope only to check maxillary sinus, natural ostum, and frontal sinus. Then I have switched to the 0-degree for sphenoid and ethmoid. Now I'm working with a 0-degree. Dammi la 2 grossa tagliente. Ok. Okay, we can say that landmarks are fully exposed. Okay?
That's a great demonstration.
Landmarks are fully exposed, and now it's time to drill out the papyresia in order to expose the periorbit, sorry. Of course, in this maneuver, we have to keep in mind that it's quite important to preserve the integrity of the periorbit layer. So we have to drill out this bone without encroaching, opening the periorbit, because periorbit should be open at the end. Dammi vai Lina, retta. We can remove the mucosa. Dimmi quando vuoi.
Quando vuoi te.
We can remove all this mucosa, of course, which is the mucosa over the papyresia. This is hyperostotic bone, which usually is at the level of a lacrimal system, you know?
Yeah.
Usually at this level, there is the lacrimal system. Bipolar. I would like to bipolar just a little the lamella in order to control bleeding. Vai, Paolo.
Diretto, grabbing.
Okay, just a second to... Okay, and now it's time to approach the orbital lesion. Okay? We have to drill out the bony papyresia, exposure of the periorbit, and then approaching the lesion. You can see here, posteriorly, the bony papyresia lamina is very thin. And so if I press against the orbit, you see it's moving because it's very thin. Conversely, in the anterior part is thicker. We can check this bony anatomy with a navigation system, please. With the camera, try to see this. If I move here, you can see my scope. I'm pressing against the papyresia, which is very thin and it's moving. But probably you can see here, the lesion is almost finished. If I press here, very hard bone, because this is the lacrimal system. You can see here lacrimal system. The lesion is in the middle. The lesion is in the middle, more or less in this area. You can see with the scope, you can see in axial view of the CT scan, the lesion is here. But of course, we cannot create a hole here. We cannot create a small corridor here. Once again, we have to remove all the papyresia, expose all the periorbit, and then create a window. Okay?
Okay.
So it's time that Professor Battaglia drill out all the papyresia.
Posso avere una sedia? Can I have a seat, please? So, monitor un attimino così.
Albi, muovi il monitor.
So, good. With exposure here. So the most difficult thing sometimes here is to work well in the lateral part of the surgical field. So in order to better work in this area, I like to drill a little bit here, the central branch of the maxilla. Also, if I expose the lacrimal duct, there will be no problem, but I can move better on this area. So now I will drill a little bit more just to open the windows, this area. So, okay.
Devo scolare la mucosa.
Yes.
Sulla branca.
Sure. It's okay. Can I have the okay
pedal?
Okay, it's here. Sorry, but now I have it. Okay. So I need to drill a little bit here.
Which drill are you using?
The ascending branch. I know that here there will be the projection of the nasolacrimal duct over here.
I'm sorry, can we ask what size drill head are you using there?
This is 4 mm.
Yeah.
Yeah. We use 4 mm, 5 mm. When we work at the level here on the lateral wall of the sphenoid, 3 mm. But here I don't need a tip very close. You see, I'm drilling. Let's see what happens. I can enlarge the window towards the orbit. Okay. Now I want to drill a little bit more. It's a trick, but if you don't do it, you have to work with a 30-degree or with curved instrument at this level. Remember to drill this part before starting opening the papyresia.
Our goal is to address the papyresia with 0-degree scope. And so we have to create a corridor to be able to manage all the orbital compartment with a 0-degree scope. We would like to face in front the lesion, not with angle scope, curved instrument. It's much more demanding. With 0-degree and straight instruments, we can face the lesion.
So, a little bit more here in the upper part. Dopo una fresa più grande, anche la 60. You see, we take a lot of times to take care about all these details before going towards the lesion. This is the concept, as you told it before, to gain the best access you can before going to the target.
That requires a lot of patience, though, doesn't it? As a trainee surgeon, sometimes the trainee surgeons just want to get to the lesion, don't they? So I think you learn that with experience, that exposure is key.
Exactly. Here, 2 millimeters that you gain, improve in such a dramatic way your view towards the orbit.
Absolutely, that's
Just
you can
2
really see that.
millimeter, you see?
E tieni piccola questa per lavare.
Yeah, probably there will be a small haller here, something like this. Okay, okay. I push a little bit the sac. Let's see if it moves. No, it's see. I'm pushing the sac. Can you see the movement there? That's the medial wall of the sac.
Yeah.
So I know here is the sac, and wash please a little bit. So in such a way, I know where starts the orbit